didn't say it. That's okay.
Good morning, everyone. Also, a very warm welcome from my side to this important forum on equal access to healthcare in the MENA region. My name is René Scheck, and my background is in educational sciences. And what is true for education is true for health. The right to access to education and to health is both recognized as a human right. We as MENA Center are pleased to once again focus on human rights after the first forum in December 2020 on women's rights. As a university, we want to bridge academia, civil society, and activism. Might this forum help to reach this goal?
Good morning, everybody. Warm welcome to you also. We're glad to have you, the speakers, moderators, and the participants. My name is Jubin Goodarzi. I'm an associate professor and the deputy director of the deputy head of the International Relations Department and a co-director for the MENA Center here, along with Dr. Mary Velma O'Neill. This is an important event, as you know, in terms of looking at broader issues of healthcare, in terms of also what's going on in the Middle East and on many levels, whether it's political, social, cultural, strategic. As all of you know, it's been 30 years since the end of the Cold War and 10 years since the Arab Spring. And the Middle East and North Africa and its people still face many challenges. 30 years after the end of the Cold War, in certain respects, the Middle East lags behind in terms of democratization, political liberalization, greater openness politically and socially, unlike many of the other regions of the world, which over the past 30 years in Eastern Europe, parts of Africa, Latin America, and Asia, which opened up and moved on. So in addition to a lack of political reform, greater political liberalization, democratization, we also have various problems facing minorities and women, something which we covered in our conference one-day forum back in December. And you also have major economic issues in terms of how oil and gas, the resource, of course, have basically distorted political and socioeconomic development in the region. And in addition to that, you have another layer of course, conflicts, interstate conflicts between states in the region, and also foreign intervention, which we've seen over the past 20 years, since the beginning of the century, in terms of, if you want to even put Afghanistan into the broader MENA region, but in regards to also Iraq, after the Arab Spring, also Libya, to varying degrees, direct and indirect intervention in Syria, and of course, in Yemen. And of course, all these things have accentuated the challenges in terms of people having access to healthcare and also delivery of healthcare services, both by domestic, national, and also international actors. And of course, as you all know, we're in the midst of a pandemic. So this has added another layer of another challenge, major challenge to the people and the humanitarian community, the medical community, the healthcare community, and governments in the region. So the challenges are multifaceted, and we hope that in this one-day forum, we've assembled a very broad range of distinguished speakers from different organizations, including Action contre la Faim, Action Against Hunger, the International Organization of Migration, the International Committee of the Red Cross, the UN High Commission of Refugees, and many other, in terms of the University of Central Florida, Oxford University, that these distinguished experts and scholars will be able to shed light and, of course, engage in a dialogue and enlighten us, and also enlighten the audience. So we're very proud of holding this event. This is our second major conference after the Women's Forum. We also had another event earlier in the spring, which was more modest in scale, on academic freedom in the Middle East, which went well. And we hope to have more events on the Middle East at Webster University, Geneva, and also the MENA Center for Peace and Development, and also the International Relations Department, which I'm also part of. So I will basically, again, a warm welcome to you all, and I will hand back to my colleagues, Mary Velma O'Neill, and also Renee Shegg.
Thanks, Julian. Thank you. We still have a few minutes before the keynote speaker will begin. Would you recommend we begin now, or would you rather say a few more words? Renee, do you have something else to contribute?
I think we can start.
If I could, just since we have 2 minutes, I'd like, and I wasn't recorded. Could I repeat what I said before, because I think this is important, and I won't make any flub ups this time, hopefully. So I will read quickly this time.
Take your time.
In 3 minutes. The great English novelist E.M. Forster is best known for 2 very instructive words: only connect. The Webster University MENA Center for Peace and Development was founded to live out that imperative. We aim to connect past, present, and future. Today's forum on equal access to healthcare in the MENA region is dedicated to the enduring Arab contributions to the history of healthcare. The famous Beit al-Hikmah, the House of Wisdom, founded in the 8th century Baghdad by Caliph Harun al-Rashid of the Abbasid dynasty, was a living center for medical study that continues to have enormous resonance. During the European Middle Ages, Arabs made important advances in surgery. They anesthetized patients with cannabis and opium. They used mercury and alcohol as antiseptics. They had strict rules about hygiene. They developed new technologies in medicine, dissection, surgery, and pharmacology. They founded the first hospitals and introduced physician training. They composed encyclopedias of medical knowledge. That connected past surely animates the engaged presence of healthcare workers in the MENA region during the ongoing COVID-19 pandemic. We are very grateful for their enormous service to humanity. We are also confident that social changes generated from the grassroots in the MENA region and interconnections like this forum on equal access to healthcare in the MENA region will provide new directions for peace, justice, and development in the future. Thanks again. And now I would like to introduce with great pleasure and honor our keynote speaker, Dr. Khalid Kosair, who is founding executive director of the Global Community Engagement and Resilience Fund, the Global Community Engagement and Resilience Fund, dedicated to preventing violent terrorism. Dr. Kosair is an academic by training. He is professor of conflict, peace, and security at the University of Maastricht in Holland, as well as non-resident fellow at the Lowy Institute. As a global advocate for migrants and refugees, Dr. Kosair chaired the World Economic Forum Global Future Council on Migration for 6 years. He edits the Journal of Refugee Studies. He was appointed MBE for services to asylum seekers and refugees. He chairs the Board of Trustees for the Sustainable Development Charity, Raleigh International. MBE, I'm sure all of you know what that means, unless anybody, it's a very distinguished attainment. So thank you so much, Dr. Kosair, for being with us on this occasion. And we look forward to you talking about your Engagement and Resilience Fund.
Thank you, Mary Velma. Can you hear me and see me okay? Yes, you can hear me?
Yes.
Great, good. Listen, Mary Velma, let me thank you firstly for embarrassing me with that long CV, but secondly for inviting me to join you at this very important meeting today. Could I start, as I think we should start all meetings these days, by simply wishing all of you and your families good health and future success as we start to look towards a brighter future. And I mean that from my heart. I'm really very grateful indeed for the invitation to join you today, although it does strike me that I would probably be more appropriate as a silent observer listening and learning from you than as a keynote speaker. I want to stress from the outset that I'm not a healthcare expert like many of your colleagues are, neither am I an expert on the MENA region. So I'm an imposter rather than a keynote speaker, but I'd like to share a few ideas and thoughts with you, and again, look forward to learning from you during what I think looks like a very exciting day. As you've heard, what I am is the Executive Director of the Global Community Engagement and Resilience Fund. It sometimes feels like resistance, but Resilience Fund, GCERF. We are a global fund based here in Geneva, focused on preventing violent extremism. I'm also, as you've heard, Professor of Conflict, Peace and Security at the University of Maastricht in the Netherlands, with, as you've also heard, a particular focus on migration and refugees. And most of all, I'm a friend of Webster University and delighted to be associated with this initiative and look forward to supporting you in any way I can going forward. If I may, I wanted to comment at the outset on the framing of the event today, which I think is so critical and so well chosen. We have before us a forum on equal access to healthcare in the MENA region. Firstly, I think the word forum is exactly the right word. And I hope that as you go through your discussions today, it will be in the spirit of a forum, an open, critical discussion. Something that, as you know, is often sorely lacking in the part of the world that you're focusing on today. Secondly, I want to applaud, even though I'm not an expert, the focus on access to healthcare. Clearly, access to vaccines for COVID-19 is on everyone's mind, and indeed remains a challenge in the MENA region. And I want to say a few words about that in a moment. But as you know better than me, in this region, like in many other developing economies, the current vaccine challenge is symptomatic of much deeper problems, whether weak governance, gender inequities, or discrimination. Perhaps, maybe, possibly, perhaps COVID-19 presents an opportunity to address some of these structural deficits and ensure a better chance of equal access to all healthcare going forward. And thirdly, I'm delighted that you are focusing on the MENA region. Clearly, you're a MENA center. In my opinion, it's a region that doesn't get enough global attention, apart from bad news about conflict in Israel, or irregular migration from North Africa, or the ongoing tragic conflict in Syria. But it does seem to me, in my experience of the region, that it's also a region that has enormous potential. A youthful and relatively well-educated population, enormous natural resources, steady economic progress, and increasingly social and political awareness, much as it is difficult for that to be realized at the moment. Clearly, the health experts amongst you today will speak about, quite rightly, the importance of access to healthcare to assist those most vulnerable to ill health. There is clearly a health imperative to ensure access to healthcare. From my non-expert perspective, access to healthcare is also about realizing a wider potential for the region and for its people. So from my perspective, a non-health expert, let me share with you 3 reasons why I think access to healthcare matters beyond health alone. First, and as you will well know, the MENA region, in particular Jordan and Lebanon, has very high numbers of refugees. And let me just as an aside be very clear, there was never a European refugee crisis. This was and remains a crisis of and in developing economies like Jordan and Lebanon. I'd like to emphasize here the importance of getting COVID-19 vaccines to these refugee populations, which perhaps is easy when they're in camps, but much more difficult when they are self-settled. I see this as symbolic of our global commitment to refugees. And certainly almost every country in the MENA region is a signatory of the 1951 Convention. I've often gone on record criticizing the refugee regime, and I know you have colleagues from UNHCR joining us later. I've often criticized the refugee regime for being too reactive, too focused on humanitarian assistance, and not enough focus on development and finding solutions. But if we can't get vaccines to refugees, then we're even failing on the very lowest expectation of survival. I think this is a really important imperative, and I know that countries like Jordan are making a great effort to try to inoculate refugees within their populations. A second area that I work on is migration more widely than refugees, and again, I'm delighted you're joined by colleagues from IOM today. It seems to me that the MENA region is critically dependent on migration, possibly more than any other region in the world today, whether it's European tourists or probably more importantly, guest workers in Europe and the Gulf, or students. Over the last year, clearly, this migration has ground to a halt, with most migrants from the MENA region returning home. A really important result has been the loss of income from remittances. That is, as you know, money sent home by migrants. Mobility is needed to kickstart these economies and get them back on their impressive pre-COVID growth trajectories. And this clearly won't happen without equal access to vaccines. So I see an economic imperative in getting this right. Third, as noted, my current work at GSERF, the Global Community Engagement and Resilience Fund, focuses on preventing violent extremism. We have very clear evidence from the MENA region and elsewhere that violent extremist groups, online and offline, are manipulating uneven access to the vaccine to radicalize and recruit. At a global and regional level, uneven access is portrayed as yet another conspiracy against poor people, against Islam, and so on. At the local level, violent extremist groups are driving a wedge between those who do and those who don't have access to vaccines, ramping up suspicion, ramping up resentment. We have found that the most effective way to combat this trend is by building trust between communities and authorities. So let me wrap up and let the experts talk. And of course, happy to answer any questions as far as I can about the work that we're doing or any of my comments. Allow me firstly to thank you again for the opportunity. It's a true honor, even though I still feel myself to be an imposter within this esteemed group. Secondly, again, let me congratulate you on focusing on the right topic in the right region and in the right way. And finally, let me make this point. Equal access to healthcare is clearly held back by deep structural barriers. But I think we have before us clear evidence of why lifting those barriers is so important. It's important to fulfill our international obligations. It's important to promote economic growth. And it's important to build more resilient communities and more legitimate institutions. I'm very grateful. Thank you very much for the chance and good luck today. Thank you.
Thank you very much, Dr. Koser, for a very enlightening presentation. We would like, since we have time until our first panel begins in about 15 minutes, I would like to see, in terms of if any of the participants have any questions or comments, so we can perhaps maybe engage in a brief discussion with Dr. Koser, because I think he basically, with very broad brushstrokes, painted an interesting picture of the issues and challenges in the region, in the MENA region, and what needs to be addressed. And any questions or comments? And if so, if you could just introduce yourself. And so this is a forum, so we welcome discussion, questions. So esteemed participants, any questions? Make sure your microphone is on. Sometimes tricky. Does anybody have any questions for Dr. Koser? We have several people online, so.
I have a question. Thanks so much again, Habib. I took notes during your wonderful presentation, and there were a number of very important statements made about the number of refugees, the need to get the COVID, and the link between violent extremism and the propaganda about, or whatever you want to call it, about the manipulation of this conspiracy theories that have abounded throughout the world during this crisis, which has contributed to the mental unsettlement or whatever. But I'm curious about two things. One is that I'm curious about what your organization is doing on the ground, on the grassroots level, to build trust. And a larger issue, I heard last year, I think, a discussion about a need for a kind of a new, I don't want to Americanize this new idea, but a sort of a Marshall Plan, in which the global South and the North would no longer be disconnected, but we would kind of finally realize that we are one common humanity. So I wonder if there's a larger vision and grassroots issues in terms of trust, and a larger vision before you and your colleagues. Thank you.
Thank you so much, Mary Velman. Again, thanks for the invitation. I mean, I don't want to spend too much time explaining to people what our organization does, but more than welcome, of course, to look at our website. But I did make that point about the criticality of trust between local communities and especially local authorities. And I think, even from the work done by your expert colleagues on vaccine hesitancy, it's clear that trust is incredibly important. We support local NGOs around the world, including, for example, in your part of the world, Tunisia at the moment. And one of the things we do with local NGOs is we try to build stronger bonds and trusts between local communities that are specifically at risk of radicalization. So places where we know that people are being radicalized, where we know people have left, for example, to go and fight in Syria and Iraq, and try to build stronger bonds of trust between those communities, including religious leaders and school teachers and others, and local authorities. And this sometimes can be as simple as simply bringing people together in dialogues, in forums such as you're doing today. Because what we found is that one reason people become radicalized or become tempted to join Boko Haram or Al-Shabaab or whichever group it might be, wherever you are in the world, is because they no longer trust their authorities to help them. If you can't trust your authorities to make sure that there's rule of law, that there's order, that there's the possibility of a job, that you are not disadvantaged because you're a woman or gay or Muslim or whatever the issue, or a refugee, whatever the issue might be, then you may look to somebody else to find that legitimacy. So one of the strands we certainly work on is trying to build trust between local communities and authorities. And I think it's been fairly successful in the realm of preventing violent extremism. And as I say, I think it also clearly applies to the question of vaccine hesitancy as well. On the more global level, I mean, I think everyone around this table would agree that we need to enter a new reality. We need to decolonize aid effectively. We need to try to build genuine partnerships between the North and the South. In this organization, my organization, we've moved away from the idea that we have donors and recipients. We speak about partnerships, and we even speak about equal funding partnerships with colleagues from the South giving money to our fund, as well as colleagues from the North, and so on. I mean, what is slightly, and again, I'm not an expert, what slightly depressed me about the COVID vaccine response. I've always said that one of the challenges of the work that I do is that preventing violent extremism is not seen as a global public good. It's seen as a national interest. I want to prevent violent extremism to keep my citizens or my investments or my trade routes safe. And if it's taking place in another part of the world that doesn't affect me directly, I don't really mind about it. And I think that's a shame. And part of my work is to advocate to make violent extremism, preventing violent extremism, a greater global good. But I always assumed that health and education were now seen as a global public good, that we had now realized that we are a global community, deeply interconnected, and that if people aren't getting a vaccine in Jordan, then it will directly impact on health, security, safety, economic development in the US, Europe, and elsewhere. And again, not as an expert, but when one reads about the hoarding of vaccines in wealthy countries, when one reads that the COVAX initiative is desperately under-resourced in terms of vaccines, I think that slightly depresses me that even an issue like a global pandemic is not yet seen as a genuine global public good. So I think we have some way to go. And yes, a Marshall Plan is what's needed, but I think to launch it, I think that the reality of what the reaction we've seen to COVID is that unfortunately, I think we still have a long way to go. But I don't want to set this meeting off with a pessimistic tone, but that's my feeling, I think, at the moment. I'd say one more thing, Mary Velma, if I could, while your colleagues are drinking their coffee and warming themselves up. I mean, I think your opening statements, which you kindly repeated, were immensely important. We're talking about a part of the world that really has led the world historically on healthcare and on global health and on medicine, on innovation. So I think that really helps to set the scene that this is a genuine partnership, not simply a sort of donor relationship.
I don't know if my other colleagues or anybody listening out there.
Yes, I have a question, if I may. My name is Paul Critchley. I'm the country director of Action contre la Faim in Iraq. You mentioned that the Middle East is wealthy with natural resources. Yes, currently 60% of Iraq's GDP is linked to hydrocarbon extractions, 99% of its exports and 90% of its government revenue. So if we want to ensure access to healthcare and as a global public good, when Western countries are planning to work to become carbon neutral, our attempts to limit the effect of climate change are going to lead to economic collapse in countries like Iraq, which will feed into conflict and feed into reduction of access to healthcare on any number of reasons. So what do you suggest the global community should do to mitigate the effects of this?
Do you want to take another couple of questions, Mary Velma, and I'll see if I can think of a clever answer to Paul's brilliant question. I think Osman has his hand up, I can see. I think.
I've heard that Osman wants to put a question.
Hi, Khalid. Very interesting statements from you, and interesting point you make in your most recent comments about the Middle East being a source of innovation. Traditionally, I'd say, in medicine and healthcare. But I suppose to elaborate on that point, one of the big issues with the vaccine deployment and distribution around the world we've seen is that obviously it's quite closely linked to profit for pharmaceutical companies, and the issue of intellectual property rights and protections around those. Some countries have called for suspension of intellectual property rights around emergency vaccines, particularly when you have a global pandemic. And there are arrangements at the country level. The TRIPS agreement that was signed in Doha, trade-related intellectual property system, which allows countries to have compulsory licensing so that they can manufacture and distribute vaccine or other medical countermeasures in these kinds of settings. Why is it that across the Middle East we don't really see that companies have the institutional capacity, the manufacturing capacity to produce high quality vaccines or medical countermeasures? They don't seem to have that development or manufacturing capacity themselves. They're very wealthy countries in the region. Why have they not invested in that sort of capacity and capability? They like building very tall buildings, but they don't seem to be able to want to manufacture high quality vaccines for themselves.
Thanks, Osman. I mean, Mary Velma, I know you're waiting for David and others to come off the next panel. So let me, offer some responses. But again, these are deep questions asked by experts, and I don't pretend to be an expert, but just some observations that hopefully will stimulate further discussion as you go through the day. Firstly, to Osman, yes, I've been following this. I think President Biden made a very strong statement that he wanted to lift these restrictions on intellectual property. The European Union, to my disappointment, although please note I didn't vote for Brexit, but still to my disappointment, I think has raised concerns about it. My analysis of this, and again as a non-expert, is there's something about a short-term versus a long-term response. I think it seems to me, and you got to this, I think, when you spoke about the lack of sort of manufacturing capacity within the MENA region, that I think lifting intellectual property rights in the long term is probably a way to go. But in the short term, surely it's about reducing the stockpiles of vaccines in places like the UK and other parts of the world and getting them out to people who really need them in the MENA region, sub-Saharan Africa, refugee camps and so on. So I didn't see President Biden's excellent statement as a short-term solution. I saw it as a kind of a longer-term visionary moment. And I guess the other response to your point is, you know, and I swing between this. Sometimes I wake up thinking, as I said in my brief presentation, that COVID is an opportunity that the world will seize. We have come together, we've suffered together, of course, some of us more than others. This is a chance to reset, you know, and to work together towards a better world in partnership. Other times I wake up and think it's the same old, and we're just going to have the rich countries getting rich and the poor countries largely being ignored because they don't have the political status. But I suppose the answer to your question about manufacturing is that, you know, we have not approached this in a I mean, I don't think what you want is a return to kind of a war footing economy where countries feel they have to produce everything that they consume, whether it's a vaccine or food or anything else. You know, we know what's going on with the Serum Institute in India. Unfortunately, the main production and the main kind of production line for vaccines has fallen apart because of the chaos, terrible in India at the moment. I'm not sure that I would want to retreat to a situation where we are kind of stepping back from globalization and trying to kind of nationalize all of these instruments for production. I mean, that's my feeling, but you may think differently. I mean, to Paul, I mean, I think his question, and this is why this is such a good topic. You know, this isn't just access to healthcare means getting vaccines to sick people. There are such deep structural barriers that stop equal access to healthcare. And if we get access to healthcare right, it will lift barriers to so many other things around the SDGs and so on. And I think Paul kind of reinforced that point. I mean, I guess the answer, Paul, you're in Iraq, you know this better than me, but is surely in the long term about diversifying economies. I mean, I would say the same about remittances, which I spoke about. It is a mistake for the government of Jordan to have a 30% dependency on migration remittances, because guess what? When you have a pandemic, migrants come home and they don't send home remittances. And I assume in the long term, for Iraq to be so dependent on oil, especially given what's taking place in terms of moving towards carbon neutrality and pressures elsewhere, is a mistake. And I guess, Paul, diversifying the economy would be the long-term answer, and to see whether, as you said, countries that are pressurizing for addressing climate change that will inevitably impact Iraq and other countries that depend on oil and gas and other resources, to work with them and support diversification. Easy to say, I guess difficult to do.
Thank you. We have another question from Vera Melli. If you would like to unmute yourself.
Yes, I was just going to mention a point about manufacturing capacity and impact of sanctions, specifically with regards to Iran's capacity, but I think I will keep that for during my talk. But basically my point was that I think that one of the major impediments to sort of having more secure access to medications specifically in the region is the result of sanctions and international pressures on Iran, for example, because within the MENA region, of course, Iran has I would say, largest capacity both for pharmaceutical production and in terms of self-sufficiency in terms of population needs. So like 95% of doses of needed medications are produced internally, and it's only by dosage. And it's only 5% by dosage that are imported. But unfortunately, because of sanctions, Iran hasn't been able to export and have this cooperation with other countries in the region. But I think I will touch on this a little bit more during my talk as well.
I mean, from my side, thanks, Vera, and look forward to hearing your talk. But I think, you know, what you've pointed up is the great contradictions of the global system. You know, sanctions may be effective for certain things, but they have such dramatic unintended consequences that drive absolutely against priorities of the global community. Look forward to hearing your talk. I mean, just to if I can link this to the work that we're doing here on preventing violent extremism, I mean, this was largely our conclusion that you know, you spend whatever it is, $3.6 trillion a year on security responses to violence and to terrorism. And it just seems to me intuitive that violence is not the right answer to violence. And for a far, far smaller amount of money can be invested in people and in local communities and begin to build their resilience and begin to help them push back against what I think they all know is not the right way to go and make a genuine difference. And I think, you know, rather than getting trapped in this global system, we here just set up a new organization and try to move away from it a bit.
Or comments? We still have another 5 minutes till the session with Dr. Osama Dar begins. Questions, comments from the audience? Nothing on the chat or? Vera, did you want to?
No, I'm not going to add anything at this point. I do find this dichotomy between human security and measures taken for nation state security quite conflicting at times, but again, I will touch on this on my talk.
Okay, thank you. I think Dr. Koser, Khalid Koser, Paul Critchley, and also Osama Dar and Vera Ameli touched on very important issues. Just several things which came to my mind while during the discussion was this whole issue of inequality. I teach development and I tell my students inequality is no longer just a north-south issue. You see inequality also to a large degree also in the developed quote-unquote north, whether it's in the United States or also in Europe. You have this growing gap between the state and what the state can do or wants to do for the people, and the people, the nation. So you have this bifurcation, both in the south, in the MENA region, and certain countries even in the north. We see, for example, the United States, Brazil, and others, this growing gap in terms of access to political rights, socioeconomic rights, and of course, healthcare. And as Dr. Koser mentioned, and this is something I also mentioned to my students, when you look at a lot of these radical Islamist movements, or even in Nigeria, Boko Haram and all that, a lot of the grievances, the roots for their grievances, it's not necessarily about religion, it's about, or differences between Christian and Muslim. The deep-rooted causes are basically access to jobs, access to resources, access to healthcare. And of course, as you all know, one of the reasons that Islamist groups in the MENA region and the Muslim Brethren in many countries historically did well was they would basically fill in the gap where the state would not be able to provide certain services in terms of social services, welfare, healthcare services. Even like when you look at Gaza, the Palestinian territories and all that, in terms of what Hamas did, in terms of its origins, how it grew, how it was able to develop grassroots support. So I think these are all important issues, and we look forward to the discussions, the presentations, and the discussions that will take place. Vera mentioned Iran, of course. I'm of course also from Iran, and as I said in my introductory remarks, the challenges that MENA countries are facing are multifaceted. In the case of Iran, of course, you have mismanagement and corruption, authoritarian regime, and then on an added layer is, of course, sanctions. This time, of course, it was the Trump sanctions. Before it was Obama and George W. Bush sanctions. And this, of course, has led to major problems. And I've spoken with people that you also now have incidents of vaccine hoarding and selling vaccines on the gray or the black market. But I'm just throwing this out. So these are issues we can discuss in the next panel, which and the subsequent panel, which I'll chair. The next panel will be chaired by Dr. Osama Dar. So does anybody have any final questions or comments before we move on to our first session with Dr. Osama Dar? Any final questions? Okay. Dr. Koser, thank you very much for your keynote address, your remarks. I hope you'll be able to stay with us as much as possible throughout the day and contribute. I recall we met each other a long time ago when I was working for UNHCR over an 11-year period. You were working with Jeff Chris. So you had an office down the road I believe on Rue de Montbillon here. So, but anyway, that was a long time ago. So always a pleasure to see you, and always a pleasure to read your work, which very fascinating, very insightful.
Great. Well, listen, thank you again, and Jeff's still in good health, so I'll make sure that he knows you mentioned him. Thanks again.
Thank you. Thank you.
Thank you.
Thank you.
Right. It's 9:45, and well, at least we're in Switzerland. Some of you in Switzerland and elsewhere in the Middle East. But we're not on Middle Eastern time, for better or for worse. So we're going to move to our first session, part 1, on healthcare in conflict areas, war and occupation sanctions. So I have the pleasure and privilege of introducing the moderator, Dr. Osama Dar. Dr. Osama Dar is a fellow of the Royal College of Physicians in Edinburgh, Scotland, beautiful city, and a fellow of the Faculty of Public Health in the UK. At Chatham House, the Royal Institute of International Affairs, he is director of the One Health Project, an umbrella term referring to the Institute's work on emerging infections and communicable disease control and equitable access to services, environmental public health and health inequalities, and sustainable livestock development, and its links to food security and nutritional outcomes. Dr. Dar, in his role at the UK Health Security Agency, is a medical consultant in global public health, where he works to support low and middle income countries build core capacities under the international health regulations and in the design and implementation of their broader health system strengthening initiatives. It is a pleasure and privilege to have you, Dr. Dar. So I will hand over to you and our very distinguished group of speakers. The floor is yours.
Thank you for those kind words. So we have, I suppose, the best way to describe it is quite an explosive session around healthcare in conflict areas, war, occupation, and sanctions. So how we go about ensuring or trying to foster equity in the delivery and access to healthcare in these kinds of settings, and of course the MENA region sadly is fraught with conflict and lots of wars over the years, and currently lots of occupations and sanctions across the region. So we have 4 excellent speakers. Chairs, are you guys doing the intros for the speakers? That was my understanding. We have Yara speaking first from the University of Florida.
I could certainly introduce Yara. I spoke to her about a month ago. Yara is a postdoctoral scholar, Department of Health Management and Informatics at the University of Central Florida. And she's 6 hours difference of time in the States. I think she's prepared a presentation that we will pull up now, and she hopes to join us at the end of the day when she wakes up. So thanks so much, Osman, and thanks, Yara.
So the format we're going to have is that we're going to have 4 presentations, and then we'll have a Q&A from the presenters.
Right. Thanks.
Hello, everyone. I am Dr. Yara Asi, a postdoctoral scholar at the University of Central Florida and a non-resident fellow at the Arab Center, Washington, D.C. It's a pleasure to be speaking to you on the issue of healthcare and armed conflict. While I wish I could be there live with you today, I do hope to join later for a Q&A session. I believe that war is one of the largest threats to public health today. And I don't just mean in countries where there is war. Relatively speaking, there are few countries where one of the top 10 causes of death is battle-related trauma. For example, being hit by an airstrike, stepping on a landmine, being shot or tortured, or any of those causes of mortality that we typically associate with war. However, the over-militarization of countries around the world, ostensibly to protect their populations from such threats of violence, leads to lack of investment in social services and initiatives that lead to human security, and an overt focus on what is termed something like national security or even counterterrorism. In the time of COVID-19, we quickly learned that most countries, even those that boast the most advanced militaries in the world, could not truly secure their populations from a sudden and potent threat, in this case a contagious respiratory virus. Conflict-affected countries, of course, fared even worse. I know you're going to hear about the pandemic and conflict in later sessions, so I don't want to dwell on that. But I wanted to bring this up at the beginning of my talk to just plant the seed in your mind that the relationship between health and conflict is far more multidimensional and complex than is often described in the common discourse. Now, it wouldn't be a talk about health and armed conflict without addressing these battle trauma-related casualties as a result of direct physical violence. But I'll also touch on the health effects of structural violence. In other words, the violence built into systems and structures that leads to reduced health access and quality, discrimination in health delivery, hunger, overt bureaucratic obstacles, movement restrictions, infectious disease spread, and many other social and political determinants of health. If you were watching the horrific scenes out of the Gaza Strip just a few weeks ago, then you're well acquainted with the concept of direct violence and its effect on mortality. Depending on the antagonist, this can range from an individual suicide bomber with a rudimentary homemade bomb, or in the case of a belligerent actor with an air force, direct bombardment with airstrikes, drones, or even chemical attacks. There are several ways this leads to negative health outcomes. First, of course, civilians experience significant injuries, often resulting in death or severe disability. The major wars of the 21st century alone, including Syria, Iraq, Afghanistan, and Yemen, are estimated to have killed nearly 1 million people from direct violence, more than half of whom were civilians, humanitarian workers, journalists, and other non-combatants. Millions more are left severely injured, permanently disabled, and mentally traumatized. Then there is the infrastructure that this type of violence destroys. Aside from destruction of hospitals and clinics and the killing or displacement of medical professionals, direct violence also destroys the roads that people would take to hospitals, the electricity and water connections that these facilities depend on for services, and the supply chains that bring these facilities needed pharmaceuticals and other resources. Health workers may be threatened or targeted in kidnappings and attacks to terrorize local civilian populations. Thus, it becomes harder for people in need of medical care, whether battle-related or not, to access the facilities they need for care. If they are able to make it to a facility, there may not be medical staff to attend to them or the equipment or medicines they need for care. There may simply be no power or water. Destruction of homes and residential spaces also forces displacement and crowding, which increases risk of infectious disease. Lastly, the physical insecurity posed by direct violence prevents functioning of the health system due to the potential physical insecurity posed to medical workers. Medical school and nursing students may be unable to attend their classes or rotations, preventing their training. There may be too high of a risk to enact vaccination campaigns or other health promotion efforts, or those that are enacted may be poorly attended, accelerating poor health outcomes that take time to recover, like vaccination and obesity rates. Direct violence also limits data collection and surveillance efforts, which are vital for public health efforts at all levels. In these ways, direct violence also indirectly contributes to battle-related mortality by denying people with otherwise treatable conditions access to care. It is estimated that despite the overwhelming death toll of Syria's civil war, for example, more people have died from not being able to access healthcare services than from direct violence. So despite the fact that we could spend this entire talk engaged on the topic of direct physical violence, let's move on to other types of violence. War is much more complex than bombs and drones, of course. And peace, of course, is much more than merely the absence of war. The concept of structural violence emerged in the peace and conflict literature in the late 1960s, in part to fill this gap in our understanding of violence. There were guns, sure, but what about discrimination, patriarchy, and segregation? What about slavery or exploitation? What about military occupation, colonialism, siege, and blockade? There might certainly be physical violence involved in these practices, but that isn't a necessary component. And whether there is violence or not, the impact of these practices on health and well-being seems evident. So how do these practices manifest in terms of population health? There are three aspects to health that we can use to answer this question: cost, quality, and access. So let's start with cost. Conflict is both a precursor to and a consequence of economic inequality. No matter what country, no matter how dire the circumstances, there will be a group of elites that will always have access to the care they need because they have the money to do so. These people will always have access to private physicians. They can pay to visit private facilities. In many cases, they can pay to leave their country entirely to receive needed care elsewhere. Unfortunately, most people in fragile and conflict-affected states cannot afford these luxuries. As a result, they must either access care that is free, often provided by humanitarian groups, use their limited funds to pay for what is often inferior care, or in many cases go without accessing healthcare entirely. Thus, they are much more likely to suffer from preventable or treatable ailments that may reduce their quality of life or lead to premature mortality. Not only are medications and surgeries often too expensive, but so are the other resources needed for what we consider a healthy life, like a nutritious and varied diet, space and time for recreational movement and exercise, adequate sleep, stress relief, and the like. So I've already alluded to this, but let's move on to healthcare quality. For many of the people who can overcome the first obstacle, which is cost, what they can afford is not necessarily the highest quality of care. In many fragile countries, private facilities offer the best services. They can hire the most experienced staff and offer a variety of services and specialties. They offer more updated and innovative technology, and they're more able to guarantee basic utilities like electricity, water, and sanitation services. Those unable to afford private health services must access whatever services are available. Maybe they find an NGO to fund their high-priced surgery, maybe they don't. Maybe they have the money to pay for the often lower quality public services that remain available, or maybe not. They may only be able to pay for care from local healers or community health workers. While these workers are often doing important and vastly underappreciated work, evidence shows that in some situations it can be of inferior quality. Patients are more likely to be misdiagnosed or recommended treatments that may not be suitable or safe. This is often not the fault of the worker, who might be insufficiently trained or the recipient of inaccurate information, but it does show the downsides of fragmented and poorly resourced care when the services you can get are often the result of forces almost entirely out of your control. So lastly, there is this issue of access. And access is really the core issue in all regards. Not just money, but is there even a health facility in your area? Do you have to walk for miles or try to pay for a taxi or bus to take you to the nearest facility? Do you have to cross a border or a checkpoint that is unsafe or, at best, a hassle and a delay? In countries like Yemen and Syria, many health facilities have been destroyed or damaged in the course of heavy bombardment. So you might make that difficult trip to what was the nearest facility only to realize it's no longer functional. It might literally be unsafe to travel to health facilities due to violence you might encounter on the journey. If you don't have resources or support, you also don't have access. If you're a targeted minority or ethnic group, or in some places a woman, you might not have safe access to facilities, or you might face discrimination or abuse once you get there. You may need to pay bribes for access or have the right political connections. There are so many different avenues with which access to healthcare can be restricted in the conflict-affected environment. And people rightfully get scared considering all these possibilities, which again, may leave them to avoid seeking care altogether. The last thing I want to touch on is just how the entire enterprise of war reduces healthcare for not just those living in conflict-affected countries, but all of us. States, no matter how wealthy, have finite resources. They have budgets. They have hundreds or even thousands of competing incentives and priorities. Global military expenditure has increased by more than 75% in just the past 2 decades, reaching nearly $2 trillion in 2019, which equates to about $250 per person. Between 2016 and 2030, military arsenals are expected to double. Now, to be clear, global health spending is more than 4 times global military spending at just over 8 trillion. It's not that we're spending more on war, but we do have massive health and social needs that are unmet, and war disproportionately contributes to the global burden of poverty, malnutrition, disrupted educational attainment, displacement, unemployment, and destruction of precious infrastructure. We also know that war leads to a higher mental health burden, higher interpersonal violence, more gender-based violence and subjugation of women, and many other ripple effects in society that aren't considered in military expenditure, but cost money to address and decrease social capital. Every dollar spent on war is not just a dollar not spent on health or well-being, but in a way contributes to an overall system that perpetuates this notion that national security is defined solely as military prowess and not the human security of populations. We all lose in such a system, but most of all the most vulnerable, the most oppressed, and the most marginalized. To conclude, direct and structural violence significantly reduces health outcomes in fragile and conflict-affected states through multiple mechanisms. These reductions continue long after active fighting has ceased, perpetuating in both combatants and civilians, often passed down through generations. There are some success stories of countries that pull themselves out of dark times and emerge with a stronger health system, Rwanda being a notable example. However, most countries engaged in warfare remain economically, politically, and socially depressed for years because the core issues that led to conflict are never tackled, and the threats most states protect against are external. Threats to health, by and large, are internal, both within an individual body and within a collective community. Until we learn to value the security of people as much as we currently value the security of states, we will continue to see the security of states and all the people in them threatened. I want to close by emphasizing that these are choices made by people. We can make different choices and choose to live in a world that is more equitable, more peaceful, and more prosperous, not because we live in an unattainable utopia where everyone is happy always, but because we choose the hard work of dealing with the root causes of conflict and inequality, rather than the easy path of assuming there is a military answer to everything. The evidence is not the issue. It's not even a matter of resources. We already have what we need. We just need to choose how to use it. Thank you.
All right. Oh, that was a really fascinating overview of the situation across the Middle East, and you know, Yara touched very nicely on broader aspects related to the costs, quality, and access during conflict, and sort of the indirect effects as well. Very interestingly, she also touched on very briefly, but I hope she's around in the afternoon for us to ask her about this, but on the intergenerational trauma associated with conflict and how that has an impact on health through the generations. It's a really good overview. We're going to switch now to something a bit more specific and focus on the experiences from Syria with Karim, who I know quite well. But Karim, please introduce yourself and let's hear what you have to say.
Thank you very much, my friend, Dr. Osman, and thank you for this invitation to be part of this this meeting, this workshop. So I will present mainly on the experience of the health system or systems in Syria. So my background, I'm a medical doctor. I was training in neurosurgery in Syria in 2009. But then as a result of the conflict, I had to quit my training program and I shifted my focus from surgery to public health. And this was mainly due to the emerging health threats in Syria. For example, in 2013, we had the polio outbreak in parts of the country. And I was involved heavily in the response, in the vaccination campaign in certain parts in Syria. And then the different health threats pushed me further to focus on health systems, on rebuilding the health system in Syria and generally in conflict settings, because there was a complete collapse of the health system in Syria in some parts of the country. And I led the health response for Save the Children between 2013 and 2016 in Syria. And then I moved to the UK, where I worked with London School of Hygienic Medicine, Chatham House for sure, with Osman, David Heyman and others. And I've been working with King College London since 2018, focusing on building health research capacities in the Middle East, focusing on in Syria and other conflict-affected countries. And only recently, we started a large project on health system strengthening in northern Syria, which I will talk about this project in a bit more details. So allow me please to share my screen just to present. Yeah. Okay. No, this one. Yes. There you go. Okay. And also, for Northeast Syria, I work with Integrity Global, which is a global consulting firm, and also I'm a member of the steering committee of the Syria Public Health Network. So generally, when we talk about health system in conflict settings, I think usually there is a confusion between fragile states and active conflict settings. And usually we try to apply the traditional health system framework in conflict settings, which I think will mislead our approach. For example, these traditional frameworks, the World Bank one, the control knobs, which focus heavily on the supply side of health system, with a little bit of focus on only key outcome measures or performance measures. And there's another framework, which is the WHO one, but still the building blocks one. They try to improve this building blocks by having more focus on patient engagement and the overall goals of the health system. I think these frameworks are more applicable to development settings and maybe to some extent to fragile states. But in conflict settings, we need something more dynamic, because the outcome of the health system in conflict settings would differ based on the different phase of the conflict. That's why we're proposing a new framework to look at health system in conflict settings. And this framework, if you see here the timeline. So as we go in through the different phases of the conflict, the outcomes of the health system would differ. For example, during active conflict, the outcome would be mainly on saving lives and accessibility, or basic accessibility and responsiveness for key health threats. While we go to further phases of early recovery and reconstruction, we need to focus on further outcomes, including social and financial protection and universal health coverage. And this is especially important in today's conflicts, because most conflicts today are characterized by being chronic and more urbanized. So none of the recent conflict concluded in a few months or a few years. Most of the, for example, Somaliland, we've been dealing with the conflict since 90s, and the situation now in Yemen and Iraq and Syria and Iraq. So there is kind of chronic status of conflict, which would push us to think about the dynamics of the health system. And also in conflict settings, these circles affecting the different determinants of health, but also the dynamics of health system, social determinants, different sectors, including food, environment, education, and the external environments, which affect the way health regulations, for example, or health systems are framed. And then on the demand or the supply side, these building blocks in the center, funding and human resources, are hugely affected, or should be considered in parallel with the demand side and the performance measures. And we heard from Dr. Yar about the issues of equality and discrimination and inclusion, that they should be at the heart of our thinking of health systems and the different policies, frameworks that govern the way health systems are approached in complex settings. So I will focus specifically on the experience of the health system in the Syrian conflict. As you know, the conflict in Syria has divided the country into different areas of control. I think this is one of the most recent areas of controls maps in Syria, but the dynamics, were very quick. For example, in 2016, 2015, we used to change the map every couple of weeks, because the areas of control were very dynamic. While now it's a little bit more stable. While the red areas are controlled by the government of Syria, the Damascus one, the Assad ones, and then the greens one are more in the oppositions. And in the north, we have another green, which is the one that has presence of the Turkish army. And then this gray area, they are controlled by Turkey. And the yellow ones are the Kurdish controlled areas controlled by the self-administration of the northeast of Syria. And here in the green here, we have another opposition controlled areas. And there are still some spots of ISIS, the Islamic States, that are being pushed by the Kurds and also by the Syrian regime. But how this has been affecting the population, as you know, the humanitarian crisis in Syria was one of the major humanitarian crises in the recent decades, with more than 12 million people in need, and more than I think around 10 million population were displaced either internally or externally outside of the country. The health system was severely affected. Almost 50% of health facilities have been either destroyed or partially destroyed. And in some areas, less than 1% of health facilities are functioning. In terms of primary health care, more than 70% of facilities are out of service. The pharmaceutical production dropped from covering 90% of local needs to less than 30% in the recent years. And vaccination dropped from one of the best coverage, I think, in the Middle East to less than 5% in some areas. And also the impact on human resources and health workforce was massive. A lot of medical staff were killed, and a lot of them decided to leave the country because of the unprecedented risk. And also the causes of the mortalities and morbidities profiles were changed dramatically. So compare between before the conflict in 2009, while NCDs were the top killers in Syria, while now for sure conflict and terror is the top killer, but we still have NCDs and also CDs. So now we have triple burden to deal with in terms of man-made and communicable and non-communicable morbidities. And the shift is obvious. This is taken from the global burden of diseases. And also some indicators dropped significantly. For example, life expectancy dropped from around 74 for men to less than 60 in some occasions. And also the mortality of under 5 and under 1 increased. For example, for the under 5, it was less than 18 per 1,000. Well, now it's around 30 per 1,000 births. Also, mental health was affected severely, and the all aspects of mental health, including social well-being or the different aspects of physical access to healthcare that can affect mental health, were affected in the different parts of the country. And if we will look at health governance, how this was affected, looking at the different areas of control, the health systems were divided. So the Damascus Ministry of Health, after some areas were taken by oppositions or by Kurdish groups, the Damascus Ministry of Health, they withdrawn from these areas, leaving some of the areas in severe needs. For example, in Deir ez-Zor, while these areas in 2013 was used to control by oppositions, in 2012 the vaccination coverage dropped to 0%, which was the main reason behind the emergence of polio in 2013. So as a result, we have different health systems in Syria. We have the Ministry of Health in Damascus covering the red areas here. We have the Syria Health Directorate, which is a very interesting initiative using bottom-up approach. Local health doctors in the opposition-controlled areas, they established a technical health system that does not have certain political affiliation, and that derives its legitimacy not from a Ministry of Health, but rather from a General Assembly, which consists of all health workforce in the region, which is very innovative experience that we are trying to highlight in our work now in King's College. And then the self-administration in northeast of Syria has also established their own health system. And also the Turkish Ministry of Health, they have presence here. So we have at least four different health systems operating inside one country. And accordingly, the health cluster system was divided between the Gaziantep hub here in Turkey and the Damascus hub. And they used to be a northeast hub, but now with the expiration of the cross-border response in northeast of Syria, these interventions are managed by the health cluster in Damascus. There is another whole of Syria approach in Amman. I would like to highlight some key highlights about how humanitarian health interventions can be framed in a way that can strengthen health system rather than disrupt health system. Because sometimes humanitarian interventions in conflict settings establish a parallel system that can further disrupt local systems. So I will give some examples. In the polio response between 2014 and 2016, what we try to invest this response is to strengthen local networks and establish some central mechanisms at district level and at governorate level. And these mechanisms were strengthened by resources and infrastructure to establish core teams that can not only respond to polio, but also to other health threats. And as a result of the polio response, this Syria Health Directorate, the system that used bottom-up approach, this was further strengthened because of the polio response. And then other humanitarian responses or interventions were framed in a manner that can further strengthen these district and province level health systems to respond to other health threats. Another idea was to move from facility-based projects to more central projects, not on national level, but more on district and governorate level. Some examples including the Syria Immunization Group, because it was impossible for one actor to focus on one camp, for example, on one village to do vaccination. And there was a need to have more district level and governorate level. And this was what was represented by the Syria Immunization Group. Other example including the health information system and the referral system, the primary health care. So in light of having no one health system or less clarity about health governance, establishing technical projects which focuses on thematic areas could be a solution on how to deal with health system strengthening. Attacks on healthcare, as you know, was a major challenge in Syria, most of which are committed by the Syrian governments and their allies. So to deal with these, and I've written about potential motivations behind these attacks, and I was arguing that these attacks of healthcare in Syria were used as a military tactique rather than a collateral damage in the Syrian conflict. But one of the innovations here is how to use different technologies in documenting and preventing attacks on healthcare. This was used as an example of strengthening health systems here. For example, this paper talked about the use of WhatsApp to generate and establish real-time reporting tool, which used to call MVA, Monitoring Violence Against Healthcare. And this, unfortunately, was replaced by the SSA, the System for Surveillance of Attacks, the global system applied by the WHO. Another very innovative system was the HALA system, which used different machine learning to expect or to predict attacks on healthcare. And also they do sensors to predict attacks and to warn people of attacks on healthcare. Another example was the Syria Board for Medical Specialties after interruption of medical training. Again, another initiative that was trying to rely on local resources to train resident doctors. So there are many other initiatives I don't have time maybe to go through, but maybe I would highlight our work on our recent project, which is research for health system strengthening in northern Syria. So this project is by King's College in partnership with also with the Union for Medical Care and Relief Organizations. And at the heart of this project, we try to encourage academic or multidisciplinary partnerships between academic, humanitarian, policy actors. And some other actors are involved in this project as well. So the project aims to produce a model on health system strengthening on complex settings, which could be applied elsewhere, investing or learning from the Syrian context. So we focus on four building blocks. We don't have time to go through all of these, but in terms of the work streams, we focus on this project. The first one is a provision of health services. So we try to explore and provide evidence on the effectiveness of the different health system strengthening interventions that I presented, including, for example, central projects and assessing, for example, surgical capacity in all levels. The other work stream is health education. We try to engage with all health education initiatives in the region, whether it was medical school or nursing schools, try to help them develop curriculums. And one example that maybe out of the Syrian context was the King's Somaliland partnership that started in 2000. And King's College was supporting the Ministry of Health, Ministry of Health Education, and 4 different universities in Somaliland to develop their health education. And we aim to do something similar here in this project. Health information system, we try to establish electronic medical record system in northern Syria. And for health governance, we support governance initiatives and produce or generate different financial models on how to finance the health system in the active conflict now and also in the early recovery phase. Maybe I will stop now because I'm already out of time. And maybe if there are questions, maybe we can engage in further discussions. Thank you.
Thanks very much, Karim. That was a great whiz-stop tour through Syria and the impacts on healthcare and access to it over the course of the conflict. As sort of using my prerogative as chair, I did want to ask you a question, because I found your dynamic model for health system strengthening very interesting, given we do so much work with the more static models. I challenge you though to include an element of your own work in that model. So specifically around preventing and monitoring attacks on healthcare. Shouldn't that be part and parcel and an explicit part of a dynamic model for a framework for healthcare in conflict settings? That and I felt that that an element around justice and restitution. So in the post-conflict phase, where part of healing for the community, for the whole population, is that the perpetrators of attacks are brought to justice, and there's some form of restitution around that. Surely those should be part of the model.
Thank you very much, Dr. Osman. And indeed, this framework, we have not published yet this framework, where it is still kind of a working framework. So really thank you for these inputs. And unfortunately for attacks on healthcare, attacks on healthcare now is kind of the new norm for conflicts. And that's why maybe they should be included here, because they're not specific to Syria. We've seen this many times in Yemen and in Libya and other contexts. So I think definitely attacks on healthcare and this protection of healthcare element should be at least one of the outcomes of the health system, because the health system should ensure that health workforce, at least, if not infrastructure as well, are protected, which I completely agree with. And the point of transitional justice, I think, is very much important, because this I think there was work on the health as kind of a bridge of peace. This was, I think, in the Bosnian war since 90s, but I think this was not further developed. And some actors, they are pushing back that, we do not, we cannot use health for any other purposes, including peace, which I argue, having this triple nexus introduced in the new working of the UN agencies about peace and humanitarian development, I think we cannot, move away from or avoid or ignore that the health should be part of peace initiatives in early recovery. And now in Syria, because we have different health systems, one of the aim of our project is to unify the health policies into the different health systems as an entry point that can allow those health systems to talk to each other, which could be, a first step. And transitional justice, I think, is at the core of this, because they will not be willing to talk to each other unless there is a minimum level of justice in the early recovery. So really thank you for these inputs, and I will take this in consideration definitely.
Okay, thanks, Karim, and stay on the line because we're going to have a Q&A, a proper Q&A at the end of all the presentations. So switching now swiftly and deftly to our colleagues from Action Against Hunger. I'm not sure who's presenting first, but John Cunliffe and team, please, take the floor is yours, and please introduce yourselves and your work. Thanks.
Thanks very much, Osmond. Thank you very much again, Jubin and team as well, for the opportunity to speak to you all today. So very briefly, John Cunliffe, I'm the Regional Director for the Middle East for Action Against Hunger. Been working in the Middle East for 15 years so now. Action Against Hunger is very much a traditional, if you like, classic French NGO dating back from 40 years. And I'm sure as the day goes on, we'll talk a little bit more in detail about some of the battles that we've had around some of the issues that we've already discussed around the transitions, the North-South partnerships, etc. But for the moment, what I'm going to do is almost immediately hand over to my colleagues. I have with me Paul Critchley, who is our country director for Iraq, who was asking questions earlier on. Naomi Renard, who's our country director for Jordan. And to start us off with, we have Sami Gwazabi, who is our country representative for Libya and Tunisia. And he is going to start off by talking more about healthcare and conflict. As the rest of the morning goes by, Paul and myself will be looking at sanctions and the impact of sanctions. But let's start, and then later in the day, Naomi will be talking as well about COVID. But let's start with Sami. Over to you, Sami.
Thank you, John. Good morning, everyone. I will just make sure that everybody is hearing me correctly. I will be sharing my screen. Is it working?
Well, good, Sami. Go for it.
Okay. So we decided to have a presentation on the context of Yemen and Libya. We'll be representing my colleague from Yemen, Alex, unfortunately not able to be here this morning. So we'll go through 4 different parts: a brief introduction and the current context, the conflict, the armed conflict and the health system, a very short COVID-19 situation and impacts, and some possible solutions. Starting with Yemen, a very brief introduction. As you may all know, 6 years after the beginning of this armed conflict, Yemen remained the world's largest humanitarian crisis. In 2020, we have nearly 4 million people displaced, including 172,000 people who fled their home, 20,000 civilian deaths and injuries have been verified, and this since 2015. The health system, already overwhelmed, is expected to remain like that, with a capacity to decline, and health workers to be underpaid or in short supply with no additional fund provided. We have a high likelihood of infectious disease outbreaks, particularly conditions that favor the spread of cholera. What is very interesting is that since 2016, there is an outbreak of cholera in Yemen, with almost 4,000 deaths and almost 2.5 million cases, which is quite important. So as I said, conditions that favor the spread of cholera and COVID-19 are facilitated by the spread of other communicable disease. Multiple health risks are coupled with deteriorating access. The Yemeni conflict is a situation where we have more than 42% of the Yemeni people living more than 1 hour far from the nearest health facility or public hospital. That was something that was mentioned earlier by Dr. Yara in terms of access, physical access. It's also something very important and quite significant in Yemen. The effects of declining access to health and nutrition services are likely to be compounded by challenges related to logistics and basic supplies. We are talking here about the Yemeni blockade, quite important in terms of affecting the situation in Yemen. In 2021, we have more than 20 million of the population in need of humanitarian assistance. Within more than 12 million people were estimated to be in acute need. It's quite a number, so obviously. We have more than 16 million people who go hungry this year. Among those, we have 5 million people facing emergency condition and nearly 15,000 who are already experiencing catastrophic conditions. More than 2 million cases of children under 5 and more than 1 million pregnant and lactating women are expected to suffer from acute malnutrition. And more than 11 million people with health assistance, including almost 6 million children and almost 3 million women. It's quite significant, quite scary, I would like to say. Conflict and the health system. So the conflict, the 6 years armed conflict in Yemen impacts significantly the health system. We saw a breakdown of the infrastructures. We have nearly 15% of the health facilities that are partially or not functional, and destruction of wash and electric power facilities. Again, that was mentioned previously by all the colleagues. We saw shortages of medicines and medical supplies. We saw shortage of healthcare providers. They are regularly threatened, harassed, intimidated, or attacked. And as Abdulhakim said previously, it's something that it's important. Taking care of the health worker is something really, really important, and we may be discussing that later. We have an increased health burden, a reduced capacity to address infectious disease and events. We talked about that previously with the cholera, but we have also the COVID-19 going to be discussed more further this afternoon, if I'm correct. We have a limited data. So the system is weak for data collection and evidence generation. We have a poor quality data existing and the lack of proper documentation. We have a limited access to the health facilities and the limited access to and restriction of conducting surveys and data protection. That's very important because Yemen is one of the countries where the authorities are significantly and permanently blocking the humanitarian access. That's something that we can maybe discuss later, but it's very, really significant, and that has a huge impact on healthcare, obviously. We have also restricted access to health and nutrition services. As mentioned, the insecurity, legal and administrative barriers, the militarization and politicization of healthcare, the armed conflict, all those things are impacting negatively the access to healthcare. We saw an inadequate coordination among humanitarian actors. That's something, despite the fact that we are one of them, we need to obviously open the debate on that, and that's something that needs to be discussed. There is limited prioritization. There is a clear discrepancy between the priorities of the health sector and the needs of the affected population. It's something really, really important. As an example, the care services for sexual and reproductive health or mental health, as discussed before, are clearly under prioritized. The sustainability and transition to development, despite the fact that maybe Yemen is not in this situation, is still something that needs to be discussed. The short-term humanitarian intervention do not transition smoothly to a more longer-term development work, and that's something that we collectively need to think about and collectively try to figure it out and see how we can address that. Very briefly, policies are not sufficiently tailored to specific conflict-affected contexts. We have insufficiently accountable to affected population to their performances. When we are talking about accountability, something very important for humanitarian organization, but that's also something that we need to, that's something in my opinion, we need to raise awareness within the contexts we are working in, because we are all, and we should all be accountable to the affected population. We are providing services, including authorities, obviously. And to complete this part, the donors and the states engaging on humanitarian health issues, clearly the access to funding or to short-term funding is clearly insufficient. The allocation of aid in the way that goes is not facilitating the response to the local needs, and the counter-terrorism clauses or new rules in donor contracts are also impacting the way we can deliver the services and the aid to the affected population. Very quickly on COVID-19 and the impacts on health system in Libya. So the first COVID-19 case was announced in April, the 10th of April 2020 in Yemen. We are now almost 6,600 cases and approximately 1,300 deaths. Yemen received 360,000 doses of vaccines through the COVAX facility in March 2021. It's positive, but still not enough, unfortunately. In terms of impact of the pandemic in Yemen, the agriculture and the food systems were really hardest hit. We saw a lot of employment losses, so household income, very, very important. The COVID-19 is exacerbating the already overwhelming health crisis in Yemen, particularly on the insufficient testing capability, across the country. The lack of necessary infrastructure for COVID-19 prevention and management, a lack of supplies, particularly ventilators, oxygen generators and oxygen cylinders, the need of increased training for health staff, health personnel, particularly those the staff involving in working in isolation units. It's quite significant. We have quite a high infection rate and deadly effects of COVID-19 on health staff. That's something also we'll be discussing that in the Libyan context, but it's quite significant in both countries. And the multi-year cuts to medical personnel salaries and incentives in Yemen particularly, is clearly affecting the way the health system is able to support the population affected by the COVID-19. Possible solutions to protect and maintain the health system. As mentioned previously, improving the coordination is something for us and for all humanitarian actors very, very important. Responding to context-specific needs, understanding a better understanding of the context, engaging more with local actors is crucial to understand and to tailor responses to local priorities and needs. Detecting and responding to attacks. We saw that previously it was mentioned by all the colleagues that health facilities, health workers are regularly attacked, and it's really important to be able to detect this as soon as possible and being able to provide responses. Holding health sector accountable to affected population. I mentioned that previously, the accountability not only of humanitarian actors but of authorities and also health. All health actors is really, really important. Making responding sustainable. We are talking here about the humanitarian development nexus and improving the access to a long-term programming. That was very briefly, the context of Yemen. We will move now to Libya, to the Libyan context, and you will see that there is some similarities. So the situation actually in Libya, the conflict that started following the uprising of 2011 has left an estimated 1.3 million people in need of humanitarian assistance. That represent almost 20% of the population. Libya is a big country, 1.7 million square kilometers. It's huge, but only 6.5 million of inhabitants with 0.5 million of migrants. So it's quite interesting to compare both countries. While in Yemen we have 30 million of inhabitants. In Libya we have around 250,000 people displaced and 650,000 people as returnees. 450,000 people mostly in need of health assistance. Libya is a situation where we saw reduced quality and availability of services. More than half of the Libya health facilities were not functioning in 2019. It's quite important, and were forced to close in 2020, more severely in rural areas. Mostly because of the security threats and the lack of national and health sector funding. The facilities that remain open are facing a huge shortage of staff, medicines, supplies, with almost 70% of PHEs not having any of the top 20 essential medicines, such as antibiotics, analgesics, insulin, etc., etc. Libya has an acute shortage of medical specialists, midwives, or nurses, and is really relying heavily on foreign health care workers. It's really, really important in Libya, and I think specific to this context. We saw frequent water and electricity cuts, shortages in healthcare workers, as mentioned previously, medical supplies, etc., etc. To complete this brief introduction, 1 in 7 Libyans, so approximately 1 million people, are in need of mental health care for such illness as depression, anxiety, and post-traumatic stress disorders. That was mentioned previously. It's something that is always, at least in Yemen and Libya, not fully prioritized, and that's something that, at least for us, is very concerning. The conflicts and the health system. Again, I'm repeating myself. I'm going to be very brief, but regular attacks on hospitals and other healthcare facilities, looting, confiscation of medical supplies, equipment, and vehicles, violence against healthcare staff and personnel, unlawful deprivation of liberty for healthcare workers. We saw some doctors, particularly in the east of Libya, being detained because speaking openly about how the pandemic, the COVID-19 pandemic, was managed by the authorities. We have a hampered access to essential healthcare facilities. And one thing I think, I mean, that was quite important for me to mention that, because I saw that it's quite important, but the management of domestic, industrial, and medical waste was really poor before the conflict, and it's clearly worse now. And that's something that is always not fully addressed, or it's very complicated when we're talking with donors or when we're talking with authorities to raise awareness and to make it really important, but I think it's something quite significant. Very briefly, the COVID-19 context in Libya. In April 2021, we had more than 174,000 cases and almost 3,000 deaths. It's quite significant. The situation is even a little bit worse now. By the end of May, we had almost 190,000 cases and more than 3,200 deaths in Libya. The Libya started the vaccination, which is a positive sign. We're discussing that previously, and at the end of April 2021, Libya received 250,000 vaccine doses, and is expected to receive a little bit more in the coming weeks. In terms of direct impact of COVID-19 in Libya, while Libya is already facing a divided governance, a collapsing economy due to the armed conflict, COVID-19 had an even huge impact on the already devastated infrastructure and governance vacuum. We had a clearly insufficient testing capacity across the country. As I said previously, Libya 1.7 square kilometers in terms of millions square kilometers in terms of superficie, and only 32 COVID-19 labs. The country is huge, and we have only in country 32 labs operational. So clearly insufficient testing capabilities across the country. A lack of necessary infrastructure, of course, a lack of supplies, the same as Yemen. The border closure in 2020 and some national lockdowns have disrupted the trade and the livelihood of already affected population. And we saw that the price of basic items rising. At the start of the pandemic in 2020, We had up to 90% of the PHC centers that were closed in some area. It's quite significant. And several hospitals were forced to suspend their services. Last year, but still, it's still present, the healthcare staff refused to report for duty because they had no personal protection equipment or they had not been paid for several months. So this is also impacting the access of healthcare. Possible solution for Libya. We had a new government designated until the future election at the end of 2021, and we believe that they should capitalize politically by trying to resolve the COVID-19 crisis, particularly by endorsing the COVID-19 National Preparedness and Response Plan that was drafted at the beginning of the pandemic and which is still not being formally endorsed. Using the support of international organizations and donors in the health sector to strengthen the health system is something very important and it's a real opportunity for Libyan authorities. Enforcing and ensuring stability while building competencies at all health levels, improving the coordination, very important. Ensuring that implementation of essential services and the access is equally distributed across country, which is quite difficult with the size of the country, with no discrimination. Trying to reduce mobility and mortality for all Libyans. We believe that the country should try to raise efforts to erase gaps for moderate to severe mental disorders. It's something, again, in Yemen and in Libya is underestimated maybe from the authorities, but the global humanitarian actors are trying their best to provide a response to that, still not have the full support, in our opinion, that is needed. Ensuring the construction and the rehabilitation of health centers where needed, and we saw that the country, due to its size, but also to the economic collapse, is really in need of that. While strengthening the health system, we need to ensure proper planning to meet the needs and the objective. I guess it's quite difficult in a country as Libya, because the political instability until recently has clearly impacted the health system. Until recently, we had two different governments, and obviously the prioritization or the objectives were completely or at least different between East and West. As mentioned for Yemen, ensuring the accountability at all levels, professional accountability, legal and ethical conduct, financial performances, adequacy of access, public health promotion and community benefits are very important points in terms of accountability for us. That's all for us in terms of healthcare and armed conflict in Yemen and Libya. And I guess we'll be open to some questions if there is. Thank you all.
Thank you, Sami. I have a couple of questions around Yemen, but I'm going to wait for the Q&A because we're running a little bit behind time. So I'd like to invite Mariko next from the ICRC to give us his thoughts and views. Mariko, please give us a brief intro and then begin your talk.
Hello, can you hear me?
Yes, we can hear you, Mariko.
Okay, thank you very much. My name is Mariko Ivkov. I'm Regional Protection Civilian Population Advisor for the International Committee of the Red Cross. And I would like to thank you to Webster University for inviting us, and also to all the panelists for the interesting presentations they made. From my side, if Cecilia, you could upload my presentation I sent you this morning, that would be great. I'm not a healthcare specialist, I'm a protection specialist. So my role is to look into the conflict of hostilities and how conflict affects the provision of healthcare services. So I will not repeat what was already done by the others. And yes, but I would like to speak about the rules of war, which was not mentioned before. And some people are familiar with the international humanitarian laws, others may not. So I just want to have a recap slide on the legal framework. International humanitarian law is also called rules of war. And in times of armed conflict, IHL provide rules to protect the provision of healthcare services. And these rules bind states and non-state armed groups alike. So I'm not sure you can see my screen because I can't. In times of armed conflict, medical personnel, medical units such as hospital, primary healthcare centers, medical transport such as ambulances must be respected and protected in all circumstances. If they're only used for medical purposes, they lose their protection if they are being used outside the humanitarian function to commit acts harmful to the enemy. And in addition, punishing a person for performing medical duties compatible with medical ethics, or compelling a person engaged in medical activities to perform acts contrary to medical ethics is prohibited. And the rights of the wounded and sick must be respected in all circumstances. The wounded and sick must be treated without discrimination. If distinctions are made among them, it can be only on the basis of their medical conditions. So I will see if I can go to the next slide. So I just wanted to raise issues of concerns. These are only examples, and it is not meant to be an exhaustive list. But in terms of healthcare facilities, several of them were damaged owing to unguided indirect fire weapons such as mortars or rockets. And this occurs most frequently when military operations are carried out in densely populated urban areas, where the military activities and installations are sometimes located in the vicinity of healthcare facilities. And those firing weapons are required to take all feasible precautions to distinguish between legitimate and illegitimate targets and to minimize damage to civilian population and the provision of healthcare services. We also saw in recent armed conflicts that the use of explosive weapons that have a wide area affecting populated area, notably because of large destruction radius of ammunition used, is a major cause of civilian casualties and damage to or destruction to civilian homes and critical infrastructure, including healthcare facilities. And in some instances, healthcare facilities were targeted due to fighters being present within them at the time of attack. And sometimes there's a dual use of healthcare facilities. And at the time of attack, there may be fighters collocating with patients and healthcare personnel, putting them at risk. And as mentioned earlier, medical units will lose protection if they are used to commit acts harmful to the enemy. However, this protection can only be withdrawn only after due warning has been given within a reasonable time limit, and only after that warning has gone unheeded. In other incidents, healthcare facilities were allegedly directly targeted, whereas there was allegedly no military objective in their premises, which raised concern. Some of them were targeted directly because of wrong intelligence, but such incidents would raise serious concerns if the healthcare facilities were deliberately targeted without a military objective inside. Healthcare personnel, I think some examples were given by others, notably by ACF. So I wouldn't go too much into details into the other examples, but I think several participants emphasize that there's an overlapping between conflict and COVID. Countries which are affected by the conflict are also affected by coronavirus. And in the beginning of the pandemic, I think there was a high level of stigmatization in the Middle East towards COVID-19 patients, those who died because of COVID-19 and the healthcare personnel treating them. And attacks by civilians on healthcare personnel were observed on several occasions, mostly by the family relatives of patient. It happened, for example, after the death of a COVID-19 patient in hospital, dissatisfaction with treatment, etc. So on the next slide, I would like to show what do we concretely do. So the Healthcare in Danger is an initiative of the International Red Cross and Red Crescent movement. It's aiming at addressing the issue of violence against patients, health workers, facilities, and vehicles, and ensuring safe access to and delivery of healthcare in armed conflict and in other emergencies. The ICRC's Healthcare in Danger strategy aims to reduce violence against healthcare and its impact in a conflict. To achieve this goal, we have 4 specific objectives, which I will explain in the following slides. So the first step is that we document incidents. We do not rely only on open source information because sometimes it can carry misinformation. And to the extent possible, depending on our security and access situation, we would like to try to go to the place of incident, talk with the healthcare personnel in private, with the victims, with the witnesses to understand better how an incident occurred. And in doing this, the principle of do no harm is of utmost importance. If a person who spoke to the ICRC says, please do not raise this issue with a party to the conflict because he or she fears retaliation, we would not do it. We would respect his or her choice. Then if an issue can be communicated to the relevant parties to the conflict without causing harm to the people who just spoke to us, we would be engaged in a confidential dialogue with parties to the conflict and remind them of their obligation under international humanitarian law to respect healthcare services. And in addition, we do what we call prevention, which means that we offer support in training of state armed forces, non-state armed groups in terms of IHL. And this IHL training includes, of course, a module on the protection of healthcare services. And in addition, this year, we published, we made a publication called Protecting Healthcare Guidance for Armed Forces. And instead of simply saying, respect IHL, it gives concrete recommendation to the state armed forces to improve their SOPs or their rules of engagement to ensure a better protection of healthcare services. So in the next slide, if there's a possibility to go to the next slide. Yeah. Okay. The second objective is that states bring in legislation to protect healthcare services. So basically, we would have a specialist looking into the national implementation of IHL and working with the relevant authorities on this implementation. And in addition, we also carry out the studies of the national legal framework. For example, we did it in Iraq to give concrete recommendation on how to improve the domestic legislative framework to better protect healthcare services. The third example I want to give, the third objective is that healthcare providers are better prepared to prevent, mitigate, and cope with the impact of violence. And basically, it's not easy for healthcare personnel who comes under attack to diffuse this violent behavior. And we created a poster which is available in English and in Arabic, on which gives tips on how to diffuse violent behavior in healthcare settings. And in addition, in some countries, we do what we call de-escalation training. It's basically a training of trainers for healthcare personnel working under the Ministry of Health or in the National Red Crescent Society. Is it possible to move to the next slide? And the objective 4 is that the general public has greater respect for healthcare services. And either we do it through a communication campaign in cooperation with the relevant Ministry of Health or the National Red Crescent Society to maximize the outreach, or by mobilizing key influencers. And in several countries in the Middle East, actually religious scholars have a very high influence in outreach. So we organize workshops with them, and we sometimes ask to convey our messages. So most recently, we made a video with 5 renowned religious scholars across the Middle East with key messages on coronavirus, including the importance to respect healthcare personnel. I was very brief because I wanted to leave some time for question and answers, and thank you very much for your attention.
Thank you for that, Mariko. That was really excellent, and thank you for being brief as well, because I've done a terrible job with sharing and keeping us to time. We do have 15 minutes for Q&A now. So and we've heard 4 really brilliant presentations. So I suppose just raise your hand in the chat if you've got specific questions. I have a couple of questions, so I'm going to use my prerogative as chair again to ask them. One is directed at our colleagues from Action Against Hunger, and I'm doing this. This question is with my One Health bias. For those of you that don't know, One Health looks at the interface between human health, animal health, and environmental health. And I wanted to ask a specific question about the context in Yemen, and given that your organization is called Action Against Hunger, the question I had was that Yemen has a particular peculiarity, I suppose, in that they're one of the most water insecure countries in the Middle East. And water security is a huge issue, and there's a nexus between water security, food security, and human health security. And in that context, from my last reading of it, 30 to 40% of Yemen's water resources are used for growing khat, which is a recreational drug, frankly, not for growing food for the population, not for anything else, but for growing khat. And so I suppose, what are people doing in sort of trying to address that issue in both ensuring health security and nutritional security in the context of Yemen? Because water security and limiting access to water has been one of the tools of war as well in the conflict in Yemen. So, specific question around that.
Yeah, may I start, Sammy? Perhaps you can jump in. So, yes, a lot of water is used for khat, but and the main problems around food security and khat are the fact that 80% of Yemen's food has to be imported. Because so much arable land is turned over to khat. Khat itself, up until the regime, if you like, of the former President Saleh, was more or less a recreational drug that was used occasionally. So a lot of people would khat for a special occasion or at a weekend, and there's some beautiful homes and houses in Yemen where they've got special khat towers at the top of them where people would sit at the top and they'd have khat on an evening. Since then, it has become, basically, Saleh pushed it, and it's become the drug of choice for everybody. 90% of men and 75% of women are actually khatting on a regular basis at this point. And indeed, usage and the economic growth has continued throughout the war since 2015. Even before the war, Yemen, Sana.
Sorry, have we
about running out of water completely. Did I cut? My apologies. Can you hear me now?
Sorry, John, I think you've frozen.
Okay, can you hear me now?
John, sorry, I think you froze there. Yeah, we can hear you now. Sorry, could you just rewind 10 seconds, 15 seconds?
Okay, so even before the war, as you said, Yemen was extremely water insecure. Now, I'm not sure what the technical this are, but what basically has happened is that a lot of the lowlands have now become infected, if you like, by salt, and a lot of the lowlands that were used for producing near the sea, crops, edible crops, have been reduced significantly. So capacity of production of local foods has reduced significantly. There are some efforts to address that. We cannot address that. Given the sheer size and scale of the problems in Yemen, we're talking about 66% of the population, nearly 30 million, requiring some form of assistance at this point, 7.5 million requiring some sort of nutritional assistance. A lot of money is being focused just on the basics. And this is the whole nexus thing of peace, development, etc., bringing it all together. We're nowhere near that in Yemen. The only money that's available is really for providing urgent humanitarian assistance. Water, we do water trucking. We do a lot of water trucking still because we don't have a choice, because we have to take water to where people are, and where people are, there is no longer any potable water. So this is a problem that's also going to be there at the end of this conflict and will require significant investment to actually address. I hope that answers your question. I'm sure Sami can add to it if you want to, Sami.
Yes, thank you, John. Maybe very quickly, because you almost said everything. What I just wanted to add is that CAT is also a regular, sure source of income for the communities. And that's also something that needs to be considered. CAT grows many times per year, quickly, and communities are having, through growing and selling CAT, incomes when they had nothing if they don't have that. So it's a very complicated situation, but it's also something that needs to be considered. And I've been in Yemen working, and I remember discussing with communities on the reason why they split from 80% of the land growing food to 80% of the land growing CAT. And the answer is always the same. It's CAT means money. And when they had nothing, it's better for them to do that to not.
Yeah, it's a real challenge there in that particular setting. So one question now for everybody, for all the presenters. We've heard a lot about we heard that the crucial factors being sort of cost, quality, and access to healthcare services, particularly in these conflict settings, and that should be the basic framework around assessing quality and assessing access and coverage. I wonder, while listening to the presentations, should there be a systematic approach to analysis based on what group controls the particular geographical region within a conflict setting? So should you have comparative analysis on quality of healthcare provision and access to services? Because that's a double-edged sword. One is that it helps you direct resources, but the other problem is that, of course, as we've heard, access to healthcare and healthcare services themselves are a stratagem of war. So there's a propaganda element in showcasing that, yes, we're providing better services than the opposition, or undermining the opposition's of ability to provide services is an issue. And I know the ICRC probably takes a very, they need to maintain their neutrality, and for them, ensuring access to the combatants and the communities under their charge, so to speak, is paramount. So they balk at associating themselves with these kinds of public comparisons, even though they might do it in private. But I suppose, is that something of value? And what does everyone think? I'm thinking about Karim as well, who gave us, sort of a comparative analysis of 4 different areas of Syria. Is that a useful activity? Is it something that should be done in a systematic way, and so that we do know, what is the picture in terms of healthcare access in a conflict setting, or is it something to be wary of? I'll just open that out for everyone. I hope you guys understand my question. Come in, Karim.
Thank you, Osman. And I think this question is very much related to what I was trying to present in terms of different areas of control and the implication of this on different health systems, and how we need to approach these different health systems differently, maybe because of the a different set of determinants of health in each areas of control. And I think one of the issues that we've been focusing on in Syria in this phase, which is it's not yet early recovery, but we need a lot of actors, they started to think about sustainable humanitarian interventions or health interventions rather than only life-saving ones. And I think one of the things we focused on was to convince, different donors and actors that you need to, differentiate between the different areas of control. You cannot approach all areas in the same manner. I will give one example, which is sanctions, which is very problematic sometimes. Almost all Western countries imposed, very strict sanctions on the Syrian regime, on the government of Syria, because of their violations of human rights. But in the same time, these sanctions sometimes they are affecting the different health actors operating in different parts of the country, including areas where, for example, even the Western countries have presence, for example, the US or the Europeans. So our approach is that, yes, it's good to make this conditionality that your sanctions would be based on human rights violations, but in the same time, you cannot, deal with a country in conflict settings, as one unit, because it could be different. And I think very similar things happening in Yemen and in Libya, where you have different areas of control, and the different parties controlling these areas, they have different levels of first adhering to international humanitarian law, and second, flexibility in terms of listening to the different health narratives that or allowing for different entry points for health actors. So that's why I think this comparative analysis should be part of any health planning or health system analysis. And that's what we are trying to do in this project in King's College. We are focusing on northern Syria only. It is called health system strengthening for northern Syria. It's not for all Syria, because we understand the limitations that we would love to work in regime controlled areas, but we cannot. And there are a lot of sanctions and human rights issues that prevent us from working there. But it's not the solution that we either, walk away from the whole country, or, or work with all parties on the same way.
And it's perhaps an academic output, but one of the things that perhaps should be done is to have a systematic mechanism or framework for doing this kind of comparative analysis, and also for what you were saying, having a systematic methodology for assessing the impacts of sanctions on conflict-affected regions or even non-conflict regions, as was highlighted by one of the earlier interventions around sanctions on Iran and what happened around that, the health impacts, or well, it's debatable whether it's intended or unintended, but the health impacts at any rate of these kinds of sanctions. John, you wanted to come in?
Yeah, I mean, I very much agree. And we'll be talking about sanctions a little bit later after the break, I think, in more detail. But Yemen is not per se under sanction. There was an effort by the US to do this just towards the end of the Trump regime, in fact. Overturned immediately by Biden and Blinken when they came into power. But the blockade that has been placed on the north of the country, and the stopping of the importation stopping the heavy reduction of the importation of products through Hodeida port through the north of the country, had virtually the same effect as sanctions. And I do believe that it would be very, very interesting to have some comparative data, because we still tend to talk of Yemen as one country. But clearly, when you go to Yemen, and we do, and I do, you would see the difference between the situation in the north and the south quite openly and quite easily in terms of the way that people are living and the availability of healthcare. And we know the pressures that are on us are greater in the north than they are in the south. So I do think it would be useful, and it would actually probably be a useful advocacy tool for us.
And Mariko, does the ICRC have a good way of sharing information? Because it's privy to a lot of information from combatants about the kinds of health services they're providing, even though they don't necessarily you don't necessarily publish yourself, but do you have a mechanism for sharing that with others so that they can publish it and present a truer picture of what's happening comparatively in terms of provision of health services in conflict settings? How does ICRC handle that?
Okay, so first of all, thank you very much, Osman, for emphasizing on our principles, which are neutrality and impartiality. Our mandate is to help the people affected by the conflict without any form of discrimination. So we firmly believe that humanitarian assistance should be needs-based. Then we strive to work in areas under the control of state authorities and the non-state armed group, which is the case in Yemen, notably, where we have offices on both sides. When it comes to data sharing, I cannot comment because, again, I'm not a health specialist, but what I know is that usually we participate in sometimes in some contexts in cluster meetings as observers. What is the most important thing is that any assistance should be vulnerability-based, needs-based for the people affected. And this is a message that we convey in all the countries affected by conflict. Thank you.
Thanks, Mariko. So please, we're gonna allow it to run over a few minutes and cut into your break a little bit, but any questions from our audience and from everyone else? Questions, comments, anything? Or are you all really keen to go have a sandwich or a bathroom break?
Now you can talk. Hi, Osman and Mariko and John and team. It's great to be here and see you again, face à face, as we say. I have a question that's sort of general, and it probably doesn't have a response, but while you are covering this vast work that you're doing in a beleaguered and very complicated part of the world, it occurred to me again that I'm a Swiss citizen and we live in the city of Geneva, and we're often reminded of Henri Dunant, who was a businessman who went to northern Italy and witnessed the suffering at the Battle of Solferino and returned and founded the Red Cross, and actually died a pauper. I mean, he wasn't recognized. I think he won the Nobel Peace Prize in 1900. But so I'm wondering, you know, with COVID and all of the sort of compassion fatigue that the world experiences through constant news about problems, particularly in the MENA region, if there's another way to sort of turn the narrative so that people like me and other people who are not health professionals can be more sensitized towards the need to protect healthcare workers. I'm talking maybe about a new sort of Henri Dunant, you know, come alive virtual world or something, some way to communicate to us or to awaken all of our senses to the realities that you experience as professionals out there in the field. So it's not really a question, it's a kind of an observation about maybe sensitizing us more to be responsive and responsible.
If I may come in there, Mary Velma, I mean, one issue is that we need a lot more good news stories out of these kinds of regions, and whether that's you know, some of the poorest parts of Africa or conflict-affected areas in the MENA region. There's a lot of there's an overwhelming narrative of doom and gloom, and these places are hopeless, and there's no you know, there's no solution inside. But I think good news stories are good, and locally based solutions and interventions, innovations are also, you know, important to socialize and promote. With Iran, for example, Iran has hosted millions of Afghan refugees for many years, and they've got a very good equitable system for Afghan refugees being able to access primary healthcare services. They've got excellent health coverage, which is probably equal to you know, what they have for their own citizens. But you never hear that kind of story because, you know, Iran is sort of this pariah state at least in the Western press. So, and that kind of example can be shared. That's a best practice example from the MENA region that can be applied in other countries within the MENA region. But again, there's, politics comes into it. Politics plays a role in that kind of story not being shared. And I'm not some personal advocate for Iran or anything, but the issue is that's a good example of something that could have been done but isn't. Karim, you want to come in?
Just briefly, Osman, because I think it's very important to focus on these issues of attacks on healthcare being the new.
Sorry, you're muted, Karim. You've gone mute. Okay.
Okay. So just briefly, the issue of attacks on healthcare is the new norm now. So it's important to report on this issue using different mechanisms. And I think the exploring ways to report attacks on healthcare, not only as numbers, but also as real stories, as something visual that people can synchronize with. I think this is very important. Some of the good examples of local innovations in here in this area was first the tool that, for example, WHO developed, the monitoring violence against healthcare. But again, this was developed locally by WHO office, while the WHO globally, they work something differently. They worked out something differently, which is more standardized, but in the same way is less contextualized and less, human focused, I would say. The other example is using these CCTV videos from all hospitals and health facilities in Syria that have been attacked. I think this was very powerful because they show you how a patient sitting in a hospital, on his or her bed was bombed. So these were very powerful, especially when highlighting the heroic work of health workers in these hospitals. The third issue is the satellite imaging. I think this was very powerful tool to report on attacks on healthcare. I cannot recall the names of two entities, and maybe I will write these in chat when I found them. They were comparing satellite imaging before and after attacks. This was first to confirm, to help in documenting these attacks, but also to visualize the impact on the infrastructure. So I think we need more of these tools that reporting attacks on healthcare should not only be numbers. Thank you.
All right, thanks, Karim. John, you wanted to come in?
Yeah, I mean, the fact of the matter is that healthcare is increasingly political and being politicized as well. Particularly, I mean, you've just talked about Syria, Karim, and I think you all saw how the white helmets eventually became demonized by fake news and fake media coming through for all the good work that they were actually doing, because it's got such an international dimension. So you have the various state and non-state actors actually playing against them and trying to deliberately downplay what they were actually. To also think, again, the thing to do is try and get some push negative news that is coming out of the region. And people are overwhelmed. And we, as an organization, we obviously keep an eye on our bottom line as well. And something that we look at and to think about, how are our donors feeling, our private donors in particular, who are very important to us and a significant part of our funding pool, funding pot. And they are tired to an extent of just the negativity and the non-stop of negativity coming out. So we have to more generally across the region and try to do so in a neutral and fair way.
Mariko?
As I say, there's a lot of fake news out there that is really...
Thanks, John. Mariko?
Okay, first of all, I would like to say one word about a confidential bilateral approach with parties to a conflict, which may not be necessarily understood. So we don't disclose data publicly on each specific incident, mainly to protect our sources and the people who spoke to us. And it's part of a principle of do no harm. Then a confidential dialogue with parties to a conflict aimed to build a relationship of trust to achieve a humanitarian purpose, which is a better protection of healthcare services. So basically what we do is we submit allegations, so with some reference to specific incidents, either verbally or in written or both. And then we ask the relevant party to a conflict to investigate this allegation. And if there are some IHL violations confirmed, then take corrective measures to prevent the recurring of such incident. And this is our approach, which is may not be transparent for other actors sometimes, but we really believe that building a relationship of trust and providing solution like concrete recommendation, training, etc., is very important. Now, there was a question on the issue of how can we be more sensitized, and I put it in the chat box. We published touching stories from people affected both by coronavirus and the conflict in the Middle East and in other contexts, I think. And there was a very touching story of a doctor in Yemen affected by conflict and coronavirus. So it's a very good read how difficult it is to be a doctor in Yemen. And if you have some time, please have a look. Thank you very much.
Thanks, Mariko, and Marie-Velma. Just to answer your point, I think part of it is about triangulation as well. So there's the technical solutions, there's the good news stories that Karim and John were also touching on, but then there's local and regional champions as well. So just the same way you had the founder of the ICRC that you mentioned, you've got your Malala Yousafzais, people like that from within the region who help you triangulate some of the interventions and solutions that are there and who have more of a profile. And then the third element within that is having a funding mechanism to try and take it to the next level and project some of that best practice more regionally in a sense. And just the same way, you can have a billionaire philanthropist like Bill Gates working out of the US. There's plenty of billionaires across the Middle East who could similarly be supporting, efforts in their own region. So there is an element of self-sufficiency that needs to come into play across the Middle East, North Africa region. Anyone else? Any last minute interventions before we take a break?
Very, very quickly. I mean, while we've spoken about breach of international humanitarian law with the targeting and could argue deliberately targeting of health centres and medical facilities, we haven't spoken about accountability for breaches as a mechanism for preventing future breaches. But when we do talk about that, it's extremely difficult for neutral, impartial humanitarians to maintain their neutrality if they're requested to go and provide evidence at the International Criminal Court, for example. And that's a challenge we face at different levels within the humanitarian community.
Yeah, and I hope that's something that's brought up in some of the subsequent sessions, because this issue of accountability and holding people to through the justice system for what's been done is a critical part of why it's important to monitor these kinds of attacks on healthcare. And it might be interesting to hear, how many of the ICC prosecutions have had an element where part of the prosecutor's case has been attacks on healthcare facilities or that element of international humanitarian law dealing specifically with limiting or facilitating access to healthcare. So that'd be a really interesting point. So thank you, everyone. That concludes our first session. I'm sorry we went over a little bit.
Thank you, Osama.
Yeah, Jubin.
Yes, I'm in my office now. I'm going to go back because it's more effective to moderate, so I can see the screen and the chat. I'm going to do this democratically. Of course, there's a democratic deficit in the MENA region. So I guess we're supposed to start the second session at 11:30, but since after the session there's going to be a lunch break also. Does everybody, if you could, would everybody like a 15-minute break now and we start at 11:45, or do you want to continue straight into the next session? I think a break is in order for most of you. If you want to grab a cup of coffee or, do other things. So Okay, okay. So I see a thumbs up from John. And any objections? Yes. Right. You know. Okay, good. So let's break right now, and we'll start the next panel with John Cunliffe and Paul Critchley, Vera Ameli, and Nadal Ode at 11:45. Thank you very much. Thank you to all the speakers. Yeah. Right. Hello, everybody. I hope you're all back from the break. This is session 1, part 2 of healthcare in conflict areas, war, occupation, and sanctions. And we're going to continue. And of course, in this part, we're going to focus more on sanctions. Of course, there are other issues which the speakers, I'm sure, will discuss. Just in terms of, for those of you who were not here at the beginning, my name is Jubin Gudarzi. I'm an associate professor and deputy head of the International Relations Department here at Webster and co-director of the MENA Center for Peace and Development, along with Mary Velma O'Neill. I used to work over an 11-year period with the UN High Commissioner for Refugees as a political advisor. So we're very pleased we have a fine group of speakers. Initially, we were hoping to have Dr. Ruchama Martin, the founder director of Physicians for Human Rights in Israel, with us, but unfortunately she couldn't join us. She dropped out. Perhaps in view of the spike, the recent violence crisis that we had in Israel, Gaza, the Palestinian territories, what happened, or maybe, I don't know, in terms of following the events in Israel right now, in terms of, it seems that the 12-year-long premiership of Benjamin Netanyahu may end, for better or for worse. We shall see the future will hold. So our first speaker is going to be Miss Vera Ameli. She is a doctoral candidate at Oxford University. She studied biochemistry at Brown University in the United States, and then later obtained a master's in science and biomedical sciences from Boston University. And then also she joined Boston University School of Health for a master's program in public health. She is an expert on healthcare. She uses an interdisciplinary approach to understand the political, structural, sociocultural, institutional context of public health problems, interventions, and policies. So her research relies on intersection of medical and social sciences. She focuses a great deal on Iran and the MENA region. And she also investigates the potential of digital health technologies as a programming tool for improving health outcomes. She is currently engaged in a research project also, and has secured funding and built international collaboration across University of Oxford, Tehran University of Medical Sciences, Harvard Medical School, and the Boston School of Public Health. So this is also an important session, I believe. Sanctions are a major impediment to healthcare delivery and also erode healthcare services and capacities in the Middle East. This is something that I myself have felt very strongly about. I remember the 1990s when there was the 13-year-long sanctions against Iraq and what it did to Iraq, and we still see the legacy of that in Iraq, in addition to the fact that we have 35 years of Ba'athist dictatorship, 3 devastating wars, and then the invasion and occupation of 2003. And of course, also as an Iranian and having visited Iran over the past several years, in terms of the sanctions, witnessed firsthand how sanctions have a detrimental impact on people, on civil society, on healthcare. But I will hand over now to Vera, and then we will continue. So Vera, the floor is yours. So thank you for being with us.
Thank you very much for that introduction, and thank you for having us all at Webster University. I would like to first acknowledge that as a global health researcher, I'm often confronted with this difference of worldview in discussions of international politics versus that of international health. And the fundamental ontological discrepancy seems to be lying in the unit of analysis, which is the human population, position for health policy workers and academics versus the nation state for politicians and scholars of international relations. So it's not surprising that the two worlds of expertise seldom engage with one another, and it is genuinely a pleasure because of that to be here today within the International Relations Department of Webster University. And I hope that we can have a discussion that would align priorities for health and human security with that of state security, or bridging a gap between what is often referred to as soft and hard security. So health policy is usually implemented within the vertical governmental structures inside borders, of course, while geopolitical decision-making is placed within this horizontal anarchic system between borders. However, if living through this pandemic has taught us one lesson, it is the need for aligning these vulnerabilities and priorities to improve population health, well-being, and health security. And with this view, when we think of war, for example, as a tool within geopolitical decision-making, I think there's an echo because maybe someone's microphone is off. Sorry.
If you could all mute your microphones, please. Make sure your microphones are off. Thank you.
Thank you. So when we think of war, we usually think of soldiers in uniforms, guns, tanks, dust, smoke. However, the list does not include aggressively waging an economic war, proudly calling it maximum pressure campaign on a country, or blocking medicines and medical equipment to whole populations of countries, even during a global pandemic. As I'm speaking today about the impact of sanctions on Iran, however, I think it is important to first give an overview of the health structure and institutions and the history of their development, particularly after the revolution, and how these institutions have fared under sanctions. So first, this background takes us to in the aftermath of the 1979 revolution, where the country was soon experiencing 8 years of war with Iraq, and it was a very unbalanced situation where the international community was not really in any way assisting Iran, really. And so the reforms that were made to the health system were made during times of crisis, conflict, and low resources. But these reforms were largely based on a community-driven health model and increased access to health services across Iran, which was first initiated through this vast network of community health workers and primary healthcare centers that were instituted within villages and all cities or all provinces inside Iran. And this system had a pyramidal structure with an efficient referral system, and its achievements were quite remarkable. For example, during war, achieving universal immunization, dramatic reductions in maternal and infant mortality rates, which were by international standards really high, like high reductions, and effective family planning and population control were among the gains, and this included the most rapid decline in birth rates in world history, actually, which was from an average to 7 to 2 children per mother by the end of the century. So this community-driven approach was really the key to success, but also reflected the Islamic revolution's sort of ideology of rejecting both political and cultural imperialism. So it really relied on community cultural norms and religious and other social norms to build health programs. So the health interventions that were identified locally and were based on observed successes and shared norms, as I mentioned. And instead of emulating international best practice models, the community-driven approach sort of diverted from this strategy and really was able to actually gain more effective approaches, more effective outcomes, which is quite in line with today's need or discussions of more participatory and culturally sensitive approaches to public health, and also this recent emphasis on decolonizing global health, which includes sort of taking interventions from a global north country and implementing it within another country without really considering the health needs of that population. So this sort of model was really implemented from the beginning of the revolution in Iran, and this really drove successful health outcomes. And also access to education were expanded. And so the health system currently includes about 150,000 physicians. And in terms of like coronavirus cases, when we were thinking the average bed per 1,000 people is some like a little bit above the global average. In terms of research production, is actually doing quite well. It's 16th in the world, but again, there are insufficiencies internally as well. For example, there is a huge power structure with physician lobby within the political establishment, which sort of increases or reduces the medical seats so that there is less physicians basically, and physicians can profit from this. So these are recent discussions that are happening within Iranian election right now as well. And especially as a result of sanctions, I think there is more and more sort of inward-looking changes being discussed. It is important, though, that all of Iran's health gains have been made in the teeth of one of the largest and most vicious, I would say, sanctions regime in history. I think it is important to acknowledge that these sanctions have been also largely illegal. And it is important to recall the history of sanctions on Iran, which were first imposed by Carter, and then continued by Reagan, Bush Sr., Clinton, Bush Jr., and then greatly intensified by Obama, and then later further escalated by Trump. So contrary to popular belief, the JCPOA or the nuclear deal did not really lift sanctions on Iran in total. It merely suspended those which the White House had imposed via the UN, and leaving intact those imposed by the US alone, which continued in force and continues today, even after Biden is in office. And the Trump administration sanctions were openly designed to bring down the government of Iran, and to do that by sort of putting pressure on the health and well-being of the population so that they would be driven to a point to themselves overthrow the government for Washington to achieve its desired outcome. And I think it's, again, important to mention this because sanctions are often looked at as this like sort of tool for, geopolitical decision-making or geopolitical gains, but it's important to recognize that the goal of sanctions is actually to put pressure on the health and well-being of the population. So as community of global health researchers, I really think we cannot remain neutral in terms of how these decisions are made and how they're impacting the health of populations. It is important to mention that despite the European countries, France, Britain, and Germany, not being completely in line with the US decisions, but of course they really just went along with it. And even the channels that were created to circumvent US sanctions, such as Instex, were not eventually really successful. And so the impact of this blockade on the health system, I would say, falls into three main categories. The first one is that sanctions block, obviously, most financial transactions that are required by Iran for its general trading. And these include medical purchases, despite the so-called exemptions for humanitarian goods. And secondly, sanctions interrupt the supply chains of domestic production, as well as even when you have locally produced medications and equipment, these often do rely on some inputs from multiple manufacturers in various parts of the world. And the absence of even one input or one ingredient, such as like a pill packaging, can really bring production of internal production to a halt as well. Here I would give some examples in line of these two impacts. So for example, right now, Iran does produce 97%, as I mentioned, of medicines that it needs by dosage. Yet this 3% of demand include vital medication for children and vulnerable patients with rare or advanced diseases. And access to these are the ones that are really being harmed. For example, when we look at the case of the butterfly disease or epidermolysis bullosa, EB, among children, which is a genetic disorder. And the European pharmaceutical company Molnil Healthcare basically stopped delivering Mepilex, which is the only treatment that is a vital treatment for treating the chronic and acute and severe skin lesions and wounds that occur in these children and can lead to death. However, just fearing secondary American sanctions, this company just stopped providing these medications to Iran, despite calls despite supposedly humanitarian trade not being affected by sanctions. And for example, in terms of HIV, which is my field, Iran imports antiretroviral therapy from India, generic medication from India. Again, this wouldn't fall under the 97% of need by dosage because it is quite a low prevalent case in Iran. Like Iran is one of the low prevalent settings for HIV. However, what does happen is that when you are receiving antiretroviral therapy, you do need to get tested at least every 6 months to check that your viral load is suppressed. However, the viral load testing kits have not been able to reach Iran as easily. And even though within the guidelines of providing universal access to HIV treatment, you really should be offering free viral load testing as well. And Iran has had to sort of lower or extend the time frame that it can provide these tests to the HIV people, to the population of people living with HIV in Iran. And I think this is particularly important, especially when now we are thinking more in terms of the consequences of global pandemics. It is important to recognize that this does have regional impacts as well. And MENA region in general, despite very low prevalence of HIV by global standards, is the only remaining region in the world that has an increasing rate of new HIV infections, and it still has increasing AIDS-related mortality. So when we think about this, this is one of the insecurities of health within the region. So it is really important to make sure that something that is not only life-threatening, but also it is an infectious disease and can really disrupt the region long-term. What are the impacts of sanctions? Like, how are the sanctions really putting pressure on being able to manage and control HIV in the region? I can provide you with percentages and numbers later if you were interested during the discussion. And the third, and I would say perhaps most severe impact of sanctions on the health system is actually through reducing purchasing power across the whole economy. And sanctions hits obviously healthcare providers and consumers alike. And this contraction of the economy causes rapid rise in inflation and downturns or reduces or slashes the government's revenues really, which then obviously strains the universal health insurance program and has also increased the cost of healthcare itself by nearly 20% because of the rising inflation, or even more than 20% if we consider the increases in price that happened in the past year. So to protect patients from this sort of market instability, then the Ministry of Health of Iran comes in and tries to regulate drug prices. And as a result of pharmaceutical companies also being under pressure and having little to no margin to overcome the burdens of inflations and price fluctuations, the bureaucratic price controls create sort of like a condition of scarcity, which then typically leads to a hoarding behavior and then black market profiteering and obviously corruption issues. So the result is further shortages of drugs for all Iranians, and especially for working people who cannot afford this exorbitant black market prices. These are all important, and I think with regards to the coronavirus pandemic, I think it's also important to recognize then that despite all of these pressures on Iran, and in addition to that, we also had the drop in oil prices during the pandemic, which dropped to almost a half, were all justified. And when Iran asked for a request for the first time in its history since the institution of the Islamic Republic since 60 years really, an IMF loan, this sort of under US pressure, this request was not processed, or really like no real answers were received in response. And I think, again, this is important as a global health community to consider, because we really are trying to, implement policies and have fundings and have approaches that would save lives. Yet when we see that there are pressures that we can advocate for the geopolitical community to sort of revise their decisions, especially when it's something for like asking a loan. So I guess I cannot remain unbiased in this, and I can't really, to me, really a position of neutrality within public health is kind of questionable, because politics and geopolitics really cost lives, and I think it's our responsibility to think about this a bit more sensitively. However, on the other hand, given the history of the 40 years of development of Iran without any foreign aid, and after a traumatic 8 years of war, Iran's post-revolutionary policies have largely been driven by a desire or really like policies that would reach self-sufficiency. And these have made great strides in the supply of affordable medicine and equipment. And now we also see the development of vaccines, that Iran is one of the, despite all of this sanction and pressure, is one of the only countries, or one of the handful of countries in the world that is really producing multiple vaccines. And hopefully, I think by next month, we will start using internal vaccines to vaccinate against COVID. So this sort of is, although the history of vaccine production in Iran has 100 years, it goes 100 years back, but it really does point to the fact that sanctions, with all of its harms to the population, they also really force nations to develop these sort of self-sufficient and resistant means and build resilience within multiple sectors in their countries. And this has been sort of promulgated under this discourse of resistance economy, and that has really been the main discourse for 10 years now within Iran. And especially this year in terms of elections, like all of the discussion is around the economy and how to make sure that we would be resilient against sanctions. So even I want to say to the geopolitical community, I don't think that sanctions would have the impact that if the goal is to put pressure on a government and sort of on the people, it really isn't going to have that impact, because under pressure, people would find ways to resist and become more resilient. There is short-term cost on Iran and a high short-term cost on the Iranian people, ordinary people. But I think ultimately the state is going to overcome this because of the human capacities, especially, that exist in Iran, with a young, educated workforce that can really build up the service industry, but also manufacturing. And also in terms of, for example, internal issues of mismanagement and corruption, because of sanctions, these issues are now more centered in the discussions on Iran within the presidential election campaigns now. And I think, I mean, these are all really silver linings. I'm not sure if I still have time, but I can give some examples of the specific.
I think, yeah, thank you, Vera. I think if it's okay with you, we'll just leave the rest afterwards. You have a lot of food for thought, so we can, if that's okay, yeah. So we can go on to the next speaker.
Yes. Thank you for the time.
Okay. Well, thank you very much, Vera. You provided a lot of food for thought, and there's a few things that I would like to say, but I want to definitely get through and give the speakers a chance and then get to the Q&A and not cutting too much into lunchtime. So thank you very much. We're now going to have our two speakers from Action contre la Femme. We're going to have Paul Critchley and John Cunliffe, and then we're going to have Nidal Ode from the IOM. So with regard to John Cunliffe, he briefly introduced himself. He did a stint in the British military and then later studied nursing at the Tropical School of Medicine in Liverpool. And he's been in the humanitarian area working since the 1990s. He operated a hospital in the Democratic Republic of Congo, and he's been involved in humanitarian emergencies in many countries, including Somalia, Syria, Iraq, South Sudan, Burundi, Indonesia, Yemen, Turkey, Jordan, and many others. And over the last 12 years, he's been based in the Middle East, and he's directed action against hunger's operations there. And supervises the national teams in Libya, Iraq, Yemen, and Tunisia in terms of trying to reach 1 million children and women with aid. And his colleague, Paul Critchley, who also, some of you met earlier, has been also in the humanitarian field since 1999. And over the past 12 years, he's worked in different countries such as Kosovo, India, Afghanistan, Jordan, Yemen, Somalia, Sudan, South Sudan, Bangladesh, worked initially for different organizations such as MSF, ECHO, IOM, and he's, since spring of last year, Paul Critchley is Action Against Hunger's country director in Iraq. So with no further ado, I'll give John and Paul the floor. So it could like around 15, 20 minutes if possible, but anyway, we can continue then. Thank you very much.
Thanks very much, Julian, for the introductions as well. Paul is going to start, and he's going to take a deep look at what the longer term impact of sanctions actually are by using Iraq really as a case example. I think we'll touch again on some of the points of Vera, and I will certainly touch on some of the points of Vera in the operational impact that it has on organizations trying to work in these countries. So without further ado, Paul, over to you.
Thank you very much. I'll just share my screen. Right, healthcare and sanctions. As you know, Iraq was put under sanctions in 1990. And when we think about sanctions, it's important to understand what they actually do. I mean, this quote that I found from Woodrow Wilson is quite useful and interesting, even if it's dated. A nation that is boycotted is a nation that is in sight of surrender. Applying this economic, peaceful, deadly remedy, and there will be no need for force. It is a terrible remedy. It does not cost a life outside the nation boycotted, but it brings pressure upon the nation, which in my judgment, no modern nation could resist. Well, modern nations do resist it. It's the people within those nations that suffer. And I think this is not, it is a form of violence, as one of our speakers earlier alluded to. And we must think of this as, it's conflict by other means. Now, because sanctions, when imposed in peacetime, don't break international humanitarian law, people's right to neutral and impartial humanitarian action, well, people don't have that right in a non-conflict setting. However, you could argue that, for example, the Convention on the Rights of the Child is breached when children don't get access to healthcare because the state can't provide access or they can't gain access to healthcare due to sanctions. While individual state sanctions, for example, in the case of Iran, have been imposed bilaterally for a long time, UN sanctions weren't used that much until 1990. I mean, prior to Iraq being put under sanctions, only Rhodesia and South Africa were put under sanctions by the United Nations. But between 1990 and 1999, 10 different sanction resolutions were voted on by the Security Council, either putting or amending sanctions on Iraq. Now, prior to that, Iraq had one of the best health systems in the Middle East, and people would come to Iraq for medical tourism to gain access to good quality healthcare. And infant mortality rates had been dropping consistently from the 70s onwards, really. However, because of the structure of the Iraqi healthcare system, and the structure of the economy, the healthcare system was vulnerable to sanctions. Its system was focused on secondary and tertiary care in technically advanced hospital facilities with a weak public health system. Also, the health information system within Iraq was weak and still is. And being predominantly relying on imports and with little in the way of domestic production, sanctions hit it hard. And also, Iraq had imported medical expertise. It was a good place to come and work if you're a medical professional. And so it brought in and relied on a lot of expatriate health professionals. The impacts of sanctions. On the 3rd of April 1991, the UN did allow the import of medicines. However, 90% of medicines that were imported in Iraq prior to the sanctions were not imported after Iraq was allowed to bring in medical equipment and drugs. And because of Western donors' dislike of the government, only 5% of the requests for humanitarian funding to provide medical materials, drugs, equipment to Iraq were actually funded by donors. The reductions on health staff salaries had a disastrous effect with a brain drain that other countries benefited from. When I was working with MSF, our chief surgical advisor was an exceptional Iraqi surgeon who had spent 20 years working in New Zealand before coming to Médecins Sans Frontières. The medical equipment couldn't be maintained because equipment couldn't be brought in, it couldn't be paid for. The decline in the public health infrastructure. Hospitals don't work if they don't have electricity, if the sanitation systems can't be maintained, if potable water is not accessible. This all has a negative effect on the system. And also Iraq suffered from, they couldn't even bring in modern textbooks for teaching medical students. So the teaching and the ability to keep up with developments in medical science were massively hampered. Now, the effect of the impact of the reduction on GDP, as our colleague from Iran highlighted, in Iraq, GDP dropped by 75% over a 3-year period. Now, this had an increase in effect of increasing the disparity between the rich and the poor. The rural poor, who were not served well in a health system that had little in the way of public health focus, couldn't gain access to healthcare. And as the healthcare systems degraded, user rates of the remaining healthcare systems reduced as well. And again, if your water system, your sanitation system isn't maintained and is starting to break down, then we see an increase in vector-borne diseases. Now, with the HIS system breaking down or not being good in the first place, and a lot of political manipulation by the Iraqi government, the assessments of the impact of sanctions, the data is not brilliant for Iraq. However, you can see, instance of malaria, Kala-Azar, and other vector-borne diseases did increase. UNICEF did do a good statistically accurate report, and they highlighted that rates of chronic malnutrition increased from 18.7 to 32% in South Central Iraq between 91 and 96. In the same period, there was a disastrous impact on the under 5 mortality rate. Prior to sanctions, Iraq's mortality rate had dropped to 50, and with the sanctions, it increased to 125, which led to an excessive mortality, of children of 300,000 at least. Assuming that, the figure of infant mortality prior to sanctions, if we assume that the improvement of infant mortality would have continued, then that figure of 300,000 dead children would massively increase. Now, given that many countries under sanctions are not exceptionally open societies in some ways, there are other ways to assess, to have a parallel view of the effect of sanctions. If you think of sanctions as reducing access to fund healthcare and fund systems that support people's well-being. If we look at countries that have undergone IMF structural adjustment policies, we see across the board increases in malnutrition, increases in maternal, infant, under 5 mortality rates, decreases in vaccination coverage, and increases in the prevalence of vector-borne diseases and a loss of medical health professionals. John, over to you.
Thanks very much, Paul. If you could just slip down to the next slide, please. And the next. Yeah, so I'm just going to talk briefly about what the challenges are practically. And Vera's touched a little bit on some of these things, but really these are the practical challenges that the UN agencies, the NGOs, and anybody else who wants to actually go and work in a sanctioned country actually need to face. I mean, the first thing is obviously there is increased needs, as has been outlined already by both Paul and Vera, in the countries that we need to go to. So normally a country that's not sanctioned in war would be in a slightly better place than a country that is sanctioned in war. And I think that's a real reality, particularly as time goes on. One of the points that Vera mentioned was just around the fact that, difficulties in creating medical supplies, prices increasing. I wanted just to add that one of the things that happens as well is that the medical staff themselves, as the economy goes down, what we tend to find is that they are less and less motivated because their salary is less and less meaningful, and they have to find alternative means of income. So they're not working in the same way as they would normally do, particularly as time goes on and they themselves start to get worn down, all of which is really, really understandable. So bigger needs, more difficult to work in these places in general with the staff that are there and support them. And a lot of suspicion as well about organizations coming into these countries. So, I mean, I've worked with American NGOs, for example, very difficult to work in countries that are under sanction by the US. One of the first things you have to do to work in a country is get the relevant licenses to actually work inside of a sanctioned country. From the US side, with regards to Syria and Iran, these are what are called OFAC licenses, the Office of Foreign Asset Control. Before we can actually put a foot in a country, we need to make sure we've got the licenses in place. Now, if that's an urgent program, that's not an easy thing to do. It's also a very expensive thing to actually do, is to obtain these licenses that go through various departments of the United States government before they actually get signed off. And you really have to list every single item. So if you're buying a laptop to take into Iran, you have to put down the serial number, the make, the model, etc., so that everybody is aware of what the laptop is in the US government before you take it into Iran, and the same when you actually bring it out. The same applies for staffing. It's very difficult to bring in the right staffing. I've had US staff who've worked for me who've had very difficult times once they've left countries that have been under sanction from the US government, making it incredibly difficult now to employ well-qualified American doctors, nurses, etc., to go and work in these countries. And they are an excellent pool of well-qualified staff, and they have the additional problem of being seen many times as being a little bit suspicious when they arrive in these countries because they're coming from a country that's put sanctions on them. Next slide, please, Paul. Limited number of commercial partners. This actually goes back to the Iran dilemma quite a lot. It is not just the fact that we have to get the licenses. Even when we get the licenses to work in these countries, people still do not want to work with us because of the risks that it involves with particularly the US government. So if you look at the banking sector, for example, you cannot actually very easily transfer money over to Iran because of the fact that a number of the banks that we're working with will have offices in the United States, and they risk having problems themselves if they actually start to work with us, even though we have a license. And they're very, very worried and very nervy about working with us in these types of countries. The other point is, when you're actually in the country, what it is that you can use and what you can't use. So one example that's just come up is SyriaTel, which is the mobile phone provider in Syria at the moment. We don't have a license to work with them at this time, so we should not be using the mobile telephone network inside of Syria. We shouldn't be using the national airline inside of Syria because there's no license to actually work with them either. Even on an individual basis, if you take your mobile phone into the country, as the software that is running out of that mobile phone is Android based or Apple based, which is an American product, you shouldn't even be walking into Iran or into Syria with your mobile phone normally as well, because it's got 80% of its products are American. So if you're setting up and establishing an office in somewhere like Iran or Syria, it's extremely difficult. A lot of the things that we're relying on now. So let's look at what we're using now. I was trying to have a conference call 4 days ago, Monday, 3 days ago, with colleagues in Iran, and there was more than 6 of us. So we tried to see if we could set up a Zoom call. Zoom is banned by Zoom in Iran because they are an American company and they can't actually operate inside of Iran. So very, very complicated, even things like software and commercial licenses in some of these countries. Obviously, that leads to longer supply pipelines to bring things into the country. And it also means that we have difficulties as well bringing our staff in and out, which means it's hard to get people who want to go and work in these countries just because of the fact that they just never know when they're going to get home sometimes, when they're going to be able to see their families. So it's difficult to bring people in and out. Increased costs associated with all of that, the need to use alternative systems and the delays to implementation of our programs, all of which means that we have increased costs. The bottom line of that is that we are not delivering programs as effectively as we would like to our beneficiaries, and we're losing beneficiaries. We're not being able to reach as many people as we would like to with the money that we've actually got. More expensive programming, less money for beneficiaries. One of the big things that's coming through associated with sanctioned countries, and it's a major cause of concern for all NGOs at the moment, is the screening that is required, the counter-terrorism requirements that are coming through at the moment. And that's not just US, it's also from the European authorities. They're increasingly requesting that we screen everybody. In the past, we used to screen, and we accepted to do that, suppliers. So we made sure that people were not on any lists of prohibited individuals from the UN list or the US list or the European list. But in sanctioned countries, it gets even more complicated. They're actually starting to ask that we screen our beneficiaries, which is pretty much a red line, as you can imagine, for an independent NGO who works along the same principles of the Red Cross of humanity, transparency, neutrality, and independence. But it does, again, then limit the number of donors you can actually work with to get funding to go into these countries. So in Iran, for example, you'll find that there's a lot of Scandinavian funding, fortunately, but not a lot of other funding that normally would come from traditional donors that we would work with there. The legal risks are there for us as well. We've seen a recent example of a Norwegian NGO actually who was also taking US funding for other countries who were fined, I think it was nearly $5 million for working in both Palestine and Iran without correctly informing the US government that they were doing this. And they'd signed a grant with the US government. And there's a document when you sign a grant with the US government called Certificates and Assurances, and hidden in there is a little statement that says, if you spend any money, even your own privately raised money, in a country that is sanctioned by the US government, then you are going against the agreement that you actually have with us. So big financial and legal risks associated with working in sanctioned countries. It's very easy to get it wrong. A lot of things have happened to NGOs, such as this Norwegian NGO in the past, and will continue to happen. It's a risk that we all continue to take, but at any stage, we're well aware that there could be problems. So not only is it difficult for the country, but it's also difficult for the UN and the NGOs to actually work inside of sanctioned countries. I'll leave it there.
Thank you very much, Paul and John, for those very enlightening presentations. Very, very informative. I hope we'll have time during Q&A and discussion to discuss these further. I certainly want to pick up on a few of them, but I'd like to continue now with our next speaker in this session. We are very pleased to have Dr. Nidal Ode from the International Organization of Migration. We're going to have a second person also from the IOM. And also, I just wanted to take this opportunity to thank John Cunliffe and all his colleagues from Action contre la Faim, because they're major participant in today's event. They're going to be in 3 of the 4 sessions. So I'm deeply, and my colleagues were deeply thankful to you. And also with regard to the IOM, we also have 2 speakers, so we're very glad. Dr. Nidal Ode is a medical doctor and also is an expert in public health. He worked between 2000 and 2003 as the head of the public health department in Jordan at Karak, the Ministry of Health, and later he joined the IOM in March 2003 when he had the Iraq war and as migration health coordinator at the Iraq-Jordan border. And later he served in a managerial capacity with the IOM between 2008 and 14 and led the emergency health response subsequent in Jordan, subsequent to the outbreak of the crisis in Syria between 2011-14. And he was also Iraq MHU head for emergency response and led the IOM health team in Iraq during the campaign to basically dislodge of ISIS, Daesh from Mosul between 2017-18. So he's supervised implementation of GF projects in Iraq between 2017 and 19, and he's currently the Yemen senior program coordinator for the IOM since 2019 till now. So Yemen, of course, is an important country. So with no further ado, thank you very much for being with us, Dr. Ode. The floor is yours.
Thank you, sir. Thank you, Jovan, and very happy to be with you, and thanks for this opportunity to share our experience in Yemen and other countries, and also to hear from other colleagues their understanding about the situation in Yemen and other countries. And also I'm happy also Dr. Sami has, and I'm happy that many of the points that been in my presentation been discussed with him by him. So I'm just going to focus on points that I think it's good to focus on, and maybe we'll open a way for our discussion. Let me just share my presentation. So, can you see my? Yes. Okay. Can you see my slides? No.
Not yet. Yes. Okay. Oh, before. Yeah.
Okay. Let me trying again. Okay.
Not yet.
Not.
Using the share screen icon?
Yes.
Okay.
Can you see it now? No.
I can't see it. Can anybody else see it?
Is it shared now?
I'm happy to share your slides if you wish, and you just let
Yes.
me know when you want to move on.
Did you
Yes,
hear
please.
that, Nadal?
Yes. Yes, please.
Okay.
Because I don't know. Thank you.
Thanks, Sylvia. Yeah.
Okay. So I'll go fast, as I mentioned, because many of okay, second slide, please. Let's go with the definition. Yes. Actually, looking to the health actors' challenges in the conflict areas, I believe that many of health facilities and health-related infrastructure are usually damaged and destroyed. And I saw this very well in Iraq, in Mosul. And this is also coming with shortage of medications, actually interruption of the medical supplies by the central or the governorate to areas affected by the conflict. And of course, as mentioned also by many of the colleagues, that usually health personnel is a problem, and they are replaying the places of conflict because of safety. And also, as mentioned by John, that many expatriates in Iraq, it was the same in Yemen. And this is really strange. When I came to Yemen, I found that before 2015, they were saying that many medical professionals were coming from Middle Asia, working in different areas of Yemen, including the periphery areas, difficult environment. But unfortunately, after 2015, with these safety issues, with the conflict and the payment, funding, many of them left. So, second slide, please. So, armed conflict really creating so much difficult for accessing the population in need by health workers, and also for the population themselves to access the health service, the health facilities. And this is still in Yemen, can be seen, especially with the last year and this year escalating of the conflict in many locations, in new locations, in the West Coast and in Marib, in Taz, which means that really this is a big issue. Even this is depriving the cluster and the authorities to understand the situation, the needs on ground due to this inaccessibility. Of course, there are occasions when I am covering many of the governorates in the north that, let's say, military forces were occupying some of the health facilities, controlling some units and controlling accessibility of the health workers to come to these facilities. So this is also a very, it's the militarization militarization, I can say, of health facilities at the different locations near, especially to the front line. Another challenge that was very also seen, especially last quarter of the last year and this year, it is the funding issue and the short term of funding, some conditions coming from states and I can say some donors condition, and this is also limited many agencies to, or let's say oblige them to downsize, to withdraw from many locations where vulnerable population are in big need. Next slide, please. This is maybe an old map, but this color showing the different authorities, and I can say to you more colors are on ground now, especially in the West Coast, and many military troops, unfortunately, groups are occupying districts and taking full control on many of the health facilities areas, which is also something bring more challenges for health providers to work in Yemen. We are facing this more now in some areas of Maghreb, where IOM had a big projects and health interventions. The same now in the West Coast, Taz especially, and south of Hodeidah. This is something that we are facing, and I believe all health actors are facing as well. Next slide, please. Just sharing with you this photo, which is the migrants in Yemen. I believe migrants in Yemen, with hundreds of thousands of migrants coming in Yemen to pass to Saudi, especially in the past it was more in the West Coast, from the West Coast entries, and now it is more from the southern coast. These migrants from Ethiopia, from Somalia, from other African country, actually became like instead of a transit, Yemen to be transit for them, they became like it's becoming a place for them to work and to settle. Many of them spend months and years in Yemen, and this is also overwhelming the health system in Yemen. And of course, this is creating some issues in some locations, especially with the big numbers. We are talking about Shabwa, we are talking about Lahaj, the southern governorate, we are talking also about Al Bayda, even in Saada and Al Jawf, the northern, where these migrants also are passing by when they are coming back or when they are trying to enter Saudi. Of course, this model of health access for the people here, most of the our work is going through the model of the mobile teams and mobile clinics, and this is something we need also to think about, and I will emphasize about the facilities issue. Next slide, please. Can we go? This one, can we? I think this is what mentioned by Dr. Sami. The same, please, pass. Yes, maybe this is also important to mention some points here. We can say that Yemen, not like Iraq, it's really the other way. Iraq was very strong. Actually, many people in the region, as mentioned by the speaker, were going to Iraq to get health service. And I remember that some of Iraqis that I examined in my clinic when I was in the health assessment program were presenting to me some document showing that they were having medical service from UK. They were sent by the government to go for cardiac catheterization in UK and other surgical intervention, which means Iraq was very different from the situation on Yemen. Yes, it was after this 2003, there was a deterioration, a big deterioration. In Yemen's side, it is the other way, actually. It is the conflict has brought the country more and more, looking to the malnutrition that was existed before. Very high prevalence of malnutrition. It was almost 50%. We mentioned the reports of WHO, they were having this malnutrition ahead of 2015. And also considering the infrastructure, the weak infrastructure in Yemen before the conflict. And with this conflict, it is destroying more and more of their resources. Of course, this is something to be considered. And this is also make it difficult for all health workers or all health actors to try to bring up the health service to the level, to the standard level that to be accepted, considering that water is a big problem, electricity supply is a big problem. So like in one of our big project in coordination and in partnership with WHO, we go for this MSP. We were going for A to Z support for health facilities. We go for rehabilitation and sometimes very big rehabilitation project, water, electricity, incentives for tens or hundreds of workers. We go for even provision of generators, medical equipment. Many of these facilities, unfortunately, were, I can say, looted or missed their items, medical items, medications. So from A to Z, this is also a huge cost for any support. And this is also putting all health actors in a point where to prioritize their support, looking for the most important need, and also looking for the map of the health facility in the district or in the governorate to decrease the cost in the location of intervention to be able to continue and to reach. Of course, as mentioned by colleague Sami, that almost half, 50% of the health facility were destroyed partially or totally, or because of the security issue, many were left without staffing. Next slide, please. Yes, as highlighted here, we can say that more or less 30,000 dedicated local health workers been out of their salaries since 2016. And this is issue that been adopted by the cluster, agree on a scale rate to be paid, plus also considering areas where it is near to the front line, difficult environment of work, to increase the incentives rate, and also considering the female gender in the medical staff, where you need an OB-GYN, a doctor, a nurse, midwives, and etc., which need also more. It apply more cost for the medical cost of support. Of course, considering Yemen different from the most of the regional country, that it's more infectious. You have cholera, you have diphtheria, you have malaria, you have dengue, TB. It is really something that also need to be looked after, because this is a different also burden in Yemen. It is like a transit area between Africa and Asia and Middle East. Please, next. So COVID, it's considered like an emergency with the emergency, the existed emergency, and this has really had a great, especially that we found that since last year there was neglect from authority and from community population that there is COVID. Most people do not accept that there is a COVID, or if they accept there is COVID, they will think this is not something to consider compared to the problems and the issues they are facing because of the conflict, because of the economical situation, because of the many outbreaks that happened in the last few years. Next, please. We had mentioned this. Can we go for the next, please? I think I remember that 2015, in the first few months of the conflict, 25% of the kidney dialysis cases died. Of course, this is to understand how electricity supply was severely affected and how much suffering these chronic cases were having. And many of the specialty, as I mentioned, with the expatriate left the country, they were not finding the specialized services to be available in many locations. So many of them were obliged to travel to other locations, other governorate, where also the safety and the checkpoints and the problems facing many of them. Next, please. Of course, we have to consider this lack of medication and supplies. I will add here a point which is very important in Yemen, and I saw it in Iraq, that the market, local market, the private market was full with non-qualified items, medications which is coming from black market with no quality standard at all. And this is now in Yemen. Unfortunately, also the cost of such humble standard of quality of medication supply still high, considering the situation. And I'm not saying sanction, but the blockade that applied in the port seas and the seas and the airports, the seaports and the airports. Yes. Can we go for the next, please? This is maybe one of the last slide. I will just say it. This is something that forced many of the actors, health providers especially, to transfer to the south due to the very long period that taken by the authorities to clear the starting of projects implementation, and also to even for visits, for monitoring, for assessment. It took many weeks to get and sometimes declined by the authority to give international or national health workers or experts to visit the location where they are planning to support. Another issue, when we are getting something from Aden and we want to send it to the north, we have this double tax payment, unfortunately imposed by the checkpoints and authorities, which you cannot find solution for that, unfortunate. Also, we have many cases of visa issuance refusal or delays. We have, as I mentioned, restriction of movement, even for delivery of items. Many of the projects we were late, we were asking for no-cost extension because of the delay to get the approval from the authorities to deliver the items, the equipment, the medical supplies, the medications, etc. Even this is applied to the national staff movement, sometimes going from governorate to other one. Please, next. I had mentioned this earlier. Yes, and this is very true, unfortunately. Yes, thank God it was not, I can say not high percentage, but it was happening in some locations, especially at the beginning, near to the frontline districts. Next, please. Okay, thank you very much. That's all from my side. Thank you, sir. You have mute.
Yeah, thank you, Dr. Oda, for your presentation. Going into complementing Samuel Sebi's presentation on Yemen, also providing a bit greater detail, delving further into the tragedy which has befallen Yemen. In terms of there, of course, it's a combination of domestic internal weaknesses from prior to the conflict, since Yemen was quite underdeveloped even by the standards of the Middle East, the MENA region, and then of course the war, the intervention, and of course sanctions. I do want to give, we're almost near 1 o'clock, but I do want to have at least a good 15 minutes or so for questions. I just want to make one or two quick remarks about the earlier presentations also. As one of the speakers said, sanctions are a form of violence. There are no big explosions or whatever that you see on CNN or BBC News, but it basically gradually, tears apart the fabric of a society, strips people of their humanity, their dignity. They lose their jobs. There's violence at home, domestic violence. There's substance abuse, alcohol abuse, suicide. Young girls, and I've seen it myself, sell themselves on the street. And of course, this affects healthcare. I remember John mentioned OFAC, the Office of Foreign Asset Control in the US. I remember talking to a very distinguished, very dynamic business lady in Iran who had her own company which imported medical equipment and medicine. And during the Obama sanctions, she said that it took a good 6 months or so to try to get authorization from OFAC to import medical equipment into Iran. And as you know, 6 months can be a very long period if you have certain illnesses and you need access to certain medical treatments and all that. And as also Paul Critchley and John also mentioned, and Vera mentioned, there was never really sanctions lifting, there was sanctions relief. So many banks, as you all mentioned, refused to, accept payment transactions for the import of medical supplies into Iran, et cetera, et cetera. I witnessed this personally with regard to my late mother a few years ago before she passed away. And I think also one thing is a lot of people give Obama a lot of credit. Some of you may remember during the second debate when he was running for a re-election in his foreign policy debate with Mitt Romney, and I quote, he said with great pride, Romney was criticizing him, "We have imposed the most crippling sanctions on Iran in history." So I'm not going to get into Trump, but few observations, and of course, Iraq is a huge tragedy there in terms of what happened during the sanctions and before that with the bombing of the bombing during the war, in which is Iraq was basically backed into the pre-industrial age when you bomb water purification facilities, electricity, power plants, et cetera, So I'll open up to questions and comments. So let's try to spend like a good 15 minutes or so, but I'm flexible. Any questions? I guess people
more something. I'm more throwing something into to more discuss. If in conflicts, people have the right to neutral, impartial humanitarian support if they need it. Surely a country that has sanctions imposed on it by the United Nations, when that country then falls under international humanitarian law, those sanctions, if they prevent access to healthcare, should be lifted.
Does anybody want to comment on that? Any comments? Anybody? Any one of our speakers, Vera, John?
I think that is a very important point. However, I want to just emphasize something else that was, I think, mentioned by Paul, which is this drainage of resources, especially human resources and medical personnel, and this pressure that is put on the medical community themselves because of sanctions when they are working in this environment of uncertainty, increasing cost of life, and obviously considering the option of migration much more seriously. And I think that this is really an issue that is only recently, I have heard, being discussed within the academic discourse of, again, decolonizing global health, because it really does qualify as a neo-colonial sort of way of a practice where you pressure a country, you sanction a country, and then you sort of benefit from the human resources that then immigrate to your country. And I think that when all of these costs and then the benefits that are gained on the international pressure implementer party should really be considered when we think about the cost of sanctions. I think that there should be retribution or some sort of price paid by the countries that are gaining benefits from the human resources of these other countries. In the case of Iran, for example, and most times, this is not just even sanctioned countries, this happens in all of global South, where countries put so much resources into training a workforce, a skilled workforce, and then who will benefit in the end is the US and the UK for the most part. So I think this is a very important point that obviously sanctions intensify it, but it relates to all of the global South, really.
That's a good point, Vera. In terms of raising the point about migration and brain drain. As you said, it's not just about countries who are experiencing sanctions. It's been a phenomenon which has, of course, been with us for many years, decades, or maybe the beginning of human history. People go where there are opportunities if there are limitations. In the case of Iran, which you talked about, of course, this existed also during the time of the Shah, and of course, often in the case of Iran, at least, it's due to political authoritarianism, and then, of course, mismanagement, corruption, and the sanctions just adds a new layer, complicating, exacerbating the situation. Thank you. Any other questions or comments, please? I want to give anybody a chance who wants to ask a question, jump in, or comment. Anybody else before we break for lunch? I think people are hungry, or...
I just want to say that I really enjoyed this discussion, and it is very nice to hear, particularly from Paul and John, who are, have worked within the region and are as aware as all of us Iranians about the impact of sanctions, which is, oftentimes completely neglected both within the global health community and other policy or practice or academic communities. So thank you for having me.
Okay. Anyway, this was a good panel. It complemented. It was a continuation of the first part where we had. I think we've covered a lot of ground, and here, of course, with regard to sanctions on Iran, Iraq, Syria, and also Yemen. And so I'd like to thank Vera Ameli, John Cunliffe, and Paul Critchley, and Nidal Ode for their valuable contributions. We will, if you'll permit me then, we will break for lunch. We will reconvene in 55 minutes at 2 o'clock, 1400 Central European time. So, so see you at 2 at 1400 hours. We're in Switzerland, of course we are, so be on time. Thank you very much. Bon appetit.
Hello? Hibak?
Hi, how are you?
Hi, Hibak. There you go with your glasses.
I know.
Well, now you have white ones on. You had black ones last time. You're looking great. Whole different decor. The last time you had a poinsettia plant. Now you have spring flowers. All wonderful. I like the visuals. I like the visuals.
Well, I love your flower. And yes, the glasses is to impress you, of course.
Well, the flowers are to impress you. These are regional peonies from Geneva. They're very beautiful. And they came out today. And so we're glad that you came out too. And I know you have a lot to talk about with your panel. So I would love to talk to you privately when, you know, the dust settles. But for now, I would like to thank you again for putting together this panel and particularly for bringing MENA in in the emergency room as you did. So it's great on board. So I'll just introduce you, Hibak, if I can. It's a little lengthy, but you deserve it all.
No. Just keep it short. It's all right.
So should I skip every other word?
Oh, absolutely. Necessary.
I'm a pretty fast talker, so I'll shoot from the hip. That's not a good expression. That's a little violent. Okay. Hibak Osman is the founder of Karama, a movement to end violence against women and deliver sustainable, inclusive peace and democracy in Africa and the Middle East. Wow. Hibak's work has encompassed reconciliation and peace building in Somalia and Sudan, campaigning for justice and recognition for Korea's comfort women, and supporting grassroots women activists to build constituencies and secure their rights in the wake of the Arab uprisings. Named one of the world's 500 most influential Muslims, Hibak is a member of the Women's Alliance for Peace, the UN organization, and has previously served on a number of advisory groups and boards, including UN Women's Civil Society Advisory Group and the Board of Donor Action. Hibak is a senior fellow at the James MacGregor Burns Academy of Leadership at Churchill College, University of Cambridge, and a member of the Yale African Women's Leadership Network. And this is her second time here. So we heartily welcome you back. Welcome from us to you.
Thank you so much. Thank you so much. It's it's such a long thing. Yeah, it sounds like a panel itself, you know?
Yeah. Thank you.
Thank you so much. It's really a great pleasure to be here with you today as we discuss the vital issue of health in the MENA region. We are, of course, you know, in the midst of global public health crisis, but for many of us in the region, this is just another crisis on the hip, I should say, of many others we have been dealing with for so many years. I think, you know, you guys could, you know, we could teach a couple of, you know, experiences and share, and, you know, people could learn from us exactly how we have been able to handle many crises. As previous panelists have covered, our region is particularly fraught with conflict, occupation, and sanctions. What we have long known about crisis is that it has a disproportionate effect on women and girls. When a woman sought to consider these issues, I'm delighted to welcome an outstanding panel of experts. This group brings with it vast experience and can reflect on the impact of the conflict, occupation, sanctions, instability, and economic crisis on the access of women and girls, and in particular, minority groups to healthcare. I am really happy that Dr. Mary Velma O'Neill has really made this opportunity her business to spotlight the women in the region, because as you know, the most incredible work that I know of is really happening. With every disaster that's happening in the region, the women are the ones that are holding, I mean, they literally are the core, the center of their societies and holding up, you know, the society. I don't think, you know, without this incredible woman, I don't think this region would have survived. So truly, it's a pleasure to introduce Susan Arif, who is a human rights activist and a founder and director of the Women Empowerment Organization based in Erbil. Susan has served as the coordinator of the Iraq Cross-Sector Task Force 1325 for the implementation of Iraq's National Action Plan on Women, Peace and Security, leading this task force. Susan has been, and this is what the government of Kurdistan and Iraq were not talking, but Susan, all the women agreed, which shows you that women can actually agree and make a difference, that Susan should be the only representative and lead this panel. Susan has been working to ensure a robust partnership between civil society and the governments of both Iraq and Kurdistan, translating the rhetoric of international agreement into the reality on the ground, ensuring that women and girls affected by conflict receive the support they need and are able to access the vital services, including health. Susan is just sent me a message and said that she is not able to connect. So I think I will go to the second speaker. I think I will go to Sandy. So Sandy, Susan is trying to, I think there's a problem with the internet. She's in Iraq, in Baghdad, so she will keep trying. But I would like to introduce Sandy Hanna, who is an incredible feminist, intersectional, and anti-imperialist. I have used that word so many times I can't pronounce it anymore. Activist from occupied Palestine. Sandy is the founder of Feminist Diaries, an intergenerational collective of young women and girls that analyze, produce art to share stories about their lived realities under colonial oppression, and particularly activism journeys and the feminist world they dream to co-shape. Sandy, the floor is yours, and welcome.
Thank you, Hibak. Hello, everyone. Thank you, Webster University, for holding this space during such critical moments for Palestine, most specifically. When I first saw the invitation and I laid my eyes on equal access to healthcare, I was like, okay, interesting. How fundamental, one of the most fundamental human rights is really being violated consistently in Palestine, and where multiple actors in a healthcare system are really holding or manipulating power in a very asymmetrical way. And this made me think that despite the many common injustices that the different countries of the Arab world are really facing, there's some kind of more particular particularity to Palestine given the political context. So I'd like to spend the next 8 or 10 minutes just giving a few examples of how life on the ground looks like and how health is more of a political issue in Palestine and how it affects women and girls. And just being a really far from excessive jargon, let's just take a few minutes to understand how life is for women and girls in a colonial context. So not to bore you with many examples, the first one is from the West Bank, and the geopolitical divide in Palestine really dictates different types of injustices in different areas. So more than half of the West Bank is classified as Area C, and that's basically under Israeli military and civil control. And this means that they also have access, they have control over resources, and Palestinians have little access to that. And more than 1/3 of people living in those designated zones are really dependent on mobile clinics for essential health services. There is lack of hospitals, of equipment, and basic response to the needs of citizens. And if we talk about mobile clinics, in principle, it's a very efficient model in different circumstances, but not in a context of colonial oppression, because mobile clinics are really dependent on funding, and that could by no means be sustainable. It cannot meet pressing needs like COVID-19, for example, and it's most importantly prohibited under Israeli procedures, because permanent or semi-permanent structures in these areas that are designated Area C are requiring always permits from Israeli authorities, which is probably most of the time rejected. And the technical perspective is that women and girls are unable to reach those mobile clinics all the time. It takes the nearest clinic would probably take too long to reach. It will cost too much that people cannot afford it. There's no public transportation. The roads are really dangerous with bad conditions that even ambulances cannot very often reach communities. And therefore, this kind of injustices and struggles means that, for instance, pregnant women are not able to follow up with their regular checkup. Children who are suffering from trauma cannot have regular mental health services. And there's also a gap with this specific part in mental health in the West Bank. And another thing is the reality of prisoners, whether they are men, women, or even children. Prisoners in Israeli jails are systematically denied medical treatment, which is often resulting from torture and excessive use of brutality. And this is a deliberate neglect that is very often leading to death. And the health care that prisoners are entitled to is enshrined by international law, and this is a basic right. And for Israel to systematically and deliberately ignore that basic right is a question of how health is really used as a strategy of oppression and torture. A third example would be forbidding medical staff from giving first aid or even medical treatment for injured on site. We've seen for the past more than a month the brutality of the state and even the Israeli mobs lynching in streets of Jaffa, in Jerusalem, in Lid, in Haifa, in areas of 48, and how medical treatment was denied on purpose, like ambulances were not really allowed to come in near injured people and wounded people. And we've seen live ammunition being opened at Palestinians, and we can see Israeli forces not allowing medical staff to come in for the rescue. And this is also a systematic strategy of ethnic cleansing, the massive shooting and the lack of medical supplies in hospitals and the closure of hospitals and even in the bombing of hospitals like we've seen in Gaza. This leads me to talking about the inhuman conditions in Gaza, whether it is now because of the assault, the most recent assault, or even before with the horrible and terrifying humanitarian conditions. So basically what's happening in Gaza is that people are been under blockade for 14 years. And what this means is that they are being denied clean water. Only 4.3% of Gaza Strip households really have access to safely managed water, 4.3%. And that's an insane figure, you know. There's no electricity in Gaza, so I'm not really certain how hospitals are supposed to respond to times of assaults, military assaults and bombing and killing when hospitals are not really functioning in their best. The recent military assault also bombed clinics and recreational centers and healthcare infrastructure, and there was an intentional, systematic manifestation of how human rights is being violated, including health and education and others. And before the bombing, as I said, even the humanitarian conditions were terrifying. The borders are always closed in Gaza. No treatment for whatsoever, most specifically for acute diseases or chronic diseases. Cancer patients are really required to apply for permits to exit the borders, and then most of the time they are often denied those permits. Children are dying. Bisan Abu Sukkar, who is 4-year-old, left to get her chemotherapy in Nablus in West Bank, and she left the strip without her parents. Neither of her parents were with her. She was supported by the nurses at the hospital in Nablus, and this is only she's 4. Like she's a child who has been denied being with her family throughout the last moments of her lives. And we're talking about systematic oppression in ways that is also applying state-of-art weapons, like the excessive use of weapons in Gaza Strip is, if not killing people, it is impairing people, it is traumatizing people at a best-case scenario. And the health services for mutilation and trauma are really scarce in Gaza, and we've seen a very a huge gap. And even when we have different bodies coming in to interfere, let's say UNRWA, for example, who is providing a main source for healthcare services for refugees, mainly in Gaza, we've seen lobbying and different influences and pressure on such multilateral bodies to end their support for Palestinians. We've seen in the deal of century that was really notorious last year how US really cut their contribution to the UNRWA. And we've seen that this is also a mechanism. I'm done. The last thing, I'm done.
Yeah, one more minute. Sorry.
Yes. Girls are not really offered the protection that they are entitled to according to the Geneva Convention, and they are really in a critical position where they cannot even say that they feel PTSD because it's an ongoing, recurring trauma. And for this to end, for women and girls to really have access to healthcare services and to manifest their leadership and their potential to be in change agents and active citizens of the society, we need to step up to the responsibility. Multilateral instruments need to step up for their responsibilities and impose sanctions on Israel and end the military embargo, control the armed trades, and hold Israel accountable for the war crimes. If this is not happening, there will be ever no peace for women and girls in Palestine, and therefore it is really it's really hard to navigate the prospects and the ways and means that women have a say in decision making, and that the leadership is really taken into consideration on meaningful levels. Thank you, Hibak.
Thank you very much. You actually finished on time. I said 2:16, and Dr. Mary Velma has been very generous, giving us an ample time. And I think it's very important to sort of, to learn, because that's the only way to do it. You can do it, but there is no graceful way of cutting somebody in. So thank you very much. Susan is still trying to join us. The next speaker is Bridget. Bridget Shevlin is an attorney at law and founder and director of Justice Without Frontiers, which works to advance access to justice for women in Lebanon. Bridget's work is with vulnerable communities and has seen her work to improve response to and support for survival of human trafficking. Bridget?
Yes, hi Hibak. Hi all, and thank you for letting me be part of this important webinar and this important conversation. Okay, in my small intervention, I will be focusing a bit about the situation of the women, minority groups, and the health system, especially after 2019. As you know, or some of you know, that in 2019, specifically in October 2019, the revolution started in Lebanon, and also the economical problems started, and these economic problems had a very bad effects on women and girls, and on the Lebanese refugees and all population living in Lebanon. After the Beirut blast, we start having the COVID-19 till we reach the August 2020, when we had the Beirut blast. The Beirut blast have caused more than 200 deaths, injured over 6,000, and displaced over 300,000 people. The Lebanese have lost their homes, their family, their friends, their jobs, and their food security. Also, the Beirut blast heavily damaged 4 hospitals in Lebanon, putting them largely out of commission. More than 20 primary care facilities serving approximately 160,000 patients were damaged or destroyed. The Lebanese pound lost more than 80% of its value since 2019, eroding people's ability to access basic foods, basic goods, including food, shelter, and healthcare. The COVID-19 pandemic disproportionately affected marginalized groups, including low-income families, people with disabilities, migrant refugees, and LGBTQ. And of course, we are talking about women and adolescent girls. So the economic crisis and the pandemic increased poverty and reduced productivity. The consequent decline in national food security, deteriorating living conditions, depletion of the skilled workforce, and general social instability, and threatened the well-being and security of the entire nation. Due to the economic crisis, and due to the government's failure to provide private and public hospitals with the fund it owes them, hospitals are struggling to provide patients with urgent and necessary life-saving medical care, and are warning that hospitals may not be able to provide patients with life-saving surgery and urgent medical care because of a financial crisis. Medical suppliers who provide equipment for both public and private hospitals, they have not been able to import medical equipment due to the shortage of dollars and the absence of government regulation that would prevent banks from arbitrarily restricting money transfer outside the country. As well, the Lebanese bank also imposed several restrictions on line of credit, and foreign suppliers are now demanding food prior to delivery due to the refusal of insurance company to cover shipments to Lebanon. Another challenge that Lebanon also is facing. When I say Lebanon, I mean the whole population, women, men, Lebanese refugees, migrant workers, and other, is the travel of doctors and nurses, women and men. They are traveling. We have more than 1,000 doctors who left Lebanon and they traveled to work in Gulf, in France, in USA or Canada because of the economic crisis in Lebanon. Coming to the women and adolescent girls in Lebanon, I have to say that women are playing a major role within the response. As frontline nurses, midwives caring for COVID-19 patients, public health professionals, and doctors driving policy and decision makers. 80% of registered nurses are women. The vast majority of social workers, domestic workers, and health facility service staff, such as cleaners and caterers, are women. However, when it comes to governmental leadership position and decision-making, women remain underrepresented. So only 80% of government of the government of Lebanon Interministerial Committee on COVID-19 are women. Several national professional health associations leading on COVID-19 also are headed by women, including the order, as I said, the order of nurses, midwives, and the syndicate of medical equipment equipment importers. It is important to mention that before the economic crisis, there is a variation in access for women in urban versus rural areas, and by region. There is a kind of statistic that it mentioned that 75% of women in urban areas said that they are easily available to reach the medical services or to access the medical services compared to 62% of rural women. But now, after October 2019, after the economic crisis, women's access to healthcare become more problematic. because of increasing the vulnerability, because of increasing the number of domestic violence, the loss of livelihood. As well, women are facing, usually in Lebanon, they are facing a higher risk of COVID-19 transmission and fatalities. And I think this is the issue in all over the world. Many Lebanese women can no longer afford a private doctor, which places additional stress on overstretched public sector, or even women that are not satisfying from health services. As well, there is discrimination when providing services during the COVID-19 or during any pandemic or Beirut Plus, which is related to non-registered women who doesn't have an identity card. So they are not able to benefit from any strategy or from any support or relief provided from government. And still there is no solution regarding this issue. As well, the Lebanese women who are married from foreign persons, also they are facing, their children are facing from difficulties and challenges related to access to health services and reliefs. Noting also that that we have to mention that because we have the increase of vulnerability in Lebanon and increase of the economical crisis, the number of abused people increased. Unfortunately, we don't have any statistics yet, and unfortunately, some of these victims, they doesn't know that they are victims of trafficking. Another very dangerous matter that we are start facing in Lebanon, that women who are victims of domestic violence, or the victims of any kind of violence, they are not anymore asking for justice. They are just asking for food to live and to let their children live. And this is very dangerous issue and very dangerous indicator in our country. But despite the whole, despite the whole situation that I was mentioning, at the end of December 2020, in 30 December, the Lebanese government adopted 2 new laws related to women. The first law is the amendment of the law to protect women and other family members from domestic violence, where we can find a more role for the internal security forces and the Ministry of Social Affairs. But unfortunately, 1 minute, I will finish. Okay, regarding the adolescent girls, it is important to mention that the pandemic had a very bad effects on adolescent girls. Adolescent girls in Lebanon form a particularly vulnerable demographic group, and they are facing a disproportionate risk when compared with the rest of the population. Adolescent girls, Lebanese and refugees are now battling hunger, risk of violence, poor hygiene, lack of access to sexual and reproductive health services, high risk of exposure to early marriage, violence, and abuse. Noting that adolescent, noting that the adolescent pregnancy in marginalized communities continues to remain a concern. Other topics we will be discussing during the discussion.
Thank you very much. Thank you very much, Richard. Really appreciate you kept the time. I'm so happy that Susan Arif finally is able to connect. Susan, welcome. Susan Arif is a human rights activist and a founder and director of the Women Empowerment Organization based in Erbil. Susan has served as the coordinator for the Iraq Cross-Sector Task Force 1325 for the implementation of the Iraq's National Action Plan on Women, Peace and Security. Leading this task force, Susan has been working to ensure a robust partnership between civil society and the governments of both Iraq and Kurdistan, translating the rhetoric of international agreements into reality on the ground, ensuring that women and girls and minorities affected by conflict receive the support they need and are able to access vital services, including healthcare. Susan, welcome. The floor is yours.
Thank you so much, Hibak. Thank you. Good afternoon, everyone. It is really a great pleasure to have this chance to participate in this important forum and to present healthcare and gender minorities. So first, I would like to start from the national system, the house system of healthcare in regard to gender and minorities. So you know that Iraq has been subjected to the most complex emergencies, conflict, and security situations. Health facilities have sustained serious damage and need urgent rehabilitation. Primary healthcare centers have deteriorated due to lack of maintenance, lack of supplies, reduced of inadequate health works and services. The Iraqi constitution recognizes that Iraq is a country of multiple nationalities, religions, and sects. Moreover, the constitution enshrines the principle of non-discrimination and the equality of all Iraqis, and guarantee the administrative, political, culture, and educational right of all the nationalities in Iraq. Alongside the constitutional provisions, the Iraqi public health law provide broad measures aimed at supporting maternal health, family planning, and children health. The Iraqi public health law forces the state to guarantee the rights of each citizen to physical and mental health and oblige the state to regulate maternity care and family health care. This is very good. But while these are robust provisions, Iraqi minorities do not often enjoy even the most basic human rights granted by the constitution. The most significant threat to Iraqi's health comes from the overall deterioration in health facilities and service resulting neglect and war, access to quality health care for all Iraqi people is severely undermined. Thousands of Iraqis medical doctors, among them the most experienced and specialized, have fled Iraq due to the increasing threats and violence directly against them, thus affecting the overall capacity to deliver health service in Iraq. The same case exactly like Lebanon. So the cumulative effect of years of neglect of health service and the ongoing security situation affect the people of Iraq to varying degrees, regardless of their sex, age, ethnicity, religion, or urban or rural location. Some of Iraqi's religions and ethnic minorities remain at risk of targeted violence and political, social, and economic marginalization. Women and children from minorities groups suffer of double discrimination, both as members of minorities and as women and children. Evidence shows that ISIS has committed inhuman practices against women and girls, including killing, kidnapping, and forcing them to change their religion. During the past 6 years, militias kidnapped thousands of Yazidi women and girls to sell to ISIS fighters, where they have been subjected to forced marriage, sexual slavery, rape, and domestic servitude. The total number of Yazidi kidnapped is estimated at 6,000, and women constitute the largest proportion. In this complex context, difficult to examine the gender and life cycle perspective on access to quality health service, how particular obstacle to access affect women, men, girls, and boys in different ways and to different degrees. This consists data disaggregated by sex and age, must be available to allow for analysis of health trends and access to healthcare. We can see that the law does not regulate the provision of health service in such a way as to ensure the quality healthcare is accessible and affordable to women, especially widowed women or women heading up households. The privatization of some healthcare facilities and the resulting fee structure has further limited women access to healthcare. The problem is particularly serious in rural areas, where healthcare facilities are often non-existent due to the emphasis on the provision of hospital-based care, which are located in bigger urban areas. Early marriage and pregnancy preferential treatment within the household for men in access to food and traditional practice, whereby women must obtain permission from a male relative before seeking medical care, are significant cultural barriers to good health for women and girls. We can see also, like men may suffer other health disadvantage related to their gender roles, socialization, for example. Men role as protectors and providers may place a greater responsibility on them to take risk during ongoing insecurities, therefore exposing them to random or discriminatory violence, meaning that their limited health services are stretched to address their medical care needs if injured. Furthermore, women's access to reproductive health care is significantly challenged by their displacement and is mostly provided by mobile medical teams that are often too stretched to cover the size and geographical spread of the needs. 1 year after the rise of ISIS, it was reported that 133 displaced women had given birth on the street, in a camp or a school building because they were unable to reach medical center. The estimate number of weekly births among IDPs was 300 in 2015. Also, COVID-19 affected on those women IDPs living inside camps because the restriction of moving and now also facing the ignored and isolated to get vaccines.
You can finish up.
Okay, WHO data shows an average of 0.37 psychiatrists working in the mental health sector per 100,000 persons in 2014. The shortage of specialized, especially women, has been aggravated by the increasing need for mental health care provided due to the recent ISIS crime.
Thank you.
So this is maybe I have a very limited time, but I want to focus on some recommendation, and especially for the national political stability and also security as a top priorities if we want to improve the health care for minorities, gender, and accountability, monitoring on health care, gender policies that reflect the implementation of the standard right of human rights, women rights, and the implementation of the SDG goal, and especially how to have a gender responsive budget for healthcare. Thank you very much.
Thank you very much indeed. Thank you, Susan, appreciate that. Our last speaker is Dr. Muna Ghanem. Muna is an activist, a politician, a doctor. In addition to her activism, Muna has served in health roles nationally and regionally, working for both UNFPA and UNIFEM. She holds a diploma in public health from the World Health Organization and a master's of public health from Johns Hopkins University. Not to mention that she has the most important, I think, credential Muna has is working with, on the ground with communities. Mona, the floor is yours.
Thank you very much. Thank you for inviting me to this important event in this critical time of the world. I will start by talking a little bit about Syria, and then I will take it to the global level, because I think I think coronavirus has told us that we are all interconnected and we cannot live without each other. And coronavirus has told us that health is not an issue of health. It's a political issue, it's an economical issue, and it's a global issue. Syria, after 10 years of war, become obviously a fragile state. And the fragile state, the most important definition of fragile state is the state which cannot provide services to its citizen. And this is one issue. The other issue, that Syria is divided between three areas. And one area is under the Syrian regime, the Russian influence. One area is under the Kurds forces and with the American and Western influence. And one area is under the Jabhat al-Nusra, which is the radical Islamic jihadist movement with the Turkish influence. And in the two areas, in the northeast and the regime-held areas, the interest of women issues become less. And of course, I mean, I don't want to talk about the Islamic radical movements position toward women, but at least we know there is a lot of restriction of women to go out of the house, to be a human being, basically. The Syrian regime has lost interest in women issues because usually they were doing it to satisfy the appetite of the Western country, and now they don't want to do that for political reasons. So they have cancelled all the organization, the governmental organization working on women, and the civil society, between brackets, which is under the control of the wife of the president, is not interested in the women issue, is not interested in the health of women, is not interested in the feminism. So we are left with the areas which is under the control of the Kurdish group supported by Europe and USA, and these people are very much interested and they are very much progressive in the women issues, but they are under a lot of stress because they are almost isolated between Turkey and the Syrian regime, and the closure of the border during COVID-19 has increased their isolation. So they are really in a bad situation. So even if they believe in women issue, they cannot provide the needed services. And when we talk about women access to health, I have to raise a question: what health we mean? We usually talk in general, but I would like to identify two important type of health which are very important for women in my fragile states in Syria. The first one is the mental health, because we didn't, I mean, these people were living, especially in the northeast, northwest, they were living under ISIS. And Susan has talked about the Yazidi and women who were kidnapped, sold, they were victims for all kind of violation. So these women, they don't have access to any kind, I mean, because mental health is taboo and we don't have the infrastructure of the services. And also the second type of health I would like to draw the attention, it's reproductive health and sexual health. And sexual health, basically we don't have access. I mean, Syrian women don't have access to sexual health services. And now you can imagine the situation in Syria. But when you talk about access to health in the era of COVID, I draw this title of an article in the Atlantic, which says COVID-19 is the catastrophe for feminism. I'd advise you to read the articles. And it is a catastrophe for feminism because it's affected all the areas where we used to be able to maneuver. Like we cannot meet now. We have been meeting through Zoom for a long time, for more than 1 year. We don't have the freedom to assemble. We don't have the freedom to move. Our world is limited. I mean, now we are very much limited in the numbers who can access to this. And we are marginalizing the women who don't have access to Zoom. And there are many in Syria. There are many in Lebanon. And even if they have access to this, it's costly now. And it's not something very easy. So when we talk about COVID-19, it's a catastrophe for feminism. It's a catastrophe for democratic values. It's catastrophe for the equity. And if we want to talk about health, women access to health, we cannot isolate it from women equity. in the society. And if we use the health equity framework, we will see that we need to do a dramatic changes in the society, in the political system, to access, to ensure that the women enjoy the equity, which is access and equality, blah, 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 at the end, etc. So what we need to do, we need to look at the women access to health services from an equity perspective, not only from the access and the infrastructure and the law. It's something which is, I don't have the right to go to a gynecologist if I'm not married. I don't have the right to do this and that if I'm not this and that in Syria or in the Arab region or in the MENA region. So we need to analyze all the situation in the era of COVID from equity point of view and how we can do. And I want to draw here to my engagement with the Danish Committee for Health Education and the project on the equity of health. And we are working on promoting digital health as a concept, as a tool for equity of health for elderly people. They are doing it for elderly people. And I would like to call to do the same thing for women. Like we have to talk, we have to address COVID-19 from the equity perspective, and we have to have a globalized, because COVID-19 is a globalized disease. It's one of the consequences of the globalization. And when we talk about globalized disease, we need a globalized solution. We need a globalized health services. And this is why I'm saying that we have to go to digital health. But to ensure that everybody has a digital health, there should be a change in the economic situation, in the political infrastructure. We cannot leave these countries or these people alone, because if I manage to control COVID in, let's say, in Europe or in Africa, and I left some part of the coronavirus hub, we will all not be safe. So corona is a virus which calls for equity in the world. If you want really to, like vaccination before, you cannot vaccinate the rich people and leave the poor people. You cannot vaccinate, but the problem with corona that it is very much linked to more deep-rooted political issues. So we need to look at the coronavirus as an opportunity to call for more equity in health, more equity in political life, and we need to really re-examine and work more toward deepening and ensuring the democratic values in all systems. There is no equity without right. There is no right without citizenship. There is no citizenship without democracy. So my call is that we need to, as a women movement, we really need to put health as a priority, but we have to put democratic values as a precondition for health, because otherwise we will not be able to face or to manage coronavirus all over the world. Thank you very much.
Now I'm having trouble. Thank you so much, Dr. Mona. Really appreciate that. Thank you to our incredible speakers. We are now going to give an opportunity to respond what you all, each of the panelists have raised. Are there any points to my panelists that you would like to develop? Any issues that you recognize between yourselves in a different context? Then we will, after that, we will then open up to the audience. So now to the panelists who would like to pick up on any points raised by your fellow panelists.
Hiba.
Yes.
I would like to comment on the Lebanon issue, because it's very much linked to the Syrian issue. And Lebanon is really now facing a lot of financial problems, and Syria play a key role in that, because Lebanon used to be the lung for Syria during these circumstances. And this financial issue has really worsened the living condition and access to technology and access to health for the Syrian refugee in Lebanon. And I think we are all, I'm bringing this idea to confirm my ideas that we are all interconnected, and unless we solve the problems in the region, we cannot really move forward in the women issues also. Thank you.
Thank you very much. Anyone else? Richard?
I think sorry, if I can, the issues we see in Iraq are not specific to the areas that were affected by the crisis with ISIL. We see it in greater or lesser extent across the whole country for multitudes of reasons, but one of the large reasons is lack of access to financing of the healthcare system over a long time, going back to the financial impact of the Iran-Iraq war and onward since then.
Susan, would you like to respond to Mr. Paul?
Of course, the financial crisis also affected on all the infrastructure because it is all connected to each other. The instability, the sanction, the financial crisis, the instability, the conflict between the parties themselves. So this is all is affected hardly on the health system. Yes, ISIS, it is a big part of it, but all connected to, of course, the financial crisis also, and the corruption.
Okay. Richard, do you have something to say, or Sandy?
I'd like to comment on Muna's contribution. Actually, you raised multiple fantastic points, but I'd like to just quote you when you said COVID as a political issue and how it is globalized disease, and that requires a globalized solution. And I cannot agree more with you, Muna, that this is probably a perfect timing for international cooperation and multilateralism to shift and to take more of positive stances towards human rights. We've been hearing lots of promises, but not actually, and advances in the past, but not in the extent where the security of the region is really interconnected with the security of the globe. And this is perfectly a good timing to understand that we need more gender voices in multilateralism, and we need to make sure that we work together towards global justice and global peace, because we cannot afford at this moment double standards of international justice where accountability is imposed on specific political parties or states or whatsoever, while other perpetrators of war are really enjoying an endless culture of immunity. And for this to happen, we as people, and this has been heartwarming throughout the solidarity campaigns running all over the world with Palestine last month, the interconnectedness of people is really a strong voice that can very much pressure governments into reflecting that soul into multilateralism and international cooperation that would eventually benefit the good of everyone. Another thing very quickly is that the healthcare system is very much linked to other social systems like education and food production and others. And it's also linked to unemployment and poverty and conflict and displacement. And I like when you said that Syria is a fragile state, and that means that it cannot really provide for their citizens the basic needs. And I just need to say that however our circumstances are different in our respective countries, the result is the same. States are unable to respond. And for Palestine, for example, it is merely a state on paper, like formally for UN records a state, but on the ground there is nothing relevant to sovereignty or to efficiency or to resources that would really testify that Palestine is standing up for their citizens, especially minorities. And thank you for everyone else for your wonderful contributions. Thank you, Bob.
Thank you. Bridget, you didn't say anything. Would you like to just...
Yes, I just want to say that to be able to have, to ensure access to health, to justice, and to have a more fair society, we need to work on different issues. The first one, we have to combat the corruption. The corruption is very high in our countries. I want to talk about Lebanon. We have a very high corruption, and all the perpetrators that are benefiting from the immunity capacity, and there is no political will to combat this issue. Secondly, I think we have to work on our legal system. So when we have legal systems, when we have law, we will be ensuring all access to justice, including women, children, people with disabilities. A very important matters is to have a special special work on adolescent girls. We cannot include adolescent girls with women. We cannot have a strategy for women and adolescent girls. We must follow what is needed for adolescent girls and to put a strategy related to their needs, to their access to services, to the justice, to the healthcare, to the need. And finally, I think with most of us, Lebanon, Syria, Palestine, and Iraq, all of us, we suffered from crimes, different kind of crimes, war crimes, crimes of aggression, and whatever. What is needed in our country is to work on the implementation of the Rome Statute, but what is needed is to ensure the impunity system in our country, to define the violence crimes, because in our countries, women is used as a war. It is used. It is the most person who is or human who is violated or during the war. So what is needed is to revise our legislation to ensure protection for victims, for witnesses, especially for victims of sexual and gender-based violence in conflict.
Thank you very much. We have done this panel differently because we wanted to make sure that everybody, just to show the similarities, the difference, what people could learn from each other, and to talk to each other, because usually panelists, you talk and then you finish and you wrap. So I think this is very important. And as you know, in this region, we are touch-feely kind of people. So this is very important to us. And the fact we are just doing it in, by Zoom also does not help anyone. We, miss that hug and that, hugging and all that. So this is very important. So I would like to wrap up and then open up for discussion to the panel, to the audience. What we have learned from Sandy, for example, is how healthcare has been weaponized, and there is no more rules of engagement. Actually, not only in Palestine, but in many other countries, even when it's civil war, they target the health, and they are targeting the education, and they are targeting everything and any institution of any semblance of civilization. So this is really something that's new in many ways. Sandy said healthcare in Palestine is a political issue, and I think Muna said that, and I think Richard said that, and Susan said that. The geopolitical divide in Palestine has a serious impact on healthcare access and a gendered impact. Denial of healthcare service to prisoners, including women and children, is a crime, highlighting most recent examples from our experience with COVID-19 and the geographical divides in historical Palestine. This is Sandy. Gendered lens on healthcare in Gaza, and most specifically children under 18, given the humanitarian conditions of living under blockade for 14 years and the most recent military assault. This is Sandy. This is what Sandy has really, shared with us. Bridget, shared with us and said, crisis upon crisis, from the refugee crisis, the economic and political crisis, the Beirut blast, and COVID-19. Lebanon faces a brain drain. Healthcare workers are living en masse because of the economic crisis. Women are responding to the crisis as workers, but they are underrepresented in the most senior levels of decision-making. Economic, the other point she made was economic and COVID crisis is having a particular effect on women. We are seeing an increase in violence against women and girls. For many survivors of violence, they have given up on justice. And then she shared with us 2 new laws to protect women. She also said that our girls and girls are really, really a high risk, facing a high risk. Susan Arif shared with us and said a serious damage to healthcare infrastructure. On top of that, there is a lack of maintenance. And of course, like I think also one of Mr. McCarthy, I think, also shared that the overall capacity of, on top of that, there is a lack of maintenance. She said overall capacity is reduced by health care staff fleeing the country. Again, it's the same everywhere. It's the same. Healthcare workers are fleeing the countries, whether it's in Syria, whether it's in Lebanon, whether it's in Iraq. Iraq is a multicultural country, Susan said, under its constitution, with physical and mental health seen as rights. But Iraqi minorities often don't have even their basic rights recognized. 6,000 Yazidis are estimated to have been kidnapped by ISIS. The government does not ensure healthcare services are regulated to ensure quality and access. State and constitution and Iraq health law, how conflict has impact on infrastructure. Even with having a woman minister for health, it hasn't had a better impact for women. We always said that it's not just being a woman and then you have a position. You know, if you are not a womanist woman and if you don't have a womanist agenda, you are no woman. You just basically look like a woman. All connected to political will, difference between cities, rural areas, and IDPs. There is no share of the vaccine for them at all, and for the majority of the people. And of course, Mona said it's a political issue. If we really cannot take care of the political part, there will not be any security, there will not be any help, and we have to look at these issues in a deeper way than just, you know, a quick fix kind of thing. So I think that's my take. If I left anything, I'm sure my panelists will remind me. And in the meantime, I'm opening this. I want to again thank Webster University and Dr. O'Neill for giving us an ample time. She said, this is the time you have, and we wanted to listen to each other, and we wanted to really bring our stories here. And as you know, we're all activists, and activists are compassionate people. So it doesn't work to say you have 5 minutes. We have to let it go so they can feel it. And I think one of the things that we have said was, bring your issue, feel it, own it, and that's how we really wanted to present this. I hope you have done a fantastic justice to my panelists. Thank you so much, everyone. It's open to the audience now. If you have any questions to the panelists. Okay, I'm going to mispronounce Jane. Okay, thank you.
Oh, it's fine.
Come live. Okay, thank you. Everyone butchers my name, so it's okay.
No problem. So my question is, you've painted a still bleak image, particularly for women and children in the Middle East. Have you seen anything really positively change over the last decade? I mean, I've been working in the Middle East since 2006 now. Do you think there's any positive changes come through? Is there any glimmers of hope out there at this time, or do you think it's actually going backwards, or it's the same basically for women and children?
I hate when moderators just keep talking and don't let other people speak. So, at the risk of embarrassing myself, I would like to say, well, the answer is right here. You have 4 incredible women. So this is the product of the Middle East. So yes, there are challenges, but there is also fantastic stories to tell. I will give it to Sandy, Bridget, and Susan Arif, and Mona. Mona, go ahead.
Okay. There is a lot of changes in the way people look at the regional issues. And my position that unless we have a sustainable peace in the region, this region will continue to be a place where we have a lot of problems. But the good things that now people are discussing, debating issues openly, at least in Syria, issues where we were never able to discuss. Now it's on the table. There is a lot of destruction. There is a lot of pain. Yes, yes. The other things that I would like to say that it is positive that during the war, Syrian women, they were victim, of course, but many of them have realized that they have potential. And I think this is very important also that we have the only things that now we have the ingredients but there is no international political will to make this region a better region. This is the problem. I think the people are ready in Lebanon, in Egypt, in everywhere. People are ready. People are aspiring for better life because now they know how the better life looks like through the social media or the internet. I think what we lack is the international political will to make solution once for all for this region. Thank you.
Thank you. Sandy?
I'd like to pick up from where Muna left, the lack of political will. I think it would be so unfair if we said we haven't seen any progress, because we have been learning from past struggles from within the region and even oppressed populations from the globe. And for that, I would say that we have been able to record very much progress, but on the very immediate level, which means that the progress that has been done, for example, through multilateral spaces, has been very much linked to short-term goals of survival rather than thriving conditions that will support eventually the social and the political liberation of oppressed populations across the region. And the second thing is that the horrific ways of torturing and oppressing women and children has become more terrific by the year. So now today, the forms and the prevalence and the magnitude of violence against women and children is becoming very hard to counter, to mitigate, to respond to. And this is because the efforts that we have are more dispersed. Of course, it's different from each country, but we've seen different actors paying much attention to this. We've seen activists, networks, social movements, etc. But what we lack is really institutional response from UN, from international community, from governments, from states, etc. So we ensure that the peace is sustainable and that it actually has a sense of something beyond the absence of war, you know, like peace on development level, peace on the long sustainable level, where we are able to really co-create different futures for our children and just avoid living in fear and in trauma. And by the moment that you're done with fear and trauma, your eye is really at the outlook of the next trauma, of the next atrocity.
Okay. And I think the good news is there are all kinds of laws that are being introduced that women are pushing. There's no political will. The effort is there. The women are really fighting there. Still there, most of the people did not leave their countries, but there is no political will. I mean, democracy has become who can really run, who has money. And I think we share that with many other countries. But in terms of the women, if you look at the revolutions from Egypt to Tunis to other places, it was the women who were at the forefront. And once the transition takes place, they were put back. So there is an effort, there is a culture and tradition that, is like pushing you back. So it's a pull and push. And I think, when we say we need the support from the international community, it's not to save, us from ourselves, but rather to support. So I think this is one of the reasons we're having this meeting today, is basically building that solidarity and being part of the international community. Because if oppressors always want to isolate you, and accuse you of working for foreigners, of being a CIA, whatever it is. But the point is, this is exactly what we should be doing, that solidarity, so we can push our people. Our people are ready, the governments are not ready in many countries, but at the same time to influence the international community through people to people, universities, and all of that. But I tell you, politically, I think the women in the Middle East have become more sophisticated. And it's because of that interaction with others, and the revolution, of course, has taken away that fear of being afraid to do something. So it's very interesting. It's just that too many 45 problems of the world, 45% are present in the Middle East, as you know. So yeah, but the thing is, it's a very interesting time.
I mean, the title of this section is Healthcare and Minority. But if we look at it in terms of the impacts on healthcare and the impacts on the progression of gender issues and the progression of minority rights across the region, we talk about the need for better governance, but my country's been developing governance, for example, for 400 years, and it's still far from perfect. And the whole MENA region has to contend with wider geopolitics interfering in the sovereignty of states and preventing states from developing themselves, the conflicts that this geopolitical interference trigger or maintain, depending on the area within the MENA region you're in, all limits the capacity of societies to progress with issues of gender access to healthcare and minority access to healthcare. What does the panel think of, the wider issue is conflict and allowing and not allowing states to develop themselves without external pressures?
Mr. Paul, are you from Britain? Because we'd like to have it.
Yes, I'm from the United Kingdom, yes.
Okay, the beginning of all our problems.
Absolutely. I don't believe in racial guilt on other people, but I'm quite happy to accept it as a British person.
Okay. Who would like to take that?
I'm not sure what there is.
Yes. So the question is, with some.
There was an. If I may, I have a question probably which is a little bit related to us here as organizer, as the MENA Center for Peace and Development. It's not a second time we are hearing these stories, the suffering of women in the region, and also the human rights violations. And I think we are all very touched by these stories. But we are trying to bring these voices together, of course, from academia, civil society, and activism. But what I really would like to hear is there something more we can do? Is there something more we can do as an academic institution to provide the goal of the MENA Center, which is peace and development? So what I really like to hear from the participants is if you have any kind of feedback towards us, because we are at the beginning of this MENA Center. And I think it's important for us to hear what kind of possible role we could assume in terms of providing this vision or making this vision more concrete in terms of peace and development. Because it's the first time we had this forum on women's rights, and it's the second time we hear these voices. And I think it's time to ask probably you what you would like to see from us.
Okay, so there are two questions, of course. We have to answer the question that Mr. Paul has asked, and then we come to your question. So is there anyone who wants to answer Mr. Paul first? In other words, can you help yourselves, and change things inside? Please correct me, Mr. Paul, if I misheard you, without outside pressure. Is that?
Yeah, basically, if do we need to remove the outside pressure or facilitate the outside pressure to be backed off to allow countries to address their own issues?
I think I'll just take a quick take on that one. The outside world is the one that is also it's part of the problem. It's a major problem, because if you look at the Middle East, there are three, overarching, what do you call, issues. One is, of course, if you look at the Americans and others, it's the protection, and preserving of the oil. It's protection of Israel. It's fighting terrorism. It never is how do you develop institutions that can weather oppression. Whereas you have societies that are coming together, that are going out there doing this. That's one. Two, no one is really very honest about peace. Look at Palestine. We're still, it's an issue to have a two-state, because really the international community is not helping. But you can see young people as young as 4 years old throwing the stones and refusing and rejecting oppression, but there's no support for them at the international level. So the internationals are not leaving us to, I think, to deal, with the problems, and it's more complicated than that. I'm just saying that when you have oppressed governments that are being supported by outside, by the guns they are giving, by the money they are giving, by basically pushing for look at what's happening in Libya. Even the United States is being, the UN is being accused of being, corrupt, instead of helping and supporting Libyans to come together and come up with their own leaders. So there is a lot of interference. People are not, it's not like, Somalia could really come from Somalia and, you can, for 30 years, but still, it's push and back, push and pull. There is really no honest interlocutors, in out there, but hopefully, it will come. But let me tell you, people really, want to do, to sort out their problem. But, there is a lot of outside interference, as you know, it's just, it comes with the territory. But yeah, hopefully we'll come up with our own solution. And that's what we would like to do. Mona.
Yes, I think the two questions are very much interlinked. So I will start with the questions about if the governments, if the external intervention or external pressure is needed. I think in Syria, let me bring the experience of Syria. We were not allowed to promote the democratic or secular groups in the opposition because all the Western country has supported the radical Islamic movements. And all the people who wanted to have a democratic life in Syria were marginalized in the Syrian opposition. So when you say external intervention, not necessarily in a positive way, sometimes they put external intervention in to prevent us from being into the normal evaluation cycle. I mean, Europe was not created a democratic states. Europe really suffered and paid blood among their citizens to reach what they are now, and the United States as well. So, but Europe didn't stand for its values when it comes to Syria. Democracy is only for specific kind of people. This is what I'm trying to promote, that the vaccination also for COVID should not be only for a specific group of people on the global. It should be for everybody. Equity is the key issue. So if we are in an ideal imaginative world, then leaving the states by themselves, they will evolve, but we are not. There is a lot of intervention, as Hibak said, supporting the dictatorship in the region, allowing all this violation without accountability, promoting and supporting the radical religious groups, preventing the development of secular democratic movements is really under the support of other people, not with the will of the Syrian people or the Iraqi people or the. So coming to the question for the MENA Center, what they want to do for peace and development, my organization has the same name, Women for Peace and Development. And I think what link peace and development is the political freedom. And we should not forget that we cannot have development unless you have peace, and you cannot have peace unless you really have a peaceful way for political life. Once you have a political lives, political parties, people can go and express their point of views peacefully. And if they don't do that, they will go to the fight, they will go to the street and fight and use their guns to win the political stage. So democracy is the most important thing to achieve peace and development in the region. Thank you.
Susan and Richard, would you like to?
Yeah, I have to say that I can say that we are going backward with public health care and with the public health institutions. And why this is because due to the corruption, due to the also because mostly focusing on establishing a private health sector, which this again affected on the minorities, marginalized group, that they cannot have access to private health sector. So one of the important thing, again, it is the corruption, because they want to, also they are using the health care as a trade for the politician. They have both tasks. They are leading the country, and also they are part of the economic growth and all, it become like a trade. So this is why we are going backward, and the poor people, of course, it is very difficult to access those kind of private health care. Another thing, the state is more focusing on militarization, like mostly spending money on weapon, on military issue, not on healthcare. So again, this is a big problem, and also supporting the terrorism and the conflict in the country. It is also preventing the peace, the stability, and also to give some priority to this kind of issues. So this is the big issues, that why we are backward. Maybe for the suggestion, what can this university can do for like peace development? Mostly it is about how to monitor and how to have evidence, how to have advices, how to have reports on what's happening on the ground in these countries. I can see that we have a common point of the challenges in each country. We are lacking of budget, of resource, of infrastructure. So we have common issue. It means this, we have facing the same challenges, the same problems. And also we will have the same solution. So maybe this is what we want, how to have evidence, how we can have like a strong, maybe the international community, how they can interfere in this, how they can use their political will to change. So this is what I think. Thank you.
Richard? You're mute.
Well, I want to answer both questions, and I want to say at first that it's true that women and girls in our countries, they are suffering, but suffering here doesn't mean that women are weak. Because now, if you will go through the COVID-19, I will talk a bit about Lebanon and the Beirut blast and the economic crisis. Who are in the front line? Most of them, they are women. During the revolution, women, they are also on the front lines. But it's the system, the whole system itself, that they are not allowing women to reach some decision-making or high-level positions. So it's something, it is related to the culture, it is related to the political will, and in Lebanon, it is related to the personal status laws. In Lebanon, we have, for example, 19 sects. They are leading the life and the future, and even they are interfering when we have any law related related to women and girls or children or family. So what is needed at first is to move from a religious account, to try to have a civil personal status law, where women are governed by a civil law. So they don't need to get back to their husband or to get back to see what the personal status law are saying, to see if they are able to reach this position or another. The secondly is how we can combating the corruption. The corruption is making not only women backward, it's the whole community, men, women, children, elderly people they are facing. So it's how to combat the corruption, and I think this is the first issue that it's needed to be done, and then everything could be solved. Regarding also what I want to mention, that not only women in MENA were suffering and facing challenges, but during COVID-19, it's women all over the world. The number of violence against women increased, not only in Lebanon, but increased also in Europe. So there is some lacks in the let's say in the strategies, but we have a percentage of difference between country of another. Finally, only this point regarding the healthcare system and justice system, I think the COVID-19 put on highlight the lacks and the gaps in our system. And I think from now, we have to think in a different way when designing or when putting any strategies. Thanks.
Thank you very much indeed. I think we have only 5 minutes left. Yes, yes.
Hello,
Yes,
hello.
Dr.
I
Adil.
have three very quick questions. One is how a young women, who was it? I think it was Bridget who said there needs to be special work in adolescent girls. I think that's really important. And of course, we've seen Bella Hadid intervene in the past month for the Palestinians successfully through her social media. And I wonder, I'm not sure if I sort of think that's a very consistent way of approaching the issue, but I'd welcome your responses to that. Secondly, I would like to know about, through Sandy, about the digital divide, because as far as I know, there's only 3G in the occupied Palestinian territories and not 4G because the Israelis don't allow it. And that links to my question about, I'm asking quickly because I know we have little time, about providing digital healthcare for women. I would be very interested in knowing to what extent women have possession or autonomy or agency over their own cellular use. Finally, I challenge you, particularly Hibak, she's so colorfully in front of me. In front of the UN is a chair, is a great big wooden chair in front of the Palais des Nations. It was placed there in 1997 in commemoration of the Ottawa Convention to ban mines. And it only has one leg, and people didn't know what it was for. Some people thought it represented the dead wood at the UN. But actually, I thought it was the fragility of peace. But in fact, when Princess Diana died, a lot of people came to that chair and laid flowers there because, of course, she was the patroness of the Ottawa Treaty. And so I'm sort of asking you, because my language is visual as a professor of cultural history and arts, if you could imagine another monument in front of the Palais des Nations in Geneva, which would somehow be a metaphorical resonance of your combined sort of concerns and hopes and aspirations for the future. Because I think artistic expression is a wonderful language that's very liberating, and all those fonctionnaires at the UN will take notice of you, and there will be international and political will behind you because you'll be in front of them. That's a comment. I don't know if you have time to answer all of my questions regarding digital divide, the social the healthcare, or special work in adolescent girls, etc.
Okay, so I think Mona and Sandy both talked about the digital divide. So digital health, sorry. Yeah.
This is the core concept. Like, you need to bridge the digital divide to be able to fight corona with digital health. And by doing this, you are using the coronavirus pandemic as a tool to reduce the equity to increase the equity in the world. There is a digital divide for sure, but it's less than the health divide, for example, because most of the people used mobile and used technology. This is my point. For the status in the front of the UN, I would like to put the wings for every woman so that they can fly. They can fly in life. So if you want, you can put a status for a woman with wings, so flying all over the world. Thank you.
Sandy, quickly.
I was really scared about missing this panel because we've been on a power cut all this morning, and my 3G, as you said, Marivalma, could not really support Zoom. And what we witnessed the last month is an intentional interruption of internet connection, deliberate from both sides, like from our state, from the occupation side, to really restrict the freedom of speech. I think what has been one of the most important achievements of the struggle last month is that our narrative is back to the attention of the world. We have been able to mobilize and organize virtually. Solidarity campaigns with feminists and civilians in Palestine has been hugely spread. And I think when we talk about internet, given our new world order where everything is going virtual, I think this is also, this is also a weapon. I need just a second. I'm sorry. I need to also say something about states being able or allowed or not allowed to develop themselves. And I think that we need to look at the intersection of state versus what is that actually outside power. Is it war? Is it pressure? What kind of outside pressure are we talking about? So from one side, Hibak, just give me 1 minute.
No,
From
no,
one
you're
side,
1 minute.
from one side, there is the authoritarian regimes of the state. There is corruption. There's extremist violence. There's repression. There's different things that really embed a progressive development on many levels. It embeds a true project of liberation at many levels. But at the same time, there's also proxy wars in Libya and Yemen, and there's colonial occupation in Palestine where we have no access to resources. We cannot talk about economic empowerment because we have no clean water, and we have no prospect for income generation for many of the populations, including marginalized women. So I think that looking at the intersection, we will realize that there are expansionist imperial powers crippling into our region, saying that our region is underdeveloped and it needs rescue, but in fact, it's not underdeveloped, it's overexploited. And this is something that we have always been afraid to address. And this is something that if we want to address, it means that we need to talk about power asymmetries, and we need to shift the power, and we need to be really authentic to ourselves to understand that as long as the word is capitalistic in the way that it is, as long as the way is running on that imperial vehicle, we will never be able to get rid of power, obsessors about power, or even dictatorships, or even shift the world order that we've been talking about. Those dominant imperial powers who are dictating what the world should look like and how resources are distributed and who get the access to resources and who doesn't get the access to resources, etc., is really a critical moment now to really dismantle. Like, we need to overhaul systems like healthcare systems. We need to overhaul those systems, but other systems of power that influence health and education and media and everything else need to be completely, entirely dismantled and rebuilt from scratch. I had more creative ideas for the statue, but I can put that in the chat.
No, we'll have another meeting, but I just wanted to end on a final point. We have looked in this session at women and girls and minorities' access to health, considering how COVID-19 has impact on health systems that have already been dealing with conflict, occupation, sanctions, economic and political crises. This has been an extraordinary stress time, especially for those who have already experienced trauma. To end on a final point, we have looked at this session at women and girls and minorities' access to health, considering how, yes, I'm repeating myself again, it's okay, because we need to be thinking about our response to the stress and depression coming out of this crisis. Of course, for many people, the end of this crisis is still a long way away. There is no vaccine equality, and that is going to add even more further to the stress of this crisis. I would just like to end, and I would like to thank everybody. And in terms of the center, we can talk about that, but training and research and mediation and negotiation and all of this are things that are needed on the ground that women need, so we can have a different discussion of exactly how we can support each other in terms of the center, but there's plenty of need. Thank you very much, everyone. This is great. At first, I didn't know 90 minutes was too much. We didn't know how we really are going to have a very interesting discussion, but we did. We finished on time, almost 2 minutes over. Thank you very much.
Thank you.
It's 3:45.
Thank you. Standing ovation. Thank you so much. And I look forward to your ideas about the sculpture. And I like the bird woman. I have one in my home. Thank you all so much. We'll be meeting back at 3:45. That's like 10 minutes from now. And if you're so inspired, please join us for the concluding reflections, because we really would love to hear more of your inspired and spirited voices. So thanks so much. And it's been a pleasure.
Thank you so much. The pleasure was all ours. Thank you for inviting us. Thanks to the audience. Thanks to the questions. Thanks to everything. Thank you very much indeed. Bye. Thank you to the panelists.
Hi, Celia. Hi, Luciana.
Hello, Esperanza. Do you hear me well?
Very well, thank you.
Perfect.
Perfect. Good. Luciana, you are not presenting PowerPoints, are you?
Am I actually? I just have a few slides.
Good. And have you tried to upload them with no problem?
No, can I share the screen with you just to see if it works?
Yes, let's see.
Okay, great. Let's see. 1 second.
Perfect. Yes, it works very well. Okay, good. Great. Okay, fantastic. So and I can hear you very well.
Perfect. Thank you so much.
No, welcome. See you soon.
Go ahead. Right, it's 3:46 right now. Good afternoon again. After our short break, we're here for session number 3, our final session, which of course is a very important session about healthcare and COVID-19 social change. Those of you who were, perhaps if you're not here in earlier panels or in the morning, Juby Goodarzi, I'm one of the co-directors of the MENA Center for Peace and Development. I would like to start out with introducing our moderator. We're very privileged today to have as moderator Dr. Esperanza Martinez with us, and she will then, of course, introduce in due course the panelists. So Dr. Esperanza Martinez is a global and humanitarian health expert who is currently leading the International Committee of the Red Cross's, the ICRC's COVID-19 crisis response. Before that, prior to that, she was the ICRC's head of health and also was responsible for the provision of essential healthcare services to people affected by armed conflict and violence in more than 80 countries around the world. She is by training and by education is a medical doctor and a general surgeon who was trained in Colombia and specialized in international public health and health management in Australia. Her experience includes over a decade of fieldwork in conflict-affected countries, as well as work with different UN agencies, government bodies, and also the private sector. So we're very privileged, as I said, to have such a distinguished moderator. And I will hand over, with no further ado, to Dr. Esperanza to lead this very important session, final session, but nonetheless extremely important session on healthcare and COVID-19. A huge challenge, of course, with regards to the MENA region, and in addition to all the other problems that it's facing. Thank you very much.
Thank you very much for the introduction. And it's a privilege to be here with you and also to have the conversation that will explore the intersection between COVID and healthcare in the Near and Middle East, and particularly the changes in the dynamics that we are seeing. And it will be an interesting conversation, and I can assure you. So if we look at the Middle East, basically the MENA region was already facing a number of humanitarian needs prior to COVID-19. We have many of those humanitarian needs derived from conflict. You have the Syrian conflict, the continuing fighting in Yemen, the overburdening of systems, for example, the health system in Lebanon with the arrival of refugees coming from neighboring Syria, the unstable situation in Israel and the occupied territories, or Iraq as well. So wherever we look in the Middle East, you see all of these pockets of humanitarian needs that were prior to COVID. So what has happened, basically, COVID has added this additional layer of suffering on communities. And more importantly, the fact that COVID is not only a health crisis, but a socioeconomic crisis. So it opens a number of questions in relation to what changes are we going to see short-term, medium-term, and long-term, not only in terms of healthcare or access to health, but also in the social fabric of the communities that we work with, many of them affected by humanitarian crisis. 1 hour, a little bit more than an hour, will not be enough to unpack all these questions, but I think we will be able to look at some of the most critical challenges. And to help us, I'm really having a privilege of being here with colleagues from IOM, UNHCR, and Action contre la Faim, Action Against Hunger. And I would like to present the speakers. So we have with us Maria Luciana Scheretti, who holds a master's degree in international affairs and has more than 10 years of experience in public health. She has worked for the French Ministry of Health, various NGOs in sub-Saharan Africa, as well as in Latin America, and is currently working as migration health coordinator for IOM in Morocco, where she coordinates a multi-country program which aims at guaranteeing access to healthcare for migrants in Morocco, Tunisia, Libya, Egypt, Yemen, and Sudan. So Maria Luciana, a pleasure to have you with us today. We will have as well with us Bénédicte Duchesne. She is a clinical and cross-cultural psychologist with more than 15 years experience in research and practice in mental health and psychosocial support in humanitarian settings. And she has worked with NGOs, universities, community-based organizations, and UN agencies. And she currently is the MHPSS Senior Officer for UNHCR in the MENA Regional Bureau in Amman. So Bénédicte, also a pleasure to have you with us. And in the presentation of Action Against Hunger, we have John Cunliffe and his colleagues, two of his colleagues with us, and he will introduce Noemi and Sami a little bit later. John has worked, after an spell in the military, he became a nurse and then went to study tropical medicine. He started his work with Action Against Hunger in 1990 in the Democratic Republic of Congo. And since then, he has led humanitarian responses across the world in so many different countries that include Somalia, Syria, Iraq, South Sudan, Burundi, Indonesia, Turkey, Ethiopia, and Jordan. And for the last 12 years, he has been based in the Middle East. And since 2017, he has been directing all operations of the organization to alleviate hunger and the causes of hunger in this region. So to enter into the conversation we're going to have today, I would like to turn to Bénédicte first. And Bénédicte, there is growing evidence of the impact that the COVID-19 crisis is having on mental health and psychosocial needs of people in all levels, young, old, single, with families, in the Middle East, in Asia, everywhere. So I would like to turn to you to see specifically from your perspective and the work that you do, because globally, basically, your work focuses on refugees and other populations that have been forcibly displaced, and particularly in the MENA region. What can you tell us about their MHPSS needs, their mental health and psychosocial needs, and what are the challenges that we can see facing today and that we need to be prepared to face in the future? Over to you, Bénédicte.
Thank you so much, Esperanza. Very honored to be part of this panel today. I will try within the next 15 minutes to answer this very relevant question. I'm going to use a PowerPoint. For this purpose, I'm going to stop the video, and you should be able to see the presentation in few seconds. Perhaps now, can you confirm if you can see the presentation, the slide?
Not yet.
Not yet.
Not yet.
All right. Just a second. If
no,
it's not working, because the one which is quite weak at the moment, is there a possibility, Esperanza, that from your side,
I will try to
able...
share it from my end. Just a second, please.
Thank you so much, and apologize for this inconvenience.
No, just see, share the screen, and then I will see. Sorry. Perhaps one moment. I just need to find the right screen to share with you. I apologize. It always happens in this type of panels. It's just to have the last minute glitch.
Absolutely.
It should be okay with us. Just in a second.
Perhaps I managed. Is it working now?
Yes, now we can see it, please.
Fantastic.
Go ahead, Benedict.
Thank you very much. And again, apologize for this. Within the next minutes, I'll try to give you an overview of the overall context in MENA, in which UNHCR is operating. We look at the mental health needs related to the COVID-19 pandemic. And then I'll give you an overview of the challenges and the main strategic areas of UNHCR response in the MENA region. The context in MENA encompasses 16 million refugees, including person of concern, refugees, and other forcibly displaced populations. We're talking about IDPs, asylum seekers, stateless persons. The majority of refugees are actually living in urban context. There are also person of concerns in camp settings. The most represented population includes Syrian, Iraqi, Somalian, Sudanese, Yemeni, and Malian refugees. And I just want to switch directly to the core of my presentation, which is related to the mental health and psychosocial needs. And I think this COVID-19 pandemic has been a catalyst for change and a better understanding of the importance to include mental health as part of a health response. So for UNHCR, MHPSS is an integral element of its protection mandate. How do we understand mental health and psychosocial support within UNHCR? It is a cross-cutting topic. We do not see mental health as a standalone sector. We are promoting the mainstreaming of psychosocial support considerations within the different protection areas, such as child protection, GBV, community-based protection, as well as education, case processing, and of course, there are very close interactions between mental health and psychosocial support and public health. I'll try to give you an overview of the mental health and psychosocial needs among refugees and other forcibly displaced populations in the region. According to global estimates from the World Health Organization, more than 22% of adult population in conflict-affected areas suffer from mental health distress. Among those, 5% risk to develop severe mental disorder. And forcibly displaced populations are exposed to different stressors, in all the phases in their flight experience. The exposure to extreme adversities, traumatic events, persecution, separation, and losses in the countries of origin or during the flight. But the living conditions can also represent a very high level of stress related to socio-economical challenges, lack of social support in the host country. And in situation of protracted crisis, research has shown that the lack of durable solutions, the uncertainty toward the future, the feeling of being trapped, being stuck, it's something we hear very often from refugees. This feeling of disempowerment represents severe risk to develop severe mental health distress as well. And since the onset of the COVID-19 pandemic, there has been an increase in protection risks and vulnerabilities. Those are exacerbated pre-existing mental health conditions and inequalities, but created new vulnerabilities as well. And those new vulnerabilities have become a tipping point to develop psychological distress, even among individuals without a history of mental illness. So there is a strong interaction between protection risks and mental health. These are the challenges that are exacerbating the mental health disorders among our persons of concerns. For instance, the lack of reduce of livelihood related to the pandemic, the family separation, isolation, weak national health system, limited access to information for refugees about the pandemic, difficulties in accessing health services. These remain a very important barrier for UNHCR person of concerns to be included in the national health response. And of course, the history of mental health condition has, of course, a detrimental effect. That is a brief overview of the forms of psychological distress and mental health conditions that are commonly reported in the MENA region among refugees. Recent reports from UNHCR partners in the MENA region reveal that the majority of children are living in a state of toxic stress. Stress appears when a child experiences strong, frequent, and prolonged adversity. And this may lead to long-lasting and acute psychological and health consequences. According to the NRC, more than 88% of displaced children in Jordan, Yemen, Iraq, and Syria report psychosocial distress related to the pandemic. We have received alarming reports of increase in suicidal behaviors and deliberate self-harm within the last 12 months. So this is a growing concern for UNHCR in the MENA region. And of course, UNHCR partners on MHPSS noted a sharp increase as well in the needs for specialized mental health care. So what are the challenges when we are talking about access to mental health care in the MENA region? There are numerous challenges and barriers that are directly impacting the help-seeking behaviors among refugees, asylum seekers, and IDPs. The first one, I would say, the lack of awareness and the misconceptions around mental health. Those can significantly impact the recognition of early signs of psychological distress. They can delay access to treatment and may lead to the deterioration of the person's condition. In the great majority of MENA countries, the need for mental health care is far greater than what can be provided. There is a very, very limited number of psychiatrists and psychologists. And unfortunately, too often, MHPSS is deprioritized or absent in national program. And this is, of course, a strong limitation to implement our response. And in addition, where existing, the accessibility to mental health services remain highly challenging due to the socio-economical situation of refugees. So despite those numerous challenges, I would like to share with you the framework of UNHCR partners' interventions in MHPSS response to COVID. Basically, our response was based around two main goals. The first one was to address new emerging mental health needs related to emerging vulnerabilities. We talked about the socio-economical aspect, the impact of family separation, multiple displacement. The second objective is to ensure that refugees and IDPs with pre-existing mental health conditions, suffering from post-traumatic stress disorder, severe depression, psychotic disorders, those people need continuous access to medication as well as therapeutic support. So our response included a major shift in the modalities of intervention, and UNHCR response has shifted to remote interventions. This included that some mental health services were provided remotely over telephone or internet, while essential clinical mental health care, provision of psychotropic medication continued to be delivered safely and scaled up wherever possible. You can see on the right, this is the screenshot of a report that was published by UNHCR in MENA last June. It's already been a year, I just realized now, which is highlighting the different type of activities implemented on mental health and psychosocial support during COVID-19. Some of those activities included awareness raising and sensitization. This was done through different media, WhatsApp group, social media, as well as radio program. Helplines were developed in different languages as well. For specialized mental health services, psychologists and psychiatrists, the service were maintained remotely, as I mentioned earlier. And we trained our frontliners on psychological first aid, which is a scalable intervention aimed for non-mental health professionals to ensure that anyone interacting with a refugee is able to identify signs of psychological distress, adequately manage the situation, for instance, providing key counseling lines if it's done on the phone, basic calming technique if the person is having a panic attack, for instance, or responding to threat to self-harm adequately, and refer to adequate services. So identify, manage, and refer are the key elements of the psychological first aid response. And we are really promoting the mainstreaming of this approach within our different sectors of intervention. Of course, the core protection services were maintained. This includes remote registration, the refugee status determination. This was done remotely. We continued the provision of individual case management services, and our hotline were operating 24/7. I will pass through the different activities. This was my last slide, actually, so I will perhaps have some time to detail a little bit further what was done within specific country operations. I can share the example of Iraq, for instance, where the community outreach workers integrated key messages on mental health to their ongoing activities, visiting families to provide key informations on COVID-19 prevention. This was an opportunity to integrate mental health, and we know that it's highly stigmatized And we do never see a refugee coming directly and knock on the door of a psychologist or a psychiatrist. This does not happen. However, we see the importance of community-based interventions. We see the importance of multisectoral approach. And I think within COVID, we have seen a very interesting synergies between community-based protection, public health, and mental health and psychosocial support, integrating those key messages on positive coping skills or parenting skills, or even homeschooling for parents who felt completely overwhelmed by this new way of learning for their children. Those messages integrated to public health communication were positively received by our person of concerns and facilitated the referral to more specialized services wherever needed. I think I will stop here. Thank you so much for your attention, and I remain available for further questions. Over back to you, Esperanza. Thank you.
Thank you very much, Benedict. That was a very good overview of the situation and the work that you are doing in the MENA region. And as you said, many of the issues were there before, but they have been exacerbated by the pandemic. We will have the opportunity towards the end of this presentation to discuss a little bit more. And if you have any questions in the audience and you would like to post them, please let us know, and we can take some of them at the end. So thank you, Benedict. Now I'm turning to you, Luciana, because one of the things that we see and we are hearing very often is the element of people on the move. So we just hear about the refugees, but people on the move mean so many things. There are refugees, there are displaced people, there are people that migrate for economic reasons and for different reasons. So really it is this kind of generic term doesn't really tell us the story behind the different groups and the different risks and vulnerabilities. Specifically, you are working in your role with IOM, you are working with migrants. And one of the roles and the job that you have been doing is really health policy to ensure that migrants have access to healthcare. So really would like to hear from you, your experience in drafting and implementing this policy, and more importantly, what has happened with COVID-19, how the implementation of this policy has been affected, if at all. In your perception. So over to you, Luciana.
Thank you very much, Esperanza. I'm gonna also share my screen with you as I prepare the presentation to answer to your question. Do you see my screen?
Perfect, thanks.
Great, thank you so much. Yes, as you mentioned, I'm currently coordinating a multi-country program at IOM. So it's coordinated within IOM Morocco, but it covers 6 countries of the MENA region: Morocco, Tunisia, Libya, Egypt, Yemen, and Sudan. And the aim of this program is basically to guarantee health access to healthcare to migrants in those countries. So one of the main issues would be to have the proper health policy that will enable to include migrants. So I'm gonna mostly focus on Morocco in my presentation, which is the country who has the most developed migration health policy in the region. I'm going to also cover the COVID-19 response towards migrants in Morocco, but I'll be happy to further expand to the other countries as well and during the conversation. So, let me see. Yeah, so my presentation will have 2 main focus: migration first, because of course it's the area of expertise of IOM, but most importantly because analyzing the health policy towards migrants is very much indicative of the state of the health system of the country. And as I said earlier, Morocco has a pretty unique health policy towards migrants in the region that I'm gonna try to briefly present. And then the second focus of the presentation is COVID-19, because analyzing the COVID-19 response towards migrants, again, always with this migration lens, is in turn indicative of the implementation of such policies. So we're going to be able to see what works and what doesn't. So allow me to first briefly introduce the migration flows and data in Morocco particularly. So as you are all aware, Morocco has this pretty strategic location in the North Africa, in the African continent, in the North Africa part, and it is at the crossroads between Europe and Sub-Saharan Africa. Traditionally, Morocco has been a country of immigration. There are 2.8 million Moroccans estimated to be living abroad, and with the second generation, this number goes up to almost 4 million Moroccans. However, Morocco has increasingly become, I would say, in the past 20 to 25 years, a transit and a destination country for migrants, particularly coming from sub-Saharan African countries, Senegal, Mali, Nigeria, Cameroon, Congo, among some of them, but also from European countries, especially France and Spain. So we only have estimation figures on the number of migrants there are currently in Morocco. There are no official figures, but IOM, with its own migration data portal that takes into account surveys and census, estimates there's more than 100,000 migrants currently in Morocco. And among those migrants, 1 in 4 migrants would be in an irregular situation. So around 25% of those migrants are estimated to be irregular. So Morocco has been in the past decades a migration champion at international, regional, and national level. So these changes in the migration patterns that I have shown in the previous slide have triggered changes in Morocco's role in the international and regional migration governance. So just to brief a few events that were either organized, hosted, or co-hosted by Morocco. We have the co-chair with Germany of the Global Forum on Migration and Development in 2017 and 2018. Morocco has also hosted the Intergovernmental Conference in Marrakesh that adopted the Global Compact for Migration in December 2018, and will be hosting in July this year the revision of the Global Compact for Africa. Morocco has also been a migration leader within the African Union since 2017, and it has participated in several negotiations, joint declarations, and partnerships with the European Union. So these changes in migration patterns in the country has also triggered changes in the national policy. And in 2013, the King Mohammed VI announced a new migration policy that was intended to be much more human rights based and focused. So I'm gonna briefly introduce 2 of the main aspects of this new migration policy. The first one is the National Strategic Plan on Immigration and Asylum, also known in French as SNIA, that was adopted in 2014. So this was the first strategic plan on immigration and asylum in the country, and it had this specific objective of guaranteeing migrants access to basic rights and services such as health, education, social housing, and employment. And one of the biggest consequences of this new migration policy was the 2 regularization campaigns of irregular migrants. So in 2014, the Moroccan government regularized around 23,000 migrants. And in 2017, there was this second wave of regularization. We do not have the official number of how many migrants became regular, but we do know how many requests were filled, and it was around 26,000. And this strategic plan has also a health component, and it's for the first time that it is written in a policy document that migrants and refugees have access to health care in Morocco to the same extent as Morocco. So after the adoption of this first strategic plan, there was a much more focused plan on health and immigration that is going to be validated and approved this year, hopefully during the summer, and which is the National Strategic Plan on Health and Immigration. So this plan falls within the resolution 60.17 of the World Health Assembly of the WHO, asking member states to develop migrant-sensitive health policies and to promote the health of migrants. So this plan is much more operational. It establishes a framework with objectives, outputs, activities that are going to be put in place in order to include migrants into the health system and to promote migrants' rights and health. So just to highlight a few measures that were undertaken in terms of migration health since this new migration policy, we have the fact that regular and irregular migrants benefit from free primary health care and delivery as well at health facility levels, as well as from vertical programs such as HIV and TB and vaccination. And as you know, these vertical programs, especially HIV and TB, are backed by the Global Fund in country. So these, everything that has to do with prevention and healthcare of HIV and TB are completely free for migrants. There has also been a convention between 4 ministries in Morocco to create a health coverage system for migrants and refugees with a basket of services that go beyond the primary health care. And the intention of this was to make a system that would be pretty similar to the CAMED, which is the health coverage for the poor that is currently existing in Morocco. Then another aspect of this new policy was to very much stress and highlight the need of training of health professionals in everything that was related to migration health topics. For example, some tropical diseases that are not endemic in Morocco, but are endemic in countries from where some of the migrants come, for example, malaria. So there has been, since 2018, ongoing trainings of health professionals in those regards. There has also been quite a lot of sensitization of migrants and health professionals on migrants' rights, and of course IOM has been accompanying the government in all of these steps. So I'm gonna now talk about COVID response in Morocco, and especially focusing on migrants. So first, allow me to briefly give you some figures about the COVID situation in country. So this information is from WHO as of 2nd of June 2021. So there has been, since the beginning of the outbreak, around 520,000 confirmed cases of COVID in Morocco, with a peak around October 2020. And there has been around 9,000 deaths. And as of June, 1st June 2021, there has been a total of 14 million vaccine doses that have been administered in country. However, we do not have, again, specific data on migrants. So there was a COVID-19 response plan that was put in place by the government in 2020, whereby regular and irregular migrants have free access to a diagnostic test, PCR, but also healthcare services at hospitals. We have around 500 migrants in 2020 who could benefit from healthcare services at hospitals for free for COVID. However, we do not have that figure for 2021 yet. Regular migrants have also access to vaccination. The vaccination campaign in Morocco started around January in this year. However, only regular migrants have access because in order to have the appointment for vaccination, migrants need to have the residency card. So, of course, irregular migrants are being currently excluded at this stage. So access to information and sensitization sessions on COVID-19 have been produced in Arabic, French, and English, and there has also been access to mental health and psychosocial support, mainly through civil society organizations such as Caritas. So this is just a highlight of the services that have been provided for migrants related to COVID-19 in Morocco. So there are, of course, some barriers encountered in terms of access to healthcare for migrants. So there has been operational barriers to formalize this health coverage system, enabling migrants to have access to secondary and tertiary care. However, COVID-19 has proven to be an opportunity to further extend the access to care beyond primary care services, because we have seen that migrants that were affected by COVID could have access to health care to the same extent as Moroccans. As I previously said, unfortunately, irregular migrants remain excluded from vaccination at this stage, and IOM is continuously advocating for their inclusion into the vaccination campaign. We saw previously in Benedict's presentation aspects of mental health and psychosocial support. So this is an area that was very much important during the COVID-19 pandemic in Morocco. So MHPSS services for migrants that have been highly impacted by COVID remain pretty limited and are mainly supported by civil society organizations. And the last point about the barriers that we encounter is that data on migrants are not yet included into the health information system, so we do not have specific data on the migrants' needs, which of course it's pretty difficult when we implement programs that are specifically targeting migrants. So this is an area that where we are seeing a lot of improvement, and IOM is currently working with the Ministry of Health in that regards. So we hope that we will have data on migrants included into the health information system. So this is the end of my presentation, and of course I remain available if you have more questions with regards to the health policy in Morocco and the COVID-19 response. Thank you so much.
Thank you, Luciana, for this presentation. And you bring the issue of data, and the data of migrants is not available. And that's, I think, one of the big gaps we have seen in this crisis is exposing the weaknesses of health systems to capture key data. And not only on migrants, but we also see, for example, the recording of deaths. And the estimated number of deaths today is probably hugely underestimated. There are already studies coming out suggesting that we are way over 10 million deaths associated with COVID worldwide. So it's really an element that you bring up to the table. And I think with the next speakers, we probably are going to hear a little bit more on other aspects of the health systems that are shown to be quite weak during the pandemic. And some opportunities as well. I really like what you brought up, which is this element that also provided opportunity to test the system, to test the access to secondary and tertiary care. So there are some aspects that we will try to capture at the end in the conversation. So thank you, Luciana, very much. John, pleasure to see you. I know that I have some of your colleagues, Naomi, and I'm not sure if it's Paul or Sami that will join us. And I know that you have been participating earlier in the conversation. But John, if I can give you the floor, your organization, Action Contre la Faim, is an organization that basically works in some of the most dire humanitarian crises. And many of them are due to armed conflict, and many of them are in the MENA region. So really will be important to hear from you this confluence between healthcare issues, COVID, and the reality of war, because that's what we are having today as well. So I will hand over the floor to you to introduce your colleagues, please, and then to hear from them.
Thank you very much. A pleasure again to be with everybody this afternoon. Obviously, I think the Middle East is one of the regions that's been most touched by COVID. I say that just because of the demography of the region and the state of the incomes that have been, money that is coming into people's pockets here means that we've had an aging population that hasn't had access to healthcare systems that they wouldn't have normally aging populations in parts of Europe and other Western countries. So very much the stage of development of these countries has meant they've been particularly hit hard. Indeed, Jordan at one stage, I think, was the country with the highest rate of infections, and Iraq has never been far behind that, particularly because we don't have that accurate a figure for what has been happening in Iraq. So I'm going to turn over, first of all, to Paul Critchley, who's our country director in Iraq. Paul has been with us for a good while now. He's been an aid worker for 22 years and has worked with a number of organizations, including ECHO and IOM, as well as various NGOs, and has been in the Middle East for a long time as well. After that, he'll be turning over to Naomi. Naomi, again, is going to be looking really at the mental health and psychosocial support side of things and how it's actually done now, particularly in the context of COVID, how we can actually get some things done. And again, Naomi's highly experienced in the Middle East, has been in the Middle East for about 10 years as well. So let's start with Paul. Over to you.
Good afternoon, everyone. Let me just, is my screen successfully shared?
Yes.
Yes.
Good. So I'm going to give you a snapshot of Duhok Governorate, which is, and COVID within Duhok Governorate. It's the northwestern governorate of Iraq within the Kurdish region. As those of you who are in the earlier presentation, the healthcare system in Iraq is focused on, or has been focused on, secondary and tertiary curative care facilities, with little focus on, traditionally on public health or primary healthcare facilities. And it has a weak health information system generally. The start of the COVID pandemic, the healthcare system had been starved of funds for a long time. For example, and to give you an idea of the level of funding, in 2018 in Switzerland, the government spent 11.88% of GDP on healthcare. In the same year in Iraq, it was 4.11%. And due to political divisions between federal Iraq in Baghdad and the Kurdish regional government in Erbil and the KRI had limited funding coming to it from federal coffers, which has extended the time that the departments of health here have been starved of funding. The Duhok Governorate did do COVID planning and COVID contingency planning, but the contingency planning wasn't really effective to a certain extent. They did try to renovate a disused medical facility to bring it in to start treating COVID patients. That was a 10-bed facility. And at this time, which was July last year, when I first visited Duhok, the deputy governor said, we don't really have a problem here. We've traced all the patients. We don't have it in general population. It's not an issue. They'd also planned and contingency planned to increase bed space and bring in other medical facilities as the pandemic increased to increase their capacity to treat COVID patients. And also for patients who were positive for COVID but didn't need medical treatment, because of the family structure in Iraq, people would find it difficult to self-isolate at home and not pass on the infection to family members. So they used 6 hotels to try and allow people the option and the opportunity to self-isolate if they had COVID. Now, when they did try to implement their sort of gradual extension plans and bring in more beds, even though these plans were discussed and it was not new to the medical staff in these hospitals that were suddenly had to treat COVID patients. Doctors and nurses left. They didn't turn up for work. There was a shortage of PPE, both in terms of quality and quantity. The lack of the ability to separate patients on arrival, with COVID patients coming in the same doors as patients coming in for normal medical treatment, a lack of capacity and a lack of the capacity to increase infection control measures within hospitals meant that there was transmission in hospitals, both to other patients and to medical staff. And the clinical waste management facilities in the hospitals were not capable of dealing with the increase in medical waste that COVID has been producing. On the public health side, measures were put in place, but they were never really enforced. I arrived in Iraq on the 17th of June last year, and at that stage, only shops selling foods should have been opened in Erbil. As I drove from the airport, I was shocked that every shop was open. No one was wearing masks. There was no social distancing. The public health measures just weren't being enforced. Business, yeah, like I said, businesses were open.
John, so just a quick question, John. We are only seeing the first slide, just for your information, if that is...
Is you right? Let me close. Can you see?
Yeah, now we can see it. Okay. Yes, now it's moving. Thank you.
Well, yes. In August 2020, a month before the disease peaked in its first wave, in KRI, in the Kurdish region of Iraq, all public health restrictions were removed. A senior official within the Kurdish regional government explained it to me that they needed to focus on the economy and that they could accept COVID deaths and the increase in the pandemic. The numbers kept increasing, and by October, the Hook Governorate had the highest incidence rates in Iraq. More than 20% of the hospital's bed spaces in Duhok were dedicated for treating COVID patients. Despite the fact that the head of the Directorate of Public Health in Duhok Governorate, his medical specialization is clinical psychology, he was, or psychiatry, he was deprioritizing mental health and psychosocial support within Ministry of Health to enable the health department to treat COVID patients, even when he was asking us to provide mental health and psychosocial support to DOH staff. Later that month, a doctor in a private health facility assessed the situation that the public hospitals were full, and indeed at that time one of our staff had COVID, needed medical care, and we could not get him into a public health facility. At the moment, Duhok has the third highest incidence rates of COVID in the country. Yesterday, or the day before yesterday, I had a meeting with the head of the Joint Crisis Center in the Kurdish region of Iraq, which doesn't just look at COVID, but it looks at other issues. And he was openly wondering whether the end result of COVID would be more deaths due to lack of healthcare or the focus of healthcare on COVID, causing increased mortalities due to other diseases going untreated. So, yeah, we won't see this for some time. Whether we ever get the figures out of a health information system that's of limited strength, we don't know. But the health system is really stressed within the whole country. And Duhok, believe it or not, is quite good in comparison to some other areas. Thank you.
Thanks, Paul. I'm going to jump in from here and focus a little bit about the situation in Jordan. You know, Benedict and I didn't have a chance to talk before this this session, but I think there will be a lot of commonality and coherence around what she was talking about on the broader scale in the region and the mental health situation here in Jordan. So forgive me if I'm repeating a few points, but I hopefully will be able to focus quite a bit on the situation here. For those of you who aren't so familiar with the Jordan context, I'll give a little bit of background before I start. Unlike a lot of the other countries that people have spoken about today, Jordan is a relatively safe country. It's been a refugee receiving country for many, many years. And so while we don't see the same challenges that you would see in a complex humanitarian environment like Syria or Yemen, we do face a number of unique challenges because of the large number of refugees who are living in Jordan. There are about 10 million people in Jordan total, and there's over 1 million Syrian refugees alone. There's also Iraqi refugees and Palestinian refugees. Jordan's also one of the most water scarce countries in the world. So you can imagine with a 10% increase in population over the last 8 years, that's had significant strains on the natural resources that are available in the country. It's also worth noting that though women are 50% of the population, in 2017, only 17% of Jordanian women were economically active. That's compared to 59% of Jordanian men. Those numbers are anticipated to be significantly less for refugee women because of the unique ways that refugees are limited in their ability to access livelihoods and engage in economic activity. And that's important because when I start talking about the mental health situation, particularly due to COVID, many people indicate that socioeconomic stress is a major cause of their own depression and anxiety. I'll also just finally add that as was mentioned in the session about about gender and minorities, women do play a really key role among refugee populations in Jordan in reproductive work in the household, which also further restricts their ability to economically engage outside of the household. So it adds to the complications of their ability to engage in that way. From there, Paul, if you can go to the first slide. So the pandemic in Jordan hit a bit late, and initially there were quite few cases. It was identified as clusters of cases in the beginning of the pandemic, and there were more major waves in December of last year and February of this year. But despite that, there was early and quite aggressive lockdowns in Jordan, including a full lockdown in March of last year, closing all schools and universities, borders were closed, people were not allowed to leave their house for any reason at all except for emergencies for the first couple of weeks of the lockdown. Following that initial quarantine, there was a easing of restrictions, but there remained an evening curfew and a Friday lockdown up until just a couple of weeks ago. So you can imagine the impacts that that has if you can't go after your work to the store or to a restaurant or get the needed basic items for your household. It significantly limits people's ability to meet their basic needs. In addition, I think it's worth noting that, like in many countries in Jordan, COVID regulations were managed by the Ministry of Defense, not by the Ministry of Health. And that's important to note because the mandate of having that under the Ministry of Defense changes the way that we as humanitarians could engage in the conversations around the needs for humanitarian populations within the broader spectrum of COVID mitigation measures. Essentially, the infection control measures that were put in place across the country were also applied in refugee camp settings, and those populations are completely dependent on external support to meet their basic needs. Humanitarian organizations like ACF were not able to do basic food distributions, to run centers within the camps where people would normally get together and provide support to each other. It really limited the ability for people to initially engage in community engagement and risk communication about the pandemic as well. So there was a need for really immediate and quick shifting of thinking of the way that we work and strong advocacy to encourage an ability for us to return to working in those environments. I think you can move from there to the next slide, Paul. Like in many contexts with the COVID-19 pandemic in Jordan, resourcing for health services quickly focused on the COVID-19 prevention, mitigation, and response measures. And in a context like Jordan, this meant an immediate and significant gaps in healthcare services, particularly for service provision for communities that are largely serviced by NGOs. There was a shifting of centralizing health services at a hospital level. So smaller rural health centers were closed. So populations who might not have the resources to access hospitals were not able to do so. In addition, refugee populations who might not have legal documentation cannot access services in the public hospitals. So they were left with very few options for accessing health services. This impacted both COVID mitigation and response, as well as the overall health environment in Jordan. We immediately saw a number of people who couldn't access sexual and reproductive health services, communicable disease services, and really a focus from the government on COVID-19 and not on these complementary health services. And in addition, I think it's worth noting that these aggressive lockdowns quickly resulted in a number of populations adopting negative coping strategies. Socioeconomic challenges resulted in an increase in mental health needs among both refugee populations and vulnerable Jordanians. But with this focus on COVID-19, mental health was deprioritized among health service delivery from the government quite early in the pandemic. As has been mentioned by a number of other speakers today, in most humanitarian contexts, refugee and displaced populations tend to have higher mental health needs than host communities because they've gone through a trauma during or before their displacement. This has definitely been observed in Jordan. I think there's been a recent UNICEF report that says 85% of Syrian refugee children live in poverty, and half of them suffer from nightmares, various forms of sleep problems, and bedwetting as a result of distress from being refugees themselves. To complement that, a recent study indicated in Jordan, 4 out of 10 Jordanian respondents experienced some level of quarantine-related anxiety. Women and people from large families, which of course represent a number of refugee populations, have higher levels of anxiety. Notably, at the beginning of the quarantine in Jordan, Families Department reported a significant higher number of calls for support from women who were experiencing violence within their home, which was a trend that we saw throughout communities in the Middle East. At the beginning of the year and following the quarantine period, we conducted a study to look at the continuing mental health needs among vulnerable Jordanians and refugee populations due to the pandemic. And an overwhelming 94% of people that we spoke to had indicated that COVID had had a negative impact on their life. Interestingly, the 6% who could identify something positive said that the best thing about it was that they could spend time with their families, which I think is a nice thing to point out in a day full of some not so nice things. However, the majority of respondents are facing stress due to their unemployment and due to financial burdens related to that unemployment. And they are struggling to meet the basic needs for their households. The respondents to our study were largely refugee and vulnerable Jordanian populations, which of course is a small subset of the Jordanian population. But there was a particular focus from our research on populations in informal tented settlements, which tend to be the most vulnerable of refugee populations in Jordan. Among this population, the anxiety and depression rates were similar to the population of hospitalized COVID patients, which give you a sense of the bleak situation in these informal tented settlements. These populations were largely unable to access services available from the government because largely they're not legalized refugees in Jordan. From there, you can go to the next slide. Maybe the next one after that, actually. Perfect. So while the mental health situation during the COVID-19 pandemic and continuing today does need particular attention and particular intervention and concerted effort from humanitarian organizations. There have been a few successful adaptations, and I think it's worth noting some of those as opportunities for us to look for. I also think we've learned a lot as a humanitarian community during this period. Number one, and I think this was noted also by Benedict, but remote interventions have really been leveraged during the COVID-19 pandemic as a way to reach populations when there are severe limitations on movement. Humanitarian populations generally face severe limitations on movement. So this to me is a really successful adaptation that we've made and one that we can apply even outside of the COVID-19 pandemic. The remote interventions themselves are limited, and it does not replace in-person mental health services. And there's a really important need for us to strengthen referrals. As we scale up our ability to reach people through remote interventions, we have to equally scale up our ability to refer people and accompany people to make sure that they're able to access the services that they need. I also think one of the key interventions that was also mentioned by Benedict is around improving the ability for general service providers to identify and refer mental health needs. I think Benedict mentioned psychological first aid. For Action Against Hunger, we also worked with a number of primary healthcare providers to improve their awareness around mental health and psychosocial support and to provide referrals to specialized services when needed. That was really critical early on in the pandemic, as they were seeing a lot of people coming through their doors who had mental health needs. And I think many of those providers prior to these trainings didn't know how or when to refer people who might have mental health needs. This, again, is something that we should take beyond the COVID-19 pandemic and look for ways that we can integrate more mental health programming into primary healthcare where humanitarian interventions are present. And then finally, and perhaps this is the most obvious, but I do think it's worth pointing out, the COVID-19 pandemic has really forced us to consider better ways of integrating our programs. Admittedly, NGOs really do struggle to provide integrated programs. And for those of you not familiar with humanitarian contexts, that means one NGO might be doing food delivery, while another one is doing a health service delivery, and another one is making sure that people have access to water. However, with severe limitations on our movement and the movement of our beneficiaries, we've really had to rethink this model and find ways to leverage existing mechanisms to support both COVID-19 mitigation and response and other basic needs in these communities. As an example, as a primary provider of water in some of the refugee camps in Jordan, we looked at ways that we could better integrate mental health into the community mobilization that we had previously done around hygiene promotion. This was quite an interesting model, and we were able to leverage community focal points and community mobilizers and train them in PFA, psychological first aid, so they could similarly refer cases and link them to those remote services when that was appropriate. I think community mobilization has also been a key priority during the COVID-19 pandemic, and particularly in humanitarian settings where, as I mentioned previously, there was a lot of challenge at the beginning of the pandemic to get the right information across humanitarian communities. Sharing lessons in what had worked previously in community mobilization and translating that into community education and risk communication was really essential early on in the pandemic, so that we could ensure that communities knew how to keep themselves safe, even when they felt that many of the social safety nets they were used to were no longer present. I will pause there and hand it back to Dr. Esperanza.
Thank you very much, Naomi, for this overview in Jordan, which, as you mentioned, and the similarities with Benedict's presentation, it really resonates across refugee populations in the Middle East and in general. No? So there are common patterns there. And I really would like to pick up on a couple of points from your presentation and Paul's, which is moving into, yes, COVID-19 has been a devastating crisis in so many different ways. But as you said, there are also elements that have made us do things in a different way, that has somehow fast-tracked innovation, really is this need to develop things in a different way, think in a different way. And you mentioned two very important ones, different ones, but I pick up the issue of remote interventions, being able to open up hotlines and remote consultations for communities that before, and people that before couldn't even dream of talking to a specialist. So I think that that's an important element that hopefully we'll be able to preserve and really embed more into not only humanitarian programming, but also health systems. That will be a great achievement to moving forward. But then you mentioned one element, which is the need to complement that with a strengthening referrals. Because otherwise we provide the basic level services, but then we are stuck with those patients and individuals that need further care. And I am coming as well to Paul and a point that you mentioned with your example in Iraq, with very critical of the fact that secondary, this very strong use of secondary and tertiary care at the detriment of primary health care and preventive care. And it really caught us off guard, this pandemic, but the next one, we need to be better prepared at the preventive level and primary healthcare level. Otherwise, it will really hit us hard again. So we'll come back to those points a little bit if we have time, but I want to come back to Benedict and Luciana on this conversation, this last part. From your organization perspective, what are the kind of things that you see apart from these two elements of primary healthcare and the remote access to patients or to individuals? What do you see as a change that potentially we would like to keep moving forward, and how your organization or you see from your area of expertise influencing this as a positive change towards the future in relation to healthcare? Benedict, can I come back to you first?
Thank you so much, Esperanza. Just a few words. I think, as you were saying, that this pandemic also has created some space for change and innovations. And I think one of the major lessons learned throughout this process for our teams in the field has been this task shifting when we are looking at strengthening the capacity at community level on different type of interventions to support persons of concerns affected by the pandemic. So we talk about psychological first aid. We talk about the integration of PFA within, blended learning curriculum. So the training of teachers who are really involved in this daily support to children while they were doing homeschooling. And this integration of MHPSS within the different levels of the community-based intervention was crucial, and I think it really paves the way for further mainstreaming of MHPSS, even though I don't really like this word. I would say more integration of MHPSS within the different layers of intervention. But the task shifting is really, I think, Naomi touched upon it with the question of training of care providers on the specific evidence-based intervention. And this is a very strong element also in our communication with the donor community, since MHPSS is often forgotten. MHPSS doesn't mean that we need to hire more psychiatrists and psychologists. Of course, it's always better if we already have these resources. But the community can also help by, alleviating low or moderate distress. We can, strengthen traditional ways of coping. And for this purpose, we need to strengthen their capacity and invest more on trainings and supervision. And one element which I think is also crucial, and I will end here, is the importance of staff care, self-care as well. What we have learned is how much frontliners that are exposed on a daily basis to very traumatic experiences suffered from this COVID-19 pandemic, from healthcare workers, social workers, case managers, etc. So one element is that to keep in mind is really how we can further, enhance access to psychosocial well-being for our frontliners. Thank you so much.
Thank you so much, Benedict, for those thoughts and for this remark on looking after the workforce, that at the frontline workforce, to be able to then serve communities is quite an important element. Luciana, from your perspective, how do you see an area that we can look towards cementing, strengthening moving forward?
Thank you so much, Esperanza. In terms of migration and the work IOM has been doing in the region, we are accompanying governments into the inclusion and integration of migrants in the health policies, as I presented during my presentation. And I would like to talk now about other countries than Morocco, because I tried to highlight some improvements we have seen in Morocco as a sort of model in the region in that regard. But COVID-19 has been an opportunity really in other countries of the region, in the sense that IOM teams have been able to advocate for the mainstreaming or integration of migration issues and questions in governmental policies, and especially to integrate migrants in the health policies. There has been some initiatives in countries, for example, where they built these migration health desks within the Ministry of Health. There has been pretty positive initiatives in those regards in other countries who have not previously, before COVID, had health policies that would integrate migrants. So I would highlight mainly that, and yeah, the fact that when it comes to infectious diseases, we have to take into account everybody, and to paraphrase, of course, the UN motto, to leave no one behind, actually.
And no one is safe until everyone is safe. Exactly. So I think that the element of equitable access, and is the conversations with governments, actually, with the states, to say it doesn't matter what the legal status of a person is. If the person doesn't have access to healthcare or access to vaccines, it's going to really harm efforts that are for the community and for the global community as well. So I think that somehow has brought that element to the forefront. So it's really good to hear from organizations that are working on these issues, that you also see that as an opportunity, an element that is opening the possibility to talk about this beyond legal, illegal, regular, non-regular. That I think is quite an important element. And for us, I mean, from the ICRC perspective and working in armed conflicts, whether you live in an area affected by armed conflict, which is governed by the government, or under control of non-state armed groups, it doesn't matter. There are people at the day. So I think that has homogenized somehow the environment to discuss this. So John, coming back to you a little bit and to your team, any additional points, because we picked these very important points from Noemi and Paul, any additional ones that you think is something that we should take from this conversation and something that we should look forward towards strengthening our respective roles and work?
I think there's a real threat, and we've started to deal with the threat because we've had to deal with it. And that real threat to the Middle East as we move forward is obviously the stability of the region. And we're likely to see less institutional.
Sorry, John, I think we lost you.
Funding being directed to the Middle East. There's a lot of Western donors start.
John, we are seeing you on and off. While we recover, John, Paul, could I come to you a little bit? While we recover
my video in the hope that you can hear me better. Can you hear me now?
Yes.
Okay, I've cut the video. I'm not sure what's happening. I mean, the weather here is a bit complicated. I was saying that the real threat, to the region has been exposed. The fragility of the region has been exposed. And we've even seen an attempted coup, which would be unthinkable in somewhere like Jordan, which has happened. And so one of the things that's certainly going to happen is that our donors are going to be really prioritizing where they actually program their funding. And that means that we're going to be forced to change. And in some ways, we've already started that change. And one of the points that I wanted to make is just the fact that we've had to really move into localization. And that goes into communities and really start to look at more effective more delocalized, local programming for our communities. And that has been a success, I think, as well. And it's a move that a lot of NGOs have been forced to make because of the crisis, just for practical reasons. But it's something that we've really been forced to actually have to do. Naomi mentioned as well the collaboration side and the integration side of it. Again, this is something that we'll be building on in the future for more efficient, more effective programs, and building those relationships that we perhaps never had. I mean, Paul talked a lot about his discussions with the De Hoek Ministry, Department of Health. That's perhaps something that we wouldn't have done previously in that depth of detail and in the way that we actually did. So there are some positives that have come out because of the crisis, that we've been forced to collaborate in different ways that we haven't done so before. I think otherwise you've covered the other points that I would have mentioned. Thank you.
Very much, and you really you highlighted something super important. Since the World Humanitarian Summit in 2016 in Istanbul, we have been talking about localization, but trying to figure out in an abstract what that meant. Now here we just basically had to, because we just didn't have a choice. So it's picking up what worked and what hasn't worked moving forward. Paul, just very briefly before we wrap up, to you, as we got some very good points from Naomi. Any additional points from you before we close up the session?
Only that, access to healthcare goes with stable societies, and we've got to look at multiple underlying drivers of instability within all the societies that we're working in to address those if we want to move the access to healthcare issue forwards. If we just look at it in terms of, is this government doing enough for healthcare? We're not helping a society address the full picture.
Mm-hmm. And that is super resonant in the Middle East, where the stability is precisely what's lacking. Wherever you look, you can almost drop a pin anywhere, and it's an unstable context today, which is a problem. You seem more hopeful than generally we tend to be, but thank you so much. So really, thank you very much to all of you, and to the many of you who have been listening to this conversation. It has been enlightening. I have learned a lot, and that's very good when you moderate a panel and then you learn a lot from the discussion. So thank you very much. Really looking forward to seeing how many of these elements that you have brought to the conversation crystallize a little bit more. We are still in the middle of the pandemic. The main urgent need today is to get more doses of vaccines everywhere and to be able to reach populations that are not reached even with the most basic services, let alone with COVID-related services. But we need to think further than that. And that's, I think, what we have done today is beyond that. What do we keep? What do we build on? And what do we keep doing well in the future? So thank you so much for those elements, and really looking forward to another opportunity to be with you. And now I hand over to our host. I think, yes, I can see you there. Thank you so much to everyone. We seem to be.
Yes.
We can keep having a conversation, and don't worry.
Thank you very much, Dr. Esperanza, for moderating that panel. Thank you to all the speakers. Again, with Benedicte Duchesne, Maria Luciana Ceretti, John Conliffe, Paul Critchley, and Naomi Renat. Very grateful. We've come to the end of this event, this forum on healthcare, access to healthcare in the MENA region. I think we've covered a lot of ground since this morning. There's been a lot of food for thought, a great deal of in-depth analysis, much for reflection, and I think we've all learned a lot. So thank you. I wanted to thank our moderators, our speakers, for participating, and especially, to be quite honest, when we started organizing this, and as I may have mentioned at the outset, that this forum, the idea for this forum was the brainchild of my colleague Mary Velma O'Neill and also Renee Shegg. and I helped out. And because of what's happening right now, we're in the middle of the pandemic, and also with regard to the MENA region, in view of the multifaceted challenges and problems that the MENA region is facing, we really had to work hard, and it was very difficult to really find speakers, moderators and speakers. So for those of you who did participate, who did accept our invitation to moderate, to speak, we are highly appreciative, because we know that you have your hands full, you have a lot on your plate. And as I said before, I myself used to work for 11 years as a political advisor on the Middle East for the UNHCR before I went into academia. So I know there's a lot to do. So we're very grateful to you, and I think we've learned a great deal today. If I may say also, we are hoping to have a larger audience. I think part of this is, of course, because of the pandemic over the past 14, 15 months, there's a lot of, how should I say, digital or Zoom fatigue. But somebody asked earlier, and I think you know, the entire forum is being recorded, as it was recorded, thanks to our events coordinator, who you can't see. I think some of you have seen her, Celia Joachim. So we're very grateful to her for all that she's done. So it will be posted on YouTube, and will eventually also be posted on our own website, so people will have access to it. In terms of wrapping up also, this initiative, the MENA initiative, and then the approval by we are a satellite campus. We've been in Geneva now for 43 years, since 1978. We have 4 other campuses in Europe, in the Netherlands, Austria, and Greece. So our home campus, our mothership, if you like, is St. Louis. So the center, although we started the activity last year, it was only approved recently, the MENA Center for Peace and Development. And as I said, this was very much thanks to the efforts of Mary Velma and Renee. One of the questions that Renee asked in the previous session on gender and minorities, which was not addressed, and I'm also throwing it out to all of you, is that if you have any suggestions in terms of what we could do to help you out, or to basically provide a platform to bring people together to discuss the major pressing issues in the MENA region, so we can be of service, of benefit, please don't hesitate to contact us, to write to us. And also in terms of organizing events also. So maybe, for example, I don't know, maybe in 6 months' time, God willing, if we've put the pandemic behind us or whenever, we can have another event, maybe not an all-day forum, maybe an all-day forum, but something more modest, looking at certain aspects of healthcare in the MENA region, COVID, what have you, or other things. As I said, we had a very successful all-day forum in December on women in the MENA region, which was very well attended. We had over 150 people at the time. I think COVID, Zoom digital fatigue had not set in at that point. And then we had one on academic freedom. So if you do have any ideas in terms of guidance, support, you know, we're very modest, but you know, we aim for the stars, we aim high, we hope to make a difference. And I think also in terms of, some of you knew each other today, some of you may have met now, and through those connections that you have with one another now, maybe this can benefit your own work and all that. I also again wanted to thank John Cunliffe and Paul Critchley and Naomi Renat and Sami Gusebi for their support. I'm very thankful to my colleague, Francisco Rubio, who teaches NGO courses here, for putting me in touch with John Cunliffe and his colleagues. So we're very grateful, appreciative, and also thankful to the IOM in terms of Maria Luciana Ceretti and also Nidal Ode. And so on behalf of Webster University, on behalf of the MENA Center for Peace and Development and the International Relations Department, of which I'm a part of, I would like to extend my heartfelt and sincere thanks on behalf of all of us, Mary Velma, Renee, who are the main movers. I'm number 3. I get the bronze, or maybe Celia gets the bronze. I'm number 4. Thank you very much. And I wish you all a very pleasant evening. And please do stay in touch. We'll try to be in touch with you too. So Thank you very much. Have a good evening and Godspeed.
Thank you very much.
Thank you.
Bye.
Thank you very much, everyone.
Bye.
Thank you.
There's Celia, there she is.